2007 through the Dr. Lee Jong-uk Fellowship. We have recognized groups and individuals that have contributed to public health care by awarding the WHO Lee Jong-uk Memorial Prize for Public Health. We have also operated the Lee Jong-uk Memorial Project and the Lee Jong-uk Global Young Frontier Program to foster future healthcare leaders.
Very much concerned about the health condition of the people, and this is our response.
welcome to this event that we've been looking forward to. We've been preparing for you, and we hope that you will enjoy today, and we shall have a meaningful discussion.
Which is one of the Vision 2040 strategic areas. And in here we do exist. The first document which came out was the National Development Plan 4 Cabinet Strategic Directive.
Whatever project that we do support is based on the dialogue between ministry or between the partners and the coffee. And has been here to implement quite a number of activities with a total of about 20 million, implementing projects such as the infectious diseases, capacity building, what we call CHU project, the EMS, cancer, and IED project, and also the WASH project.
The other one, 8, is on improved maternal, adolescent, and child health. In our analysis, we have seen that
value for money, efficiency, sustainability. These three things need to be at top priority now going forward. These are the key implications for the funding cuts that we're seeing, not only in Uganda but also in the region.
So I really wish that this, coffee health forum
In Uganda, access to quality emergency care can mean the difference between life and death. To strengthen emergency medical services, the Kga Foundation for International Healthcare, KOFI, in collaboration with the Ministry of Health, launched a transformative pilot project in the districts of Masaka and Bukomansimbi.
KOFI, Korean Foundation for International Healthcare, is a public agency under the Ministry of Health and Welfare of the Republic of Korea. KOFI supports government-level health assistance to the partner countries, including Uganda, contributing and promoting international health sector cooperation and humanitarian values.
The main objective was to improve service delivery in the two districts, Masaka and Bukomansimbi, and they committed and provided about 4 million.
This collaboration started in 2017 after the Korean team interacting with our permanent secretary, and emergency medical services was identified as one of the key areas of investment.
In the partnership with KOFI, because they identified one of the biggest priorities and which they are working with us.
So the project focused mainly on 5 intervention areas, and these are leadership and governance, infrastructure development, emergency equipment, capacity building of health workers, and strengthening the referral system from community to regional levels.
One of the key pillars of this initiative was strengthening leadership and governance. Project committees were established.
We have been able to see the development of emergency care protocols.
Regional stakeholders came together to create a coordinated approach to emergency services. Leadership training was also extended internationally, with Ugandan officials receiving specialized training in South Korea. Improving infrastructure was central to the project.
Over $500,000 was invested towards the setting up of different infrastructure.
Maternity department got a new maternity ward, fully equipped, and then the neonatal care unit, which has also all the equipment desired. We are also able to get a new theater, also well equipped by the support from KOFI, and the surgical ward, to also improve quality of service delivery as far as emergency medical services are concerned. A radiology unit was established.
New regional skill and simulation labs, a call and dispatch center, and upgraded emergency units, including operating theaters, surgical wards, and neonatal units, were built to support effective care in Masaka and Butenga. Advanced emergency equipment, including 4 new ambulances, X-ray machines, and point-of-care ultrasound scanners, were introduced to ensure that health workers have the tools they need to provide life-saving interventions.
Over $500,000 towards procurement of Type B ambulances.
New operating light we are currently using during operations. Modern X-ray machine, which is in place, and on a daily basis we are able to do over 100 X-rays.
To build human capacity, health workforce training was done at the national level in the Ministry of Health, the regional level at Masaka Regional Referral Hospital, and the community level, empowering them to respond swiftly and effectively to emergencies.
The project has enabled us to train 1,700 health workers in courses ranging from advanced life support to basic life support, basic emergency care. We've also trained the regional ambulance drivers on how to deliver emergency care services.
508 VHTs were trained in CIFA, Community First Aid Responder course.
Regarding Dr. Lee Jong-wook Fellowship Program, we have sent 130 health sector government officials to South Korean institutions and hospitals for the invitational training under this program, to enhance medical human personnel capacity building by fostering experience and skills and knowledge so they can apply to their institutions when they return to Uganda.
This training opportunity has been able to train 6 doctors, 5 nurses, and a number of biomedical technicians, and also clinic officers. One of our specialist surgeon, a general surgeon, Dr. Mona, who got an opportunity to train with the Lee Jong-un Fellowship, was able to come back and won a grant that is able to implement treatment algorithms for trauma, assessment of trauma and treatment in Uganda. And this is the first of its kind that we are really proud to implement, and we look forward to implementing it in various regional referral hospitals across the country. And we hope it will be able to lead to more life-threatening conditions being treated in a timely manner, and also have trauma mortality declining.
So the word emergency medical services is interchangeably used with emergency care systems, all right? But the broader phrasing we use is an emergency care system, an ECS. So this is a system that's responsible for providing care for people that have had sudden illnesses or injuries and need emergency care, all right? So this comprises of care that is provided on the scene. So when someone gets an injury or sudden illness, that can be in the community, on the roads, in the workplace, to care that happens when you're being transported from that point to the hospital. This is care that's provided by trained professionals who work on ambulances, ultimately to care that is provided in the hospital. Okay, the acute care point or the emergency unit, as some hospitals have it termed.
To improve emergency referrals, a new call and dispatch center was established. It coordinates the emergency units with ambulance teams and community responders in real time, ensuring that patients receive timely, continuous care from the scene through transportation and the emergency department.
I think the time we had COVID-19 exemplified the function of a call and dispatch center. So when you have people that are having an emergency, they should be able to call using a number, call a system, a center that they can report what the emergency is, and that center can then dispatch an ambulance to respond to the emergency. You have someone seated behind who has a phone, who receives a phone call and understands the request and sends the appropriate response, okay? It could be a basic ambulance or an advanced ambulance, so it depends.
At the hospital, trained staff triage, resuscitate and stabilize patients before they receive definitive care.
An emergency department is a designated unit in a hospital that receives, triages into categories, how sick are you, assesses, so finds out what the problem is, resuscitates, meaning if you're not well, it resuscitates, brings you back to better, and then stabilizes people that are having emergencies.
This comprehensive system has led to a dramatic increase in emergency room attendance, with over 25,000 patients treated annually. Today, 98% of patients are triaged on time, and 100% are attended to within an hour. The Coffee Project has strengthened emergency care, reduced deaths, and saved countless lives.
Kuyamara kufentinga nengenda kumufunako enamba ya ambulance nenjikubira era tebalwawo ne bajja ne bamutwala nittukira ku emergency.
107,000 lives were saved in the greater Masaka region, and 58,000 lives were saved in the Bukomansimbi district.
There was a 50% reduction in mortality due to some of the interventions which were put in place.
Ne bamukolako ne bamuzanzaba n'atereera. Mwebale nnyo mwebalire ddala ab'ekitongole kya Coffee.
Mine would be expression of gratitude for people who don't know us to be kind enough to extend to us such help.
On behalf of the people of Bukomansimbi district, which I lead, they are so much grateful, and actually they are saying they have never seen people who have good hearts like the Koreans.
I just want to appreciate Coffee, especially the emergency medicine project, to identify the critical need and addressing it without conditions, but identifying with us our need and addressing it has been the cornerstone of the success.
This successful project, therefore, awaits being scaled up across the country.
morning once again. You're all welcome to this event that we've been looking forward to. We've been preparing for you, and we hope that you will enjoy today, and we shall have meaningful discussions in as far as the topic is concerned.
So this year, actually, I myself create 3 pillars, 3 framework. One is research, another one is e-contents, another one is health forum, Coffee Health Forum.
Coffee was founded in 2006 as a Korea Foundation for International Healthcare, and it's a government agency affiliated to the Ministry of Health in the Republic of Korea. So Coffee maintains 11 overseas offices, including the one of Uganda. We have a country office in Uganda and also in other 10 countries, making it 11 countries.
Currently, we have been able to move, and the biggest document in the country right now is the National Development Plan 4, which is one of the Vision 2040 strategic areas. And in here we do exist. The first document which came out was the National Development Plan 4 Cabinet Strategic Directive.
Whatever project that we do support is based on the dialogue between ministry or between the partners and the Coffee. And has been here to implement quite a number of activities with a total of about 20 million, implementing projects such as the infectious diseases, capacity building, what we call CHU project, the EMS, cancer, and ID project, and also the WASH project.
The other one, 8, is on improved maternal, adolescent, and child health. In our analysis, we have seen that there is a big contribution which we make in maternal health. About 60% of our interventions actually are on delay 2. In 2019, you go to an accident and emergency unit and you find yourself feeling inadequately being attended to. So this is the reason why we came up with focusing ourselves to improving these areas.
Value for money, efficiency, sustainability. These 3 things need to be at top priority now going forward. These are the key implications for the funding cuts that we're seeing, not only in Uganda but also in the region.
So I really wish that this, Coffee Health Forum will be developed into a kind of at least East African global networking, where as a knowledge generator, especially leading forums focusing on health, of course.
Good morning once again. You're all welcome to this event that we've been looking forward to. We've been preparing for you, and we hope that you will enjoy today, and we shall have meaningful discussions in as far as the topic is concerned.
So this year,
The international community has recently faced a series of crises that threaten human health brought on by continuous conflict, poverty, and disease. Moreover, there is a growing need to build understanding and consensus on healthcare support for North Korea in order to establish a healthcare community on the Korean Peninsula. To respond to such challenges at the domestic and international levels, the Kga Foundation for International Healthcare is engaged in a range of diverse and specialized healthcare projects. Kga Foundation for International Healthcare, KOFI. Creating a world where everyone, regardless of race, gender, region, or religion, has access to healthcare. KOFI was established in 2006 for the purpose of building a healthier world, free of disease, by following the footsteps of the late Dr. Lee Jong-wook, the 6th Director General of the World Health Organization. KOFI is a global healthcare organization that promotes international cooperation and humanitarianism and works to spread the value of good health around the world. As the first former aid recipient to join the OECD Development Assistance Committee, the Republic of Korea is well aware of the reality and hardships faced by developing nations. Based on this understanding, KOFI works to make the world a kinder and more warm-hearted place and ensure that everyone has a chance to enjoy a life of health and harmony. We step in to provide assistance to developing countries with poor healthcare infrastructure by supporting the medical services, medical facilities, and healthcare workers of such countries. KOFI works to build a healthcare community on the Korean Peninsula through mutual exchanges and cooperation that enhances the life, health, and future of all Koreans. To create a sense of connectedness as fellow Koreans, we have continued to focus on and provide healthcare services for overseas Koreans. Moreover, we work to ensure right to health-preventing disease of migrant workers living in Korea and stand side by side with people who need our assistance. The Dr. Lee Jong-wook Fellowship Program is an invitational training program for healthcare workers from developing nations. Since the program was launched in 2007, it has invited 840 people from 29 countries around the world to receive healthcare and medical training in Korea. KOFI honors the legacy of Dr. Lee Jong-wook, the 6th Director General of the WHO, and a man who devoted his life to improving global health. With a sense of humanity, Korea fulfills its responsibilities and duties through KOFI, bringing new hope for the world. KOFI works to ensure a better tomorrow for all by providing practical assistance rather than one-off support for developing nations. This assistance helps countries establish and operate their own healthcare systems. Based on its belief in life, hope, and coexistence, KOFI continues to work to build a sustainable future for all. Promoting global health with KOFI. The international community has recently faced a series of crises that threaten human health brought on by continuous conflict, poverty, and disease. Moreover, there is a growing need to build understanding and consensus on healthcare support for North Korea in order to establish a healthcare community on the Korean Peninsula. To respond to such challenges at the domestic and international levels, the Kga Foundation for International Healthcare is engaged in a range of diverse and specialized healthcare projects. Kga Foundation for International Healthcare, KOFI. Creating a world where everyone, regardless of race, gender, region, or religion, has access to healthcare. KOFI was established in 2006 for the purpose of building a healthier world, free of disease, by following the footsteps of the late Dr. Lee Jong-wook, the 6th Director General of the World Health Organization. KOFI is a global healthcare organization that promotes international cooperation and humanitarianism and works to spread the value of good health around the world. As the first former aid recipient to join the OECD Development Assistance Committee, the Republic of Korea is well aware of the reality and hardships faced by developing nations. Based on this understanding, Kofi works to make the world a kinder and more warm-hearted place and ensure that everyone has a chance to enjoy a life of health and harmony. We step in to provide assistance to developing countries with poor healthcare infrastructure by supporting the medical services, medical facilities, and healthcare workers of such countries. Kofi works to build a healthcare community on the Korean Peninsula through mutual exchanges and cooperation that enhances the life, health, and future of all Koreans. To create a sense of connectedness as fellow Koreans, we have continued to focus on and provide healthcare services for overseas Koreans. Moreover, we work to ensure right to health-preventing disease of migrant workers living in Korea and stand side by side with people who need our assistance. The Dr. Lee Jong-uk Fellowship Program is an invitational training program for healthcare workers from developing nations. Since the program was launched in 2007, it has invited 840 people from 29 countries around the world to receive healthcare and medical training in Korea. Kofi honors the legacy of Dr. Lee Jong-uk, the 6th Director General of the WHO, and a man who devoted his life to improving global health. With a sense of humanity, Korea fulfills its responsibilities and duties through Kofi, bringing new hope for the world. Kofi works to ensure a better tomorrow for all by providing practical assistance rather than one-off support for developing nations. This assistance helps countries establish and operate their own healthcare systems. Based on its belief in life, hope, and coexistence, Kofi continues to work to build a sustainable future for all. Promoting global health with Kofi.
Good morning. Good morning, ladies and gentlemen. This microphone is not working. Where's the other one? right. All right. Thank you. I think since we are continuing with the same event, we might not repeat the anthem and the anthems that we had yesterday, but I think every single day we need to pray. So I need a volunteer to give us a prayer as we kick off today's events. Please, it's always a pleasure to pray for others. Anyone? Come in front.
Let's humble ourselves and we pray. Father in heaven, we give you praise, we give you glory, we give you honor. We thank you for the new day. We thank you for the gift of life that you've given us and the journey mercies that you've offered to us, that we reached here safely. Father, we offer our day unto their hands. We pray that you guide us, your spirit be upon us to do that we are supposed to do and accomplish it to our expectations and to benefit the country as a whole. I thank you and I prayed in the name of our Lord Jesus Christ.
Okay, thank you so much. We're going to reintroduce ourselves because some of us were not here yesterday. And as you introduce yourself, please tell us about your best moment in coffee or Kga, and also tell us about where you work, what you're working at, and what you expect to learn from this particular event. My name is Edward Kakungulu. I work at the Uganda Cancer Institute. I'm a surgeon, and I'm glad to be here to help moderate these sessions, but also to learn a lot about EMS and the policies and how far you guys have been able to bring EMS in a very short period of time. So I'm going to start on this table and move this microphone for everyone to have an opportunity to introduce themselves.
Good morning, colleagues. Good morning. Chair, people are not here. So I'm called Nirinjimana Benjamin. I work with the National TB Reference Laboratory as a laboratory scientist. And Coffee Alumni 2017, I think we are pioneers, me, Edward, and the team. So what I have liked, I think, in previous sessions yesterday, mainly, it was health financing. It opened our eyes and away from our clinical work. What else do we do? Who is planning for us and how much is in a basket? I think mainly that's all, and I hope today and tomorrow I'll pick other good new things. Thank you.
Protocol observed. My name is Isaac Newton Okeba. I work with the National TB and Reference Laboratory. Thank you. Okay. Best moments, I know when one betters the other one, I know it will delete it. So far, I was amazed.
912 where we can call in case of any incident. I have personally watched
Morning, colleagues. I'm Kga Gerard, work at Medical Emergency as a nurse. Yesterday I was just amazed to see that coffee is still with us and is still coming with a second phase to support and strengthen us. My worst moment is about the departure time. I think, with Kampala, Kampala is full of jam. I think we can improve the time. That is all.
Good morning, colleagues. I'm Joy Nsisireki. I'm a nurse working with Mulago in medical emergency. My best moment yesterday was the in-depth about health financing, and the worst, not yet so far. I'm yet to get the worst.
Good morning, everyone. I'm Marjorie Nazua. I'm a nurse working with Butenga Health Center for Bukomansimbi at the emergency department. And I wasn't here yesterday, but I'm just thankful to coffee because it has put too much in my workplace, at my workplace. And we are having the first of the kind, having an emergency unit at the healthy center for, and that was the effort of coffee. So I just thank them.
Hello, Dr. Michael Lukoma, physician at Mulago National Referral. Yesterday, I was very impressed with the finance presentation. It was extremely practical and very eye-opening, and enabled us to think about how we can work more efficiently with the new financial landscape. Another great thing from the presentations was the fact that they were multi-sectoral. We had the WHO, we had the coffee, we had the researchers, the clinical people. So the fact that it was cross-cutting was really amazing. The only main feedback I give, as one of the organizers, I felt that sometimes we had a lot of discussion between the panelists, but then the participants in the room were not being engaged enough.
Good morning. I'm Dr. Mona Alphonse, consultant surgeon and KGA president from Masaka.
cheating us.
My best moment yesterday was on the finance aspect of the presentation. Yesterday was really good, and I have copied some things which I'm going to share in my presentation today. Thank you.
Okay. Good morning, everyone. Sarah Elaita is my name. I'm an epidemiologist. I think yesterday I was just encouraged. In the midst of the financial tensions and all that, at least one of the presenters assured us that resources are there, so we need to be calm. So that was an encouragement. Thank you.
Good morning. My name is Beatrice Orena. I'm glad to be here today, day 2. I'm thankful for yesterday that it was a success because of all of us here. My highlight yesterday was that we were able to have our main speakers come around and give us really so much insightful information on EMS, health financing, and I think most of the day everything went on well as part of the organizers. So I'm encouraged that the God who took us through yesterday is the same God today, and we'll have a blessed day. Thank you.
All protocol observed, good morning. Hashaka Alex. Like I said yesterday, my best moment being one of the organizers was seeing you guys turn up. Because we didn't sleep. We were like, are they coming? Are they not coming? So seeing you guys turn up in good numbers was a plus. And it made us go through the day with a bit of comfort that everything will be fine. The other best moment was when I went through the evaluations for the day. Majority of the things went well, the presentations, the presenters, the participant engagement, the communication before the event were all good. Mr. Kato, for the time management, we apologize and hope to improve today, and you'll set off early to beat the jam. I think that's it. Thank you.
You've tortured the video lady. You've been running away from it. All right, let's continue. Some introduction here. Some of us were not here yesterday would like to know who is in the room.
Just introduction. Good morning, everyone. Dr. Emmanuel Toyonjere, I'm a senior medical officer at the Ministry of Health. I'm here on behalf of our Commissioner, Communicable Disease Prevention and Control Department. Thank you. Oh, my best moment yesterday, I think the whole day was pretty good, but this presentation on financing was very good for us. Yeah, thank you.
Thank you so much. Thank you, everyone, for the introduction. I think, do we still need to have the feedback? Mr. Ashaka, you're still going to give us a feedback on what the assessment yesterday? You've covered it already. All right. I think we're going to dive into our first presentation. Dr. Mona is going to be giving us our first presentation. So let's listen in intently. Okay, he's still trying to sort out the presentation. Oh, there's a hand. Yes.
Yesterday, I wanted to thank the ID team for their presentation, but I had a query. They listed 4 disease areas, and my question for the ID team was, if your funder was to fund only one of those, which disease area would you pick?
All right. Do you want to answer now?
Thank you, Dr. Alkoma. I think we would go for TB because it is least funded among the diseases. Thank you.
Okay. Who was supposed to chair that session? You weren't around, eh? Who would you want to chair the session? Do you have anyone in the room?
morning, ladies and gentlemen, and welcome to day 2 of the Coffee Kga Annual Health Forum. I'm Dr. Mona Alphonse. I'm a consultant surgeon at Masaka Regional Referral Hospital and EMS fellow of the Lee Jong-wook Fellowship Program 2022-2023. And I'm here to present for you an innovative clinical protocol in the management of trauma. It is called the Uganda Trauma Assessment and Treatment Algorithm. It's a local innovation which is meant to reduce preventable trauma deaths. So why must trauma be a priority for us? As we discussed yesterday, we already saw that trauma is one of the highest conditions, or it caused the biggest burden in healthcare in Uganda. Like, for example, in 2016, over 26,000 crashes occurred, around 7,500 deaths, and over 60% of trauma deaths in Uganda are preventable. There are more people who die from trauma than HIV, malaria, and TB combined. So this shows that trauma is a very big issue that we need to handle them. And the majority of the people who die are the young ones. If you have attended the trauma emergency units, you'll see that the majority of those who die are these young people in their early productive age. So the problem keeps compounding. We are not just losing them, but we are also losing the productive aspect of them. So this significantly affects our economy as well. And for those who work in the emergency department, one trauma patient can consume everything. If you have a patient with a severe head injury, for example, you need to fix the airway, you need to fix breathing, you need to fix circulation, and the entire human resource will be consumed in this one patient. Next. Now, so what is TUTATA? TUTATA is simply the Uganda Trauma Assessment and Treatment Algorithm. It is locally developed, it is context appropriate in our setting, and its main thing is rapid trauma evaluation and treatment. It standardizes primary survey, secondary survey, and immediate life-threatening conditions. And we designed it looking at our context, our human resource, our equipment, and it is for use in regional referral hospitals, general hospitals, health center force, and you can apply some to ambulances as well. And because these other trauma protocols like advanced trauma life support, the pre-hospital trauma life support, the Korean trauma assessment and treatment, they are very expensive. And they're actually even not available here in Uganda. I myself, I trained in ATLS in 2019. It cost me, and that was on the cheaper side, $800. I also trained in pre-hospital trauma life support. The cost fee for the ATLS was $800. You forget about the cost of traveling from Uganda. At that time, it was done in Kenya. Even the pre-hospital, it cost $1,000. That is outside the other expenses that you incur to travel there. And these are very expensive for Ugandan doctors, even at a specialist level. You can imagine spending, if you are to train in both pre-hospital and the ATLS, it can cost you over $2,000. And that is more than your monthly salary. So the cost is prohibitive, and yet it is a very important course is a very important protocol that all health workers in Uganda must have. And that is why we developed the Uganda Trauma Assessment and Treatment so that it can be easily accessible to all the health workers in Uganda. Next. So, what is our vision? We want to reduce and maintain preventable trauma deaths to less than 10% by 2040. Now you would ask yourself, what are these preventable trauma deaths? Now when you look at the trauma in general, it comes in different flavors and fashions and designs. But what is more critical is that there are a few conditions or a few nature of injuries that are associated with trauma that actually kill. They kill very fast, and it is very easy to identify and to treat them. For example, airway obstruction. All you need to do to determine if there's airway obstruction is to look, to listen, and to feel. You just need your eyes, your ears, and your hands. And you will know that this patient has airway obstruction. And it is very simple to treat by simply doing a chin lift, a jaw thrust. Or you can go an extra mile to put oral airway devices like oropharyngeal airway. And sometimes, if it is in the extreme, you might need advanced airway. Same goes for C-spine fracture, a simple C-collar. It might be a bit complex, especially in the hard-to-reach areas, but there are mechanisms which we always do to ensure that the C-spine is immobilized. All these go on and on to include life-threatening injuries in the chest. For example, cardiac tamponade, tension pneumothorax. They are very easy to identify and they are very easy to treat. And our mission is 60, 6, 60. You would be wondering, what is this? Now, 66, 60, those are timelines. And it is derived from the golden hour. The first 60 is the first 60 seconds. The first 60 seconds you encounter a trauma patient. By the end of that 60 seconds, you should be able to determine whether this patient needs immediate intervention or you can delay. Is to triage the trauma patient and to determine what determine the presence of these life-threatening conditions. Now, the next 6 is the minutes. By the end of 6 minutes of your interaction with this trauma patient, you should have identified all life-threatening conditions and you should have treated all life-threatening conditions. It doesn't end there, it proceeds to the next 60 minutes, that is by the end of 1 hour. Is that this trauma patient is stabilized, resuscitated adequately, stabilized, and is ready for definite care. So, all the life-threatening conditions have been sorted, hemodynamic stability has been achieved, any hemorrhage that is there has been stopped, and now the patient is ready for definite care. We could take, for example, a patient who have blunt abdominal trauma with, for example, a ruptured spleen. When they come, you assess, look, listen, and feel, airway, breathing, circulation, disability, and you expose. Whenever you find any life-threatening condition, you have sorted it out. And by the end of 60 minutes, this patient is ready for definite care. For example, if the surgeons want to do a splenectomy, by 60 minutes, this patient is ready for that. So, our objective is to train all healthcare providers in the country in the identification and treatment of these life-threatening conditions. And specifically, we want rapid and accurate assessment of trauma victims, rapid and effective treatment of all life-threatening conditions according to priorities. priorities is very important. We want to fix airway problems before we will go ahead to fix breathing problems. And these patients are stabilized and ready for rapid transfer for definitive surgical care. Now, for example, if you are in L Center 4, you have got this patient and you are following hour 6, 66, 60. By the end of the first 60 seconds, you have triage. By the end of the 6 minutes, you have identified and treated all life-threatening conditions. And by the end of 1 hour, your patient is stable and ready for definitive care. And you know that you cannot do trauma laparotomy in your unit. After that time, the patient should be ready for transfer where such definitive care can be got. Next. Now, we developed this and we trained health workers at Masaka. And we saw that now the national preventable trauma mortality stands, we don't have latest information, but the old literature shows it to be at 60%. Now, in Masaka, it was at 32%. This difference was because there was already some intervention which was already ongoing. The Coffee EMS pilot project, it was already ongoing. And as you can see, there are small things that if you do, can actually make big changes. And this we could attribute it to that intervention. Now, when we trained our health workforce and we put them back into the emergency department, this preventable trauma mortality came down to 6%, and there was a big rise in the identification and treatment of life-threatening conditions. We trained 32 health workers, 10 were performing very well, and we selected them as TOTs. There was significant improvement in the recognition of life-threatening injuries. There was more consistent trauma management and teamwork, and this demonstrated a high feasibility and a strong clinical impact. We also trained in Mulago National Referral Hospital this year around September. 30 of those staff were trained. The staff at the emergency departments, and 10 of them were selected as TOTs. Next. So why does it work? It works because it is simple, it is clear, the steps are very clear, okay? We don't expect much. You know our human resource. Like in Masaka, I'm the only surgeon. I have 2 medical officers who cannot be on duty all the time. So in many cases, you'll find their nurses. The nurses at bachelor's level is only one who is the in charge, and the majority are diplomas. So you can imagine training these people in complex treatment protocols. So that's why we had to tone down to Tata up to the level where these low cadres clearly understand. So the steps are very clear. All you need to do is identify and treat these life-threatening conditions. That's all you need. Of course, in the care of trauma patients, there are so many things, like doing CT scan, X-rays. First of all, those tests are not available, and even if it is available, the nurse can say, okay, go for CT scan. But even if it is done, she doesn't understand, cannot appreciate. So it is not part of that Tutata. So it is tailored to common Ugandan injuries and low resource settings, and it reduces misdiagnosis and delays. It improves triage, stabilization, and referral, and it is easy to integrate with the routine emergency department workflow, and it is low cost. I told you about the pre-hospital trauma life support and the ATLS, which I trained in. But this one, the cost is less than $100 per person. Next. Now, Tutata also aligns with national EMS priorities. It supports the implementation of the EMS Policy 2023, which emphasizes the standardization of emergency care. It also in line with the EMS Strategic Plan 2023 to 2028, which is strengthening emergency department readiness and training. It is a key part of the National Emergency Care Quality Improvement, and it fits perfectly in the Vision 2040, which is to reduce avoidable deaths. And as we can see, nobody should die because there is airway obstruction. Nobody should die because he has tension pneumothorax, because you only need to identify that it is there, and you just use a needle and poke in there and finished. Next. So why do we need a national trauma algorithm? Because we don't have one at the moment, so that's why we need it. And in different units, you'll find different people using different things. So if you have one for all of us, it is going to be good. And then, like we saw yesterday, trauma is a major contributor for mortality in the emergency department, and most of these deaths are preventable, and that's why we need it. And standardization is very important for national training, quality assurance. It is easier for supervision, and you can easily report this in the DHIS2 and for referral coordination. Because it is structured, the reporting is easy, and if you have enough data, you can always keep improving on the protocol. For example, if the way we are doing it now is not the best, as we have seen from the data which we have accumulated, we can come back to the drawing board and redesign it and check it again until we have a very refined one, something which is even better than the ATLS. Next. So, the clinical framework is the assessment and treatment of life-threatening conditions, which include the primary survey, following the ABCDE, look, listen, and feel, so that we can be able to recognize those life-threatening conditions. And then immediate resuscitation, where we treat them. For example, if you get shock, you initiate the treatment for shock immediately. It also involves secondary survey and referral decision making with documentation and communication flow. Next. Now, one of the things that is very challenging, now that we have shown that this thing works, we need to make sure that it is sustainable. Now, how do we make sure it is sustainable? We need financing. And to finance it, we need government intervention. But before that, for anything to be sustainable and to live long, it should have a governance structure. And this is what we are proposing as a governance structure for Tutata. It should be owned by the Ministry of Health so that there is central coordination. Because it is owned by the Ministry of Health, it promotes decentralization to regional referral hospitals, and then from there it can go down to district hospitals, and finally to health center 4s. It will also ensure quality through technical oversight and guarantee sustainability through multi-source financing. And this actually aligns with the EMS governance architecture that we have seen or we are about to see. Next. So this is the proposed governance structure. We have a national steering committee which is responsible for policy and oversight, and this needs to be chaired by a commissioner at the Ministry of Health, and mainly the commissioner EMS, or the director of clinical services. And it could be co-chaired by an implementing partner. For example, the country director of coffee or the country director of World Health Organization. And I have members to include the key departments in the ministry itself and other partners like Seed Global, Emergency Care Society of Uganda, Red Cross, and also members from regional referral hospitals, academia, and medical associations like Uganda Medical Association or the Association of Surgeons of Uganda. And the function mainly is policy direction to approve annual plans and budgets, resource mobilization, and national accountability. Next. Then we shall have the National Technical Committee, who are mainly responsible for standards, training, and evidence. Now, these are the people who will actually foresee Tutata over time. They will develop and update the curriculum, make certain changes to see if what is currently available does not work anymore, and make changes so that the next version is better. It is also responsible for certification of TOTs. Remember, at the moment we have 20 TOTs, but then we want to have TOTs at every regional referral hospital. And this is the National Technical Committee is the one responsible to oversee that the TOTs are up to date. And they lead research and updates. Research is a very core component of Tutata because treatment, generally medical care, and especially trauma care, keep changing. If you look at the history of ATLS, things have changed a lot over time. In the previous version, they were giving 3 liters of IV fluids. The next version, it dropped down to 1, and the current version is only 500 mils of IV fluids. So things keep changing. So that is why the National Technical Committee comes in handy for research and updates of the training program over time. Next. Then we have the National Secretariat, who are responsible for coordination and implementation, organizing training logistics, monitoring and evaluation of the program, data management, and donor engagement. So the National Secretariat practically does the every day-to-day activity of the Tutata. Next. Now, like within the health system in Uganda, the way it is structured, we shall also have regional hubs at regional referral hospitals, and they will be responsible for training and supervision of lower units. For example, the Ministry of Health wants to have skills lab in all regional referral hospitals. For example, Masaka now has a very good skills lab. So it is in this skills lab that health workers in the entire region come and they are trained. And when they go back to their units, the team at the regional referral hospital can go and do support supervision in the lower units. So the regional hub is responsible for Now, we need money so that we can achieve all this. And the only sustainable source of funding is from government and through the Ministry of Health. We have already shared this with the Ministry of Health at the technical working group and at the senior management level. So we hope that the top management can bless it, and then it can be put within the government funding so that every year we are doing this training. We are also looking at partner financing. Kofi has already done a lot through the KGA project like this one. It gave us $30,000 and this is what has made us come to the point where we are. But still, they can continue to support us so that we can enroll this across the country. And we also still look at other partners like WHO, Seed Global, and any other partner who can come and support the scale up of Tutata across the country. Next. Now, we are also thinking outside the box. Yesterday we talked a lot about corporations. Somebody mentioned MTN, another one mentioned Airtel, Uganda Breweries, Nile Breweries. These are big, big, big corporations, and they also have corporate social responsibility. And if Tutata wants to reduce preventable trauma deaths from 60 to less than 10%, I'm sure they'll want to associate with us. That's why we want to organize the annual Tutata Run. So we will mobilize the community across the country with a massive media campaign on print, TV, radio, and social media. And our main goal will be to raise EMS and trauma awareness in the community. Like we saw yesterday, the EMS in the table discussion, EMS talked about raising awareness. It's a very, very important thing. If the community knows that emergency medical service or emergency conditions can actually be treated, and you can actually treat them in very simple ways, and you can actually spend very little money to treat those conditions, then they can come and support us. So we want to raise awareness. And also we can attract sponsorship from individuals and from companies who share our vision. So if we raise that money, the funds will go to support training health workers across the country and in the operations of the Secretariat. Next. So now we are calling on the ministry for a formal adoption of Tutata as Uganda's national trauma protocol and integrate this into the EMS policy implementation plan like we saw yesterday, the commissioner was talking about. And then we have an annual budget line for trauma training and quality improvement. Under quality improvement, the Tutata comes along with trauma registry. During the time when we were piloting this, we were using the emergency care form, which was developed by the WHO. And that form, there are two categories, one for trauma and the other one for non-trauma. So if we can use this and we develop a national emergency care and trauma registry, that will go a very long way to support the subsequent improvement of Tutata. So that's why the ministry need to strongly work towards having a national emergency care and trauma registry. Also, we need the ministry to come in and approve the Tutata governance structure and support our public awareness initiative, especially the Tutata Run. We are not only running to raise money, we are running to create awareness, and we are running to save lives every step of the way. Next. So for all of us, Uganda loses thousands of citizens every year from preventable trauma. Nobody should die because they have a condition which can easily be treated. Tutata is a Uganda innovation that prevents lives. And with national adoption, governance, and financing, every health worker will be empowered to save lives, and every Ugandan will benefit. So let us institutionalize Tutata, and let us save lives. Next. So this is briefly how we came about the development of Tutata. When we went for the Lee Jong-ok Fellowship Program, at the top you'll see me and Professor Lee Kang. He played a very key role in supporting us in the development of Tutata. And below are my colleagues who we were with them. And now we also got a lot of support from Coffee Uganda by giving us the initial financing. Ministry of Health through the commissioner himself, he was here yesterday, Dr. Marion, is not able to be here today, but you'll see her tomorrow, and Dr. Umo for technical support in the development of this program. We also got support from Yonsei University and Wonju Severance Christian Hospital. Next. So we have done significant. We have trained health workers in Masaka and Mulago Hospital. We have presented this at international forums at the Korea African Summit in 2024 and at the Association of Surgeons of Uganda annual scientific conference. There has been positive feedback of improved confidence on our very low cadres and faster interventions. We have also presented to the MOH Technical Working Group and senior management, and they have all blessed to Tata. Thank you very much. Maybe I can give a brief background to that video. I talked about the coffee EMS pilot project, which was implemented in Masaka. So we, under guidance from Mr. Jong, who was here yesterday, we created this documentary. We are going to show you this one for 5 minutes. There's a 10-minute version and a 20-minute version. And it is mainly to create awareness in the public, but also to show that intervention, however small it is in emergency care, it will go a long way to improve, prevent deaths and save more lives. Thank you.
Access to quality emergency care can mean the difference between life and death. To strengthen emergency medical services, the Korea Foundation for International Healthcare, KOFI, in collaboration with the Ministry of Health, launched a transformative pilot project in the districts of Masaka and Bukoman-Simbi.
KOFI, Korean Foundation for International Healthcare, is a public agency under the Ministry of Health and Welfare of the Republic of Korea. KOFI supports government-level health assistance to the partner countries, including Uganda.
So the project focused mainly on 5 intervention areas, and these are leadership and governance, infrastructure development, emergency equipment, capacity building of health workers, and strengthening the referral system from community to regional levels.
One of the key pillars of this initiative was strengthening leadership and governance. Project committees were established.
We have been able to see the development of emergency care protocols.
Regional stakeholders came together to create a coordinated approach to emergency services. Leadership training was also extended internationally, with Ugandan officials receiving specialized training in South Korea. Improving infrastructure was central to the project.
Maternity department got a new maternity ward.
New regional skill and simulation labs, a call and dispatch center, and upgraded emergency units, including operating theaters, surgical wards, and neonatal units, were built to support effective care in Masaka and Butenga. Advanced emergency equipment, including 4 new ambulances, X-ray machines, and point-of-care ultrasound scanners, were introduced to ensure that health workers have the tools they need to provide life-saving interventions.
New operating light we are currently using during operations. Modern X-ray machine, which is in place, and on a daily basis we are able to do over 100 X-rays.
To build human capacity, health workforce training was done at the national level in the Ministry of Health, the regional level at Masaka Regional Referral Hospital, and the community level, empowering them to respond swiftly and effectively to emergencies.
The project has enabled us to train 1,700 health workers in courses ranging from advanced life support to basic life support, basic emergency care. We've also trained the regional ambulance drivers on how to deliver emergency care services.
508 VHTs were trained in CIFA, Community First Aid Responder course.
So this is a system that's responsible for providing care for people that have had sudden illnesses or injuries and need emergency care. All right, so this comprises of care that is provided on the scene. So when someone gets an injury or sudden illness, that can be in the community, on the road, in the workplace, to care that happens when you're being transported from that point to the hospital. This is care that's provided by trained professionals who work on ambulances, ultimately to care that is provided in the hospital, okay, the acute care point or the emergency unit, as some hospitals have it termed.
To improve emergency referrals, a new call and dispatch center was established. It coordinates the emergency units with ambulance teams and community responders in real time, ensuring that patients receive timely, continuous care from the scene through transportation and the emergency department. At the hospital, trained staff triage, resuscitate and stabilize patients before they receive definitive care. This comprehensive system has led to a dramatic increase in emergency room attendance, with over 25,000 patients treated annually. Today, 98% of patients are triaged on time, and 100% are attended to within an hour. The Coffee Project has strengthened emergency care, reduced deaths, and saved countless lives.
Kuyamara kufentinga nengenda kumufunako enamba ya ambulance nenjikubira era tebalwawo ne bajja ne bamutwala nittukira ku emergency.
107,000 lives were saved in the greater Masaka region.
There was a 50% reduction in mortality.
Ne bamukolako ne bamuzanzaba n'atereera. Mwebale nnyo mwebalire ddala ab'ekitongole kya Coffee.
Mine would be expression of gratitude.
They are so much grateful. We have never seen people who have good hearts like the Koreans.
I just want to appreciate Coffee, especially the emergency medicine project, to identify the critical need and addressing it without conditions, without, but identifying with us our need and addressing it has been the cornerstone of the success.
This successful project, therefore, awaits being scaled up across the country.
Thank you so much. Let's give Dr. Omona and the team a big hand clap. Dr. Omona Drew. Yes, thank you so much. So let's park our questions for him. We're going to have a session for Q&A. I invite Dr. Oumo to also talk to us. You are welcome.
Good morning. My name is Dr. Joseph Oumo. I work with Minister of Health, Emergency Medical Services. My task here is simple. It's to deliver a speech on behalf of Commissioner Health Services, Emergency Medical Services, Dr. John Baptist Wanyaye Nambohe, who is not able to be with us today. I'll read the speech as provided. Kindly listen into. So, keynote address titled Building a Resilient National Emergency Medical Services for Uganda. Esteemed development partners, distinguished guests, colleagues, ladies and gentlemen, good morning. We're here today to confront a simple, stark truth. In Uganda, whether a person lives or dies during a medical emergency still depends too much on chance. Our mission is to replace chance with a system, a resilient national emergency medical services that leaves no one behind. The golden hour, a global and local imperative. The burden we carry is not ours alone. Globally, injuries, especially from road traffic accidents, are the leading cause of emergency care demand. This mirrors our reality, where trauma claims lives not because it is untreatable, but because our response systems are fragmented. Evidence shows that a critical portion of this death occur in the first 60 minutes, the golden hour. This is not a medical mystery. It is a systemic one. When seconds determine survival, the strength of our system chain determines the fate of our citizens. We're not just building ambulances and units, we are fighting for minutes that save lives. Our progress is validated by the frameworks, especially the WHO Emergency Care Framework. Over the past 5 years, we have laid foundational pillars: a national policy, strategic plan, and the pioneering massacre pilot. Our direction is correct and is validated by global consensus on the 7 priority areas of emergency medical services development. We are actively working on the core pillars they identify: governance and legal framework through our passage of the EMS Act, education and training through our standardized programs for all emergency care professionals in the country, infrastructure, communication, and transport through our dispatch and our ambulance standardization work. However, we must also confront our gaps with the same honesty that defines our clinical practice. We operate in a global context of a projected shortfall of 10 million health workers by 2030, which amplifies our own staffing and retention challenges. Our dependence on external funding exposes a vulnerability we must address with urgency. What is the innovation owned and made in Uganda? The path forward is not merely to import solutions, but to innovate and own them. Our homegrown Uganda trauma assessment and treatment algorithm, TUTATA, is a proof of what is possible. Developed here, tested here, and it is dramatically reduced trauma mortality. It is a shining example of contextual innovation that global experts call for. This is the model for our future, leveraging technology not for its own sake, but for our context. While globally AI is optimizing ambulance routes and virtual reality is transforming training, our first step is to institutionalize what we have proven works. TUTATA must become the standard in every emergency unit for every ambulance team. Our capacity for excellence is not theoretical. Just this year, when the nation faced a public health emergency, our national emergency medical team was deployed within hours. This team, a product of sustained investment and partnership, achieved 100% survival rate in the isolation unit. This is what functional, ready, and trained emergency response looks like. This is standard for our entire nation. The blueprint for a national system. Our next phase is clear, ambitious, and achievable. We will. Number one, we shall operationalize a national dispatch system, integrating tracking and communication to close the deadly gaps in our referral pathways. We shall institutionalize training, making TUTATA an essential emergency care core competencies for every healthcare worker. Strengthen every emergency unit to ensure readiness, triage, resuscitation capabilities. Pursue sustainable financing, exploring innovative models, and public-private partnerships to build a system that endures. Enact the EMS bill to provide legal bedrock for standards, accountability, and protection. Deepen multi-sectoral collaboration with police, fire, Red Cross, local governments, and private sector, because EMS cannot succeed in isolation. A call to collective action. Therefore, my appeal to all partners is this. Align with our national strategic plan. Let's invest together in ambulance systems, unit readiness, and training infrastructure that builds permanent workforce. Scale what works. Let's roll out TUTATA nationwide and support the data systems that measure our impact and guide our improvement. Build on our resilience. Let's channel the same urgency and collaboration that powered our national EMT response into building our everyday EMS system. To us, esteemed colleagues who are here, your leadership, innovation, and ownership are essential. We cannot build a system, we cannot build this without you. In conclusion, the Uganda we build together. Colleagues, we have a vision within our reach. A Uganda where ambulance is linked to command center. Every emergency unit is a place of refuge. Every health worker is confident. And every system knows help is coming. Uganda where no one dies from preventable emergency. This is not a dream. It is a project plan. Our mission transcends policy. It is moral commitment to safeguard our people. Let's be architects of that system. Let's build with urgency, scale with purpose, and resource with determination. Let's deliver together for Uganda. That is the speech from the Commissioner. Thank you so much.
Thank you so much. The hand clap is not loud and clear. Thank you so much, Dr. Joseph, for that, and we are happy that you are committed to enrolling to TATA. So, ladies and gentlemen, allow me to invite Dr. Omona again on stage for QA session. Thank you. So, I think we all got the presentation, and personally I would like to thank the TUTATA team for the efforts. And one of the things that I like is community training. You know, we have seen highways where accidents are happening and there is no help. We will only wait for help from professional workers. So if we train more and more of these community people, we shall score and we shall reduce on preventable trauma death. Also having toll centers. How I wish we can scale this and it goes to all highways, like in every after maybe 2 kilometers or even less. So that if Benjamin is there, a bus has crashed, something accident has happened, I'm able to call a professional health worker on top of my community people. So this is something that we have to move. On vision, I see that we need to reduce reduce it by 10% in 2040. Don't you think it's better for us in TB, HIV, we are saying by 2030, we must end HIV. I don't know how we are going to do it, but all efforts are in place to have this achieved. How about we reduce preventable trauma deaths to 5% or 2%? Then the other thing is, how do you feel as a surgeon when you request for a CT scan, any other laboratory test, and it's not done? When it's not done, you cannot do a clear diagnosis. Do you think government has done more? Can we improve to have all these other tests done? Thank you so much. We shall take other questions and he will guide us after. Thank you.
Thank you, Dr. Mona, and I love the innovation. It's quite good. I just want to say that you need to raise more awareness about it. I work in the ministry. I am a specialist. I'm a physician. And I know most of my colleagues, just like me, are not aware about TUTAT. Yeah, so let's raise more awareness. But also, I want to encourage you to fast track the approvals. If you want it to be scaled up county-wide, definitely it has to go through the approvals. I'm happy it has gone to senior management. You should track it so that it goes to top management as well. In your opening statement, you said trauma causes more death than TB, HIV, and malaria combined. I don't think it's a right statement. I just looked at the data you presented. Unfortunately, you presented very old data, 2016, where about 7,000 people died due to crashes. I don't know what the picture right now is, or even last year, but looking at our data from TB alone, we lose about 28 people per day to TB. Now, 28 people is a whole, it's actually 2 taxis, 2 Kamunyes of people dying every day. When you look at HIV itself, last year we lost about 20,000 people. So the numbers being killed by infectious diseases are much, much more. compared to trauma. Thank you.
Thank you, Emmanuel.
Thank you, Dr. Mana, for the good presentation. And I'm impressed with the innovation because, as you clearly said, really, the foreign courses are very, very expensive for majority of the Ugandans. And now if you compare, if they are very hard for consultants, what about an enrolled nurse who wants to acquire skills? So it's very important that we have this roaring, and it's very good. So my question was on the approach. I think it focuses on ABCDE assessment, which is very, very vital. I was just wondering about the concept of CABCDE, mostly for pre-hospital training, because most of these catastrophic bleedings, mostly by the time they reach in the hospital, they have already been arrested by the pre-hospital providers. So I think it's important that we also include the component of CABCD, mostly when we are training the ambulance teams and the other community members. Thank you.
Thank you so much. Any other question? Yes.
Thank you very much, Dr. Omono, for the wonderful work you're doing. For me, my specific question, based on what you have shared, I did not see a lot around the strategy and the governance structure, something around the community health workers, the VHTs, and the role of the bystander. You shared a very nice mission, 60 seconds, 6 minutes, 60 minutes. So I am not so sure what your success rate has been for the real life cases you've had in some of the work you've done. It would be nice to hear maybe what has been the role of the bystander, what have the CHUs done, and then by the time they get to the facility, what has been the success rate, and can this probably be scaled? I've seen in the strategy there is little information around the community health workers, though I've seen something about awareness and maybe the role they play. Maybe you can highlight a thing or two around there. Thank you.
Interesting. Thank you.
Good morning, Dr. Mona. Thank you for that excellent presentation. I have a question about the components of Tutata. Please kindly list that for us, because you have a room of technical people. Because the reason we need to know these components, is it blood pressure, is it the level of consciousness, what else is being measured in that Tutata? It's very important in terms of determining what monitoring equipment. You said the assessment tool is simple. So what does that simple mean? How simple is it? Is it only a BP machine needed? Is it only the scales to do a Glasgow scale? We actually need to know what components are in, because for this team to support you and advocate for you, it's very important to know what are the key components. If there are 4 key components, please list those for us, because the presentation was missing that. Then the next issue, I saw in your steering committee, there are 2 concerns. The steering committee, I would suggest that it has a few more technical people, like someone who's a resuscitation specialist, like an emergency physician, or a trauma surgeon, or a trauma nurse. Because if you take from models about what's being done in other countries like UK and Europe, those resuscitation councils are so key for guiding policy. So yes, it's important to have the Ministry of Health people, but they need the technical team to be involved with them, separate from the other technical committee that you mentioned. That steering committee needs technical people, more technical people. The governance and the political officers are important, but the technical team also needs to be part of it.
Thank you so much, Doctor. Yes, Joseph.
Yes, thank you so much. Just a few additions. The alignment to the strategic documents. The policy is not 2023, rather 2021. Commissioner mentioned it earlier on, rather yesterday. And also the strategic plan. He mentioned that it was expiring this year, so they have just added one more year. So it is 2020/21 to 2024/25, not as mentioned. The colleagues have talked about the validation. It's quite key. You've taken it through the approval processes. Next part is probably peer review and further guidance by your peers. Thank you.
Thank you. Any other? We need him to clarify or answer to go, and then we go for break tea. Okay, thank you so much for your questions. But maybe lastly from me, I saw something on internet with Africa Health. Is it a publication or it's just a write-up? Then I have not seen much of our videos. They are very interesting. I've not seen that documentary online on any search engine. So maybe to our communication specialists, we may think of uploading these important videos. Thank you. So over to you, Doctor.
Thank you so much. Now, there were two things, the Tutata presentation and then the EMS pilot project documentary video. And I think maybe we were trying to mix the two, but because I was deeply involved in both of them, I can still respond. I will start with the first one, the vision reducing preventable trauma deaths to less than 10% by 2040. Why not 5 and why not 2? Globally, most countries do agree with having it around less than 10%. It is feasible. There are very few countries that do have theirs below 10%, and these include Korea, Japan, and some other Asian countries. Europe actually has theirs above 10%, same with the US. So I felt as a developing country, maybe we can do with the less than 10%. And then it is not very easy to lead this to go down to 10%. It involves a lot of things. And some of it may, because Tutata is just one small aspect of the bigger picture. Now, this also goes to other concerns surrounding VHTs, community health workers. Now, Tutata is designed for care in the emergency department. It might be difficult for the VHTs and the community extension workers to adapt this one. However, they actually have another course called the Community First Aid Responder course. And trainings have been done in the Masaka region, also supported by Kofi, although it's not yet done across the country. So the bystanders would benefit from the Community First Aid Responders course because they are the ones near there, the borders. They are the ones who are nearest to the point where the accident occurs, so they would benefit from that. Now, the issue of CT scan, maybe X-rays, and with the lack of those in as far as making a diagnosis is concerned. Now, remember, I think the government has done a lot to ensure that there are CT scans across regional referral hospitals. And these are very powerful tools in making diagnosis. Now, in developed countries, like in Japan, in their resuscitation room, they have a CT scan. Korea does not. Now, remember, these are highly developed countries, which means that the utility of these instruments in the emergency room is is a bit challenging to have in place. However, for us, we can adapt, and that's what we have trained our health workers on, is the use of point-of-care ultrasound scan. When you do the Tutata course, you will learn how to do point-of-care ultrasound scan, especially in doing eFast, FAST and eFast. Because these are very, very powerful tool and very easy to use and very quick in the diagnosis of these life-threatening conditions. Now, you should create a big line between abdominal ultrasound scan and then focus abdominal scan for trauma. They have different things. So the FAST and eFAST, all health workers can actually be in position to do it and be able to tell whether it is positive or it is negative. And this is very different from abdominal ultrasound scan. And in those units where they have point-of-care ultrasound scan, the rate of diagnosis of the life-threatening conditions increases, and then also the time spent to make those diagnoses is very short. So with the point-of-care ultrasound scan, you can tell if there is intra-abdominal bleeding, you can tell if there is massive hemothorax, you can tell if there is tension pneumothorax, and you can tell if there is a pericardial effusion, pericardial hemorrhage. And these are conditions that if you don't treat them within the shortest possible time, you are going to lose this patient. So yes, CT scan is important, but not so much in our setting in the emergency department. Besides, if you have done a CT scan, let's say you are in Masaka and you find that this patient has epidural hematoma, you will still have to refer this patient. And a patient who has epidural hematoma is highly likely that is very sick, that will need neurosurgical and ICU care, which we don't have in most regional referral hospitals. So still, you can still refer this patient with or without the CT scan. Raise more awareness. This is very important, not only in trauma, but in the overall emergency care. Emergency care, like if you have interacted with many health workers, the only thing that they know as emergency is a woman who is going to give birth. And that's why in yesterday's discussion you heard that ambulances are reserved for pregnant women. And I think this is so because when you look at the history of healthcare in Uganda, actual ambulances started coming in around 2017 when the EMS department was established, or maybe slightly a few years earlier with the issues of the ambulances. If you remember, maybe 10, 20 years ago, we used to use this double cabin as ambulances. Now, but during those times, there was already emergency obstetrics care, which has already, the training has already started. Now, compare this to emergency physicians whose training has just started recently. So the bulk of the health workers actually don't know what emergency care is. I would love if you looked at our video in, I think in the 20 minutes, how the medical officer at Butenga Health Center 4 was talking about emergency. That for them, they didn't know that if you get a cardiac arrest, you are an emergency. Those ones, no. And that's, on those days, nobody would think that this is an emergency. The only thing they knew was like a woman who is delivering, put in the ambulance and take. And these are real, real stories that are happening. So it is very important for awareness to happen first with us, the health workers, and then also more importantly with the community. We have worked with the EMS department, and as you have heard, we still continue to have this approval done, and we shall do all our best to ensure that the approval is done. The ATLS, yes, it is expensive, You ask about the assessment, ABCDE versus CABCDE. Now, if you have trained in advanced cardiac life support, I think they were the first to start the CABCDE, okay? And then if you have looked at the different versions of pre-hospital life support, the pre-hospital, they start also with CABCDA. Now, the C in ACLS and PHTA, pre-hospital trauma life support, is a bit different. In the ACLS is more of cardiac compression, and then in the pre-hospital trauma life support, it is catastrophic external bleeding. Now, it is only of recent that the advanced trauma life support has adapted the management of catastrophic external bleeding. They have just done it in this latest version, which came around maybe like 4 months ago. That's when they have adapted that. But in all the previous versions, they were sticking with the ABCDE. And this underscore and family shows that when you have a cause like ATLS, ACLS, and TUTATA, it is very important to have a registry alongside it so that you can always monitor what happens, so that you can, if there are some gaps, you come and refine the training. And this is what has been happening with these major courses over time. And that is where we want TUTATA to also be. We are starting now, and then we want to grow as time goes by. But we want to grow within our own setting. You never know in the future, TUTATA might meet up with the ATLS, because all this goes together hand in hand with the overall development of the country. In developed world, they do their things a little bit differently, but also us in developing countries, we also do our things a little differently to match what we have. The governance structure, which does not look at VHTs and community extension workers. Like I said, this is mainly designed for clinical team at the emergency department. And all these, the governance structure, like I've put, it's a proposal. It's not fixed on stone. So it is really open to discussion and appropriate changes. If we think we need a resuscitation physician, we will do so. And now remember, these are quite advanced things. Okay? When I was in Korea, the emergency department is divided into 3 categories. There's trauma, there's resuscitation, and then there's toxicology. I am not sure if we have this in Uganda. Maybe the team in Mulago Hospital can tell us if they have it divided into those categories. So however much we want some group of people to be there, they must first be there, and then we can add them. But if they are not there, we can use what we have, and then as time goes by, they can be incorporated. Yeah, we published it in the Africa Health publication. We would be very happy if we could upload this documentary formally on the Ministry of Health website or any other platform. And Ministry of Health, actually, Emergency Department aired this documentary on UBC. I think it was that week of Emergency Medical Service Week. It was aired on UBC. But I think if it can reach out there on social media, it will be very important. Thank you very much.
Thank you so much. A big hand clap. That one is small. Thank you. Yes, to our colleagues who have just joined us, you have missed a very great presentation. But the good news is Dr. Omona is seated behind there, and he's with us today and tomorrow. So for the good work I have done, allow me to have a photo with our president. And then later on, you will join us. Thank you. Cameramen and women. No, I cannot live without a photo with the president. And Beatrice is coming and she has a phone, not a SIM. Okay, thank you. So before he goes, allow me to invite Commissioner EMS and also Commissioner NCD, plus any other person who is interested to have a group photo. You are still there. Okay, so, yes, Emma, all coffee staff, and sir, you have just joined us and you are very smart, please. Okay. I need the ladies in this photo. Join, if you don't mind. Are you okay with the joining? Okay. All right, more joining. Please, let's join. Let's join, let's join. It's a photo that you can take to the bank and say, I was with KGA president. They approve your loan immediately. Okay. Huh? We are set. Huh? All of us. Okay. Okay, thank you so much. And after this, I invite all of us for a group photo. We need to update our social media, WhatsApp status, showing the public that today we are turning health challenges into opportunities for change. Please, I welcome all of us for a group photo. Thank you.
Good morning, everyone. I can still hear colleagues in the the dining. Can everyone come back to this session? I can still hear people in the dining. Please come and have your seats. Ladies and gentlemen, guests, colleagues, and partners, my name is Dr. Chile Justus. I work at Mulago National Referral Hospital, and I'm delighted to take you through this EMS panel. And I hope it's going to be insightful and very important for changing the face of EMS in Uganda. I have well-known presenters with wide knowledge in EMS, and I'll be happy to hear from them. I'll start with Mary Erin Ryons. She's global EMS physician. She's based in USA. She's been in Uganda for many years. I have known her personally. Personally, she has also mentored me. She's been in Mulago for some time. She's a global health researcher and an educator. She's also heading a program called Yale Program. She's a former SEED global educator with Makerere Emergency Medicine Residence Program. She's also familiar with Uganda EMS program and systems in USA regarding to EMS. She has vast amount of knowledge and experience as regards to EMS. She's going to open her discussion, and it's going to be online, and allow me to welcome her with a hands of applause. Thank you so much. You are welcome, Dr. Mary Erin.
Hello, can you hear me? Hello, are you able to hear me? Hello, are you able to hear me? Hello, everyone. Are you able to hear me? Okay, wonderful. Sorry for the hiccup. Hello, everyone. Thank you for the kind introduction. I certainly wish I could be there with you in person. As mentioned, I'm an emergency medicine physician, but I went a step further and did a fellowship in global emergency medicine and international health. So I sort of subspecialized in global health, and so was asked today to sort of share a bit about that. I'm often asked what that means, what it means, international health or global emergency medicine, since it is certainly true that emergency care always takes place in a local context, right? Our patients appear in a particular place at a particular time, and both the provider and the patient are there in that local context. But it is also true that there are challenges that some do, some don't, but there are some challenges that go across the board that have been found to be almost universal. And because of that, there are some, I think, tools and perhaps solutions that we can share without having for each country, each hospital, each provider to have to reinvent the wheel each time. So I wanted to just mention a few of those today while we're digging deeper into the Ugandan context otherwise. And I wanted to start by sharing where I am. I'm in Tennessee right now in the United States. I grew up here, and very close to where I am, not many kilometers at all, is this community up in the Appalachian Mountains. It's a very, very poor community, has been for many, many generations. It's difficult to access. You can kind of get some idea of that. There are mountain roads that, particularly in the winter, are very, very difficult to access. And someone at one point had thought, hopefully, to perhaps be able to access by helicopter. But the community was served by the Williamson Memorial Hospital, which unfortunately closed due to funding reasons during COVID, and leaving this community without health care within, it's over 100 kilometers just to get the most basic care. And so the community has banded together, and there's a sort of a loose network of neighbors helping neighbors, where just community members on their own initiative, as working as volunteers, are working to get the most vulnerable members of the community to the health care they need as able. They're doing it on their own time, often in their own vehicles, trying to meet the challenge that is made by this lack of local care. So I just wanted to, to emphasize the fact that a lot of the challenges that we talk about are everywhere. I've never worked anywhere that didn't struggle to bring quality emergency care to its most vulnerable patients. So I think that remembering that it is actually a global challenge, we can maybe start to think about what some of the tools are that we can draw on across the board. And we've been talking, and we'll continue to talk during this conference, about these three sort of bucket areas of policy, of service delivery, the actual hands-on care, and then training. And I, just because of my own personal experience and bias, will spend most time on the last two. But I will say about the policy that emergency care in general got such a huge boost at the World Health Assembly, 72.16, which was the first time that the World Health Assembly had acknowledged that emergency care specifically is an essential part of universal health coverage, that there is no such thing as a comprehensive healthcare system that doesn't include emergency care for the acutely ill and injured. And Uganda itself, in drafting its National Emergency Department design and standards, has defined that care as an integrated platform for that acute illness injury. And very importantly, right across the life course, it is a cradle to grave specialty, where from the moment of conception through your final breath, emergency medicine is there and is quite, unique in that sense, but it also brings particular challenges, right? This won't be the first time you've seen this, and it won't even be the last time you see it for this conference, I'm sure. But I put it there just to give, again, some idea of the breadth of the challenge, right? Where looking where we have the care that begins at the scene, and that's whether the scene is the side of the northern bypass or someone's bedroom. The care begins there. They need to then get transported to some sort of emergency care unit. There needs to be that handover and the providers and before they then transition to either a transfer to another facility or a transfer to another ward. And I think the last piece I would say about the policy is just how important I think it is that emergency care be seen as its own priority, its own integrated sort of standalone priority, because it is sort of unique within the healthcare system in having all of these challenges, and trying to sort of piece it together piecemeal, I think, can make it very difficult to address a lot of the challenges that we have. I think one of the ways I think that global emergency care can be most useful in terms of service delivery is in some of the tools that are offered. And two of the big ones are the triage tools, which there's really, I think you could argue there's no more important function within emergency care than the accurate triage of patients, deciding who's the sickest and who needs to be seen first and what needs to happen first. And then there's also the medical and trauma checklists. And one thing that we really emphasized in the last few years when I was there in Uganda is moving to the importance of triage and sort of an integrated triage, where we have thought in the past about a medical system versus a surgical or a casualty system. But the fact is, when this young lady presents with an abdominal pain, I have no idea. I mean, I've been doing this for years. I have no idea if she's medical or surgical. She could have gastroenteritis, she could have a paracetamol overdose, but she could also have appendicitis, right, or an ectopic pregnancy. And so trying to decide immediately whether she goes to medical or surgical is not going to be possible without really an effective triage system, and then getting her to the providers who can handle that presentation across the board. So getting our hands on the patients right away and determining what needs to happen is part of the triage. And I think Uganda, this is one of our wins, I think has done an amazing job of taking that, like for instance, the WHO, the Interagency Integrated Tool, and translating it into the Ugandan context, right? So there is now the Ugandan triage tool, both for adults and pediatrics, which has been developed for some time now. I think one of the challenges becomes, though, getting this tool into the hands of those who can use it and making it an effective thing. We need to be able to get the tool to the people who will use it. We need to have the dedicated personnel to do it, and then to have it available in a form where they can use. And similarly, in our emergency departments are the medical and the trauma care checklists. This refers to one of my favorite anecdotes. Modern checklists sort of derive from the airline industry, where they have all kinds of checklists. And in a single engine plane, the checklist for when the engine fails, if you open that checklist, the first item says, fly the plane, right? It is like, you would think you wouldn't need to tell a pilot to fly the plane, but that is what can happen when you are overwhelmed, when you're in an emergency situation, when you're tired, when you're panicked. You can forget the most obvious things that you wouldn't forget at rest on a Tuesday afternoon. And so the airline industry has learned that if an engine goes out in a plane, the first thing you need to remind the pilot is to keep flying the plane. Yes, check the instruments, yes, try this, yes, try that, but fly the plane. And I mention that only because there can be a lot of resistance to checklists. Feeling like, oh, I already know all of that. I know all of these things also, but the point of a checklist is that you are not asked to remember them. After every medical patient, you just go through the checklist just to make sure you have it mentioned. After the primary and secondary surveys, you go through the trauma, and then right before you leave the patient, you check those things. And it's just a way of remembering that after you've seen 50 asthma patients, then instead of just grabbing the salbutamol and moving on, to remember that that wheeze could be anaphylaxis, right? So these checklists can be very important, but again, like the triage tool, it's so important that they be used appropriately. And I was part of a World Bank project in the Palestine, introducing and training on the triage tool and the checklists, and I put one of those pictures there because while having the checklist over that care bed there is very handy, it's printed big enough, the providers can see it, but having the triage tool there over the bed is not helpful, right? That triage tool needs to be printed out somewhere where on a desk where the first person who comes into contact with the patient can see it. So I love these triage tools, and especially the checklist, because they can be immediately scalable, right? You can print out the checklist, laminate it, and just have them available as someone comes on shift. You can stick it in your back pocket and just be sure that every patient gets the medical or the trauma checklist before moving on. It's not the tool already exists. It doesn't need any further work, and it's scalable for very little funding. So I think both the triage and the medical trauma checklist are examples of tools that we can borrow from the global community and put into action with a little further thought and care to how best to actually implement them. Yeah. The other thing about training, I wanted to include this slide because I actually made this slide years ago when I very first got to Uganda. And the exciting thing is that the people, the students in this these photos have now finished their programs. They're all practicing emergency medicine trained doctors out there out in the world. One of the challenges, however, is that almost none of them are working in emergency care units in Uganda. And on the reverse related side, almost none of our emergency care units have emergency medicine trained doctors working there or running them. So I think this is an example of where the challenge, I think, is to match our existing resources with what we have. We have regional referral hospitals. Many of them have a dedicated space for an emergency care unit. Some don't, some do. But we have these young doctors eager to get out there with the training to help design emergency departments, to help run them, and to provide emergency care. And we have not yet been able to get these young doctors into a place where we can, as a country, best start to take care of this training that they've had. And just to leave you with one, I think, excellent example of this, at the Katakwi District Hospital, one of the Imbarara trained physicians, Dr. Joseph Imran, is the hospital director up there. It's a district hospital, not even at the level of service of a regional referral hospital. But he went back to that area and has developed an emergency care unit there. He had this building that was being underutilized, and with very little work, he was able to turn it into a small emergency care unit. They now have 24-hour triage there. He has an emergency response team that responds to an emergency anywhere in the thing. And one of the first things that he did when he got there, and I think this comes from his training as a specialist, on every ward, the men's ward, the women's ward, the labor ward, he designated the acute care area. He set aside a bed for the sickest patient and made sure that all of the available resources were there near that bed. So as soon as you walk into the men's ward, you can glance in the corner and know if there's an unstable patient or not. You can know who the sickest patient is. And if you're taking care of that patient, you can be sure that whatever is available is within a hand's reach. So he didn't go in there and get all new funding, all new equipment. He took what was there, and because of his specialty training, was able to rearrange the existing resources in a way that has brought a really great improved level of care to patients who destabilize on the wards or who present acutely ill and injured for emergency care. And this is just a picture of the emergency unit and one of the emergency response bags that they use when they do that. And my final thought on that, again, is this is from Dr. Emeron saying that, you know, he had offers to go to other settings, but he chose to go back to Catequay, and I think that's partially because he started there. That's his home district. And I wonder if that isn't one of the things that we can think about moving forward, is as we're trying to match our well-trained young doctors, and we've got emergency nursing programs coming online, is to get them decentralized, get them out across the country, probably initially into the regional referral hospitals and eventually, hopefully, into all of our district hospitals, to try to get them out so that they can begin to take advantage of the resources that are already there, and we can support them as young doctors and leaders of these units. But I wonder if one of the ways to begin to do that going forward is to reach out into these various units and recruit from those areas, recruit even existing MOs in the regional referral hospitals, and perhaps then to support them with scholarships throughout their training, with the idea that they will then return to their individual districts and begin to share their expertise with the patients there. Because again, we have these wonderful training going on. We're turning out every year more and more emergency medicine doctors, and we'll soon have equally well-trained emergency care nurses. And I think the challenge is going to be to get them out of the capital city, get them out of Mbarara, even Gulu as that comes on board, and get them out to the rest of the country. And it's, you know, it's a big problem. It's not an easy fix. But I think it's one of the ways we can really begin to take advantage of the resources we already have and let each emergency care unit within the regional referral hospital become a nidus for care. That can become the center of excellence for care in that area, so that our pre-hospital can operate in and out of there. Our emergency care can as well. And then as we begin to strengthen our referral units and we have each of the emergency care units within the regional referral hospitals acting as that, you know, center of excellence for emergency care based on the training of our doctors and ideally of dedicated nurses to the emergency unit. That's about all I had to share today. Just a few thoughts both on what we can grab from the global community, on some of the things that we're doing, I think, so well in Uganda. We have such an incredibly vital emergency care community. The pre-hospital community is one of the most, you know, dedicated and exciting I've ever seen. And I think finding a way to tap into that and to begin to take advantage of both the human resources we have and the material resources we have. I'd like to see us perhaps start to focus around these emergency care units in the various regional referral hospitals and see if we can't get that training and some of the focus into those units. I'm happy to address any questions or concerns, or perhaps I'll stay with you certainly throughout the day and happy to join at any time. Thank you.
Thank you so much, Mary. That hand clap is for you. I hope you've got it. Thank you so much again for the insights that you've given us, and it gives us a clear picture of the burden or the things we are working with, or we are dealing with as regards to emergency medical services in Uganda. And so let's build on that by looking at impact of COFI's Phase 1 EMS project. We'll get to know the lessons learned and best practices. This is going to be led by Mr. Pritchard Kavuma. He's a well-skilled gentleman with a lot of experience in project management at Coffee, Uganda for over many years. Allow me welcome Mr. Pritchard Kavuma with a hand clap.
Thank you, Dr. Justice. Good morning, everyone. My name is Pritchard Kavuma. I work as a senior project manager with Coffee Uganda office. And I'm pleased to be here today and share with you the impact of our first phase EMS project. But before I start, I would be remiss if I didn't acknowledge 5 people in this room with whom we delivered this project. At ministry, we had our champion at the far front, that was Miss Maria Nkalubo and Dr. Oumo Joseph. Then we also had Mr. Denise Nabimanya. Then I have my colleague Simon, who I worked with directly in the implementation of this project, so I acknowledge your support. So my presentation is going to have an overview, the major investments, indicator performance. I will talk about issues and mitigations, major successes. I'll conclude and I'll conclude and make recommendations. So we implemented the first phase of the EMS project for a period of 6 years, and the target area was Ministry of Health, Kampala, then we were in Bukoma, Simbi, and Masaka. The response, the EMS structure is designed in such a way that the response at regional level is at the Regional Referral Hospital, so we work directly with the Masaka Regional Referral Hospital. Then the goal was to contribute to achieving the universal health coverage through improving health conditions of vulnerable communities. And this project had a portfolio of about $4 million US, and the focus was mainly on improving service delivery in emergency medical services through human resource development, then improving the facilities where the health workers do their duties, then improving governance and management capacity for better performance management, as well as improving the values that are created by the project. So we also focused on improving access, the referral system from the community to the regional referral hospital level. So you can see these, as we procured 4 Type B ambulances for the Greater Masaka region, where we were supporting the response towards 12 districts. And I can say that our president, Dr. Omona, was the chairman of the steering committee for the entire region of Masaka, manning 12 districts. So I acknowledge your contribution. Now, this is just a location map. I think we all know where South Central is, and you can see the areas where we worked. So these are the major investments that we made. In terms of infrastructure, that is construction and renovation, we had a contribution of about 12% of the entire budget. At Masaka Regional Referral Hospital, we set up an emergency medical services skills and simulation lab. And this one was to cut the cost for hiring venues for training, because we realized that a lot of the budget was going into the hiring of venues. So setting up the regional skills lab was quite one of the values that we created. And anyone that is conducting or planning to conduct an emergency medical services training can just make a request without any payment and conduct and use that facility. It also has a simulation lab. So we also set up the emergency ward and OPD block at Butenga Health Center 4. We set up a surgical ward at Butenga Health Center 4. We built a fully fledged operation theater. we fenced the entire facility of Butenga Health Center 4 of about 15 acres. Then we renovated and expanded the maternity ward from 154 square meters to 209 square meters. And then the bed capacity increased from 8 to 20. And altogether, that is we used about $530,000 for that. So up there, you can see the regional skills lab, which was built. Then on the left is the expanded maternity ward. Below is the expanded maternity ward. So it's linking, the maternity ward is this side, and it's linking to the operating theater. Then the surgical ward is this side. So all that was set up during our intervention in the first phase. Now, when we come to capacity building, after setting up the infrastructure, of course, you need to build the capacity of the health workers to be able to do their work more efficiently and effectively. So these are some of our capacity building programs. You can see Madame Maria there. She was facilitating in one of the trainings. And these were trainings in the greater Masaka region. So we trained about 2,000 health workers, and you can see that is that's an impression that gives you what we did from 2017 to 2022. So these are the courses that we engaged in during the first phase of the project. We had advanced life support, basic life support. We had basic emergency care, community first aid response, emergency call and dispatch. In COVID, we also built capacity in that area, critical care for COVID-19, quality improvement for EMS providers, then responders. The ambulance the EMTs and the ambulance drivers were also trained to be able to do their work more efficiently and effectively. We also had pre-hospital care for COVID-19, medical major incident response teams, ultrasound management, among other trainings. Yes, so you can see the budgets that were allocated. Ministry of Health has a sizable budget in training, which is about $200,000. And they trained 456. One may wonder why there are fewer health workers that were trained by Ministry of Health, and yet they had the lion's share of the budget. What I can say is that Ministry of Health focused on training of trainers, but also Ministry of Health used to hire venues as opposed to the other partners who were using the regional skills lab and other free facilities. Yes, so how can we measure the impact of the training? Of course, it's through the pre and post tests. And you realize we averagely had a knowledge increase of about 30% from all the trainings that we carried out across the lifespan of the project. So we also procured medical equipment. Besides the training, we also had to provide equipment based on the recommendation by the health workers that were leading at the different facilities, as well as Ministry of Health. You can see a digital X-ray, which was procured for Masaka Regional Referral Hospital and Butenga Health Center 4. Then we had over 1,000 different equipment that were procured throughout the lifespan of the project. And these were mainly emergency equipment. We had the X-ray and ultrasound. We had various training equipment and mannequins. We had the maternity ward equipment. Every infrastructure that we set up, we made sure that we equipped it fully. Then, yeah, that is what I can say. We also made sure that the call centers were well established at the community level and the regional level. We set up the very first call center at Masaka Regional Referral Hospital. It was the very first call center in the country, and it was used as a benchmark by the different partners. But I can also say that this EMS project was the very first EMS project in the country, And as such, it was a signature project, and it made a very big contribution towards the achievement of the EMS policy, as well as most of the gains that have been realized with the support of other partners. So we also procured GPS systems which were installed in the different ambulances in the region to make sure that they communicate well with the regional call center. We also supported the setting up of the Naguru National Call and Dispatch Center, stroke ambulance station, which was turned into maybe the National Trauma Center. So this is some of the equipment that was procured throughout. You can see in 2019 and 2021, most of that was the period when most of the equipment was procured. So in terms of performance indicators, you can see at Butenga Health Center 4, because of the intervention of our project, the patient attendance at the emergency unit increased significantly for a Health Center 4. And in blue, we can see Masaka Regional Referral Hospital, which tried to maintain. Then the number of patients who received care at scene, we can see it really increasing for the two different intervention sites across the project lifespan. Then the number of emergency patients arriving by ambulance, we did a lot of effort because of with the intervention of the ambulances. For example, in Butenga, with the ambulance which was provided for Butenga Health Center 4, you can see arrival by ambulance increasing significantly, and that is the same with Masaka Regional Referral Hospital. Then patients accessing care within 1 hour of arrival at the emergency unit. You can see that also increasing significantly because of our intervention. At the time we started, it was really low, especially at Butenga, but you can see by the time of the end of the project period, we had really shot up. So death at the emergency unit, you can see the attendance is high, and with Butenga, you can see Butenga reducing, and also Masaka Regional Referral Hospital trying to contain this, despite the high numbers or the high attendance. Then we really emphasized a lot to do with triage, because triage is really key in emergency response. So you can see the efforts in triage, and that is how we perform. The slope is quite linear, and it shows how much effort that was put in. So referrals in and out, you can see at Butenga and Masaka, the referrals in and out. Referrals in is blue and referrals out is orange. But you can see there are many referrals in, especially at Masaka Regional Referral Hospital. But because of the support that was provided, they managed to handle most of the cases with reduced referrals out. So that can also be attributed to the project. So the number of calls received and responded to by the call and dispatch centers are also reflected on that slide. For the community call center at Butenga Health Center 4 and the one for the region at Masaka. This was a pilot project where we're trying to pilot the community level response vis-a-vis the regional response. And our kind of approach is focused mainly on health system strengthening. We just provide the budget to government, then we do the monitoring and support supervision. So we had patient satisfaction significantly increased to 92%. In fact, it was at about 50%, based on the surveys that were carried out by Dr. Mona. Then eventually, by the time of our exit, it was at 92%. And I think this is quite commendable. So satisfaction with availability of medicines. We used to provide a lot of budget towards procurement of emergency medicines. And perhaps it could have attributed to this performance, but by the time we ended the project, we were trying to make sure that we build sustainability through a phased way of reduction of these medical supplies. And there were moments when government, the national medical stores, took long to provide the commodities. So I think that's why we are seeing such a slope. Now, when it comes to community knowledge of basic first aid, we also had a survey that was carried out. In fact, this was in 2022, and that is how it stood. And we hope that in the second phase of the project, we can do a lot more to improve this picture. Then, knowledge of the number to call in case of an emergency. That one rests at 93% for Masaka Regional Referral and Butenga 49%. So there is more work to be done for Butenga, and we are doing a lot of work through the village health teams to make sure that they carry out these messages, but also we have provided information, education, and communication materials to make sure that people get to know the number to call in case of an emergency. So this is also under the project that is being managed by my colleague Simon under the Community Health Workers project. So we had some issues, and I'll share some issues and some of the mitigations that we developed in order to overcome them. So we had the challenge of the mismatch between the Korean and the Ugandan government financial years. You know, the Korean financial year runs from January to December, while the Ugandan financial year runs from July to June. So we had a very big challenge, but we are now trying to move towards proper planning, especially by being proactive, and we are recruiting project assistants to support Ministry of Health and other partners in ensuring that they deliver their plans in time, such that we align to the Korean financial year. We also had an issue of low visibility. The donor funding framework, especially for the DAC committee of the Organization for Economic Cooperation and Development, where Korea subscribes, has really changed significantly, because they have a framework which focuses on efficiency, effectiveness, coherency, impact, and sustainability. But to them, visibility is key, because that is the only area where they are also, where their taxes are appreciated. We had a team of 16 parliamentarians from the Republic of Korea who came this year, but one of the comments they made was that they were disappointed that visibility was low. So now we are putting a lot of emphasis on visibility. That's why you see these pull-up banners, that's why you see this digital display, and many other visibility items. So we are looking at increasing public relation efforts. We recruited a project coordinator in charge of visibility at our office. So he's engaging a lot with our partners and strengthening their capacity in visibility. And I think you may have interacted with him already. Now, we are also doing project videos, at least as our partners do their implementation. We encourage you at every moment in time to shoot those videos, so that when it comes to making a documentary, you don't have to recollect, or rather to reshoot. Then we had challenges with efficiency. Efficiency in the sense that we had a lot of refresher trainings where we had to incur a lot of budget. Now, we would like to leverage technology. When you look at the Korea-Uganda country partnership strategy, they emphasize digitalization and technology. So that's why for every project, for any project to be funded by COFI, when you put digitalization, you're bound to be funded. We have a project which we might implement with Ministry of Health and UNICEF, but it has a lot of digital health component. This project might start in 2027, and it has a portfolio of about $20 million US. It's also in community health and digitalization. Then we are also trying to look at results-based financing, because the way we work, we give the partner the budget, they implement, and they give us reports. We don't release funds on a quarterly basis. The funds are released maybe once, maybe just as one figure or in two portions. And we haven't really been emphasizing results-based financing, but now that is the direction. Because of America, Korea is also aligning, because it's a strong partner of America. Now there's a lot of emphasis on efficiency and effectiveness. We also had an issue of the exclusive partnership with Ministry of Health. We were actually thinking about diversifying partners. That's why you've heard of that project, which is coming up with UNICEF in 2027. Then we also had issues to do with sustainability, overdependence on coffee fund, especially for ambulance fuel, maintenance, and GPS tracking, the GPS tracking systems. So here we are saying that we shall do gradual withdrawal of fuel support through cost sharing. We shall also do regional ambulance maintenance workshops where these can support the entire region. We send biomedical engineers up to master's level to Korea. They start, they come back, and they support in this area. Even with equipment, sorry, that is with equipment, emergency equipment. Now, COFI developed the EMS GPS system. Now, we want to develop a GPS system which has our rights, and maybe we can use it free of charge without having to pay every year. Then we want to promote innovation. So whenever we receive project concept papers, Beatrice can attest to this, and maybe Regina. The competition is quite stiff. We open the space, and you come and compete. One of the things we are looking out for is innovation. When you have an innovative idea, it has a digital component, it's well aligned with sustainability, and our framework of implementation, chances are high that you'll get it. We also had an issue with the lack of a robust monitoring and evaluation system for the capacity building program. We did a lot of capacity building, but it ended right there where the capacity building was built. We didn't oftentimes follow up to check how the knowledge was impacting the attitude and behavior of the health workers. So we didn't do much on that. In the second phase of the EMS project, we are planning to do more of these kind of surveys. So we, in terms of the capacity building for the M&E system for the capacity building program, we are also engaging our consultants to support us, but we also had a challenge with lack of an M&E system for the equipment. So Regina's project is answering this gap, and we are also trying to work with the joint medical stores as well as some other private partners. We also had challenges with procurement delays. Here we are looking at consolidating the different procurements. For example, we were in Bukoma and Simbi, Masakari General Referral Hospital, Ministry of Health. So at some point in time, we noticed that maybe Bukoma and Simbi would be lacking behind, and the other partners are already ahead. So we decided to aggregate some of these procurements, such that we don't lose much time. That was one of the solutions, but also we are looking at results-based financing and planning together and bringing the private sector, for example, joint medical stores, to support us and guide us on how best we can achieve the procurements in time. Then the use of more efficient systems through partnership. we have procured quite a number of project vehicles through the UNICEF procurement mechanism. One, it's cost effective. We cut the cost of the vehicles by maybe 1/3. We actually, for example, in the two project, we wanted 3 vehicles, but with the budget, with the same budget, we managed to get 4, while when we procured with the UNICEF. So we are trying to seek out for other avenues that can be more efficient. Now, I'm trying to look at the major successes. I'll conclude and make some recommendations. So with the EMS project, it's, according to our record, over 150,000 lives were saved. And some of our major outcomes included increase in scene care. You can see scene care rising from 10% at the time of the intervention and 60% by the time of the end of the project. Arrival by ambulance rising from 30% to 70%. Triage from 40% to 98%. Resuscitation in an hour from 30% to 95%. So Dr. Mona, you did so well. We can also see that there was an over 100% increase in emergency attendance and referrals in, just like you saw in the data I've already shared. Then there was a 50% reduction in death within the emergency unit, 4% reduction in emergency referrals out, more than 60% increase in patient satisfaction with emergency services, and more than 30% average knowledge increase across the trainings. So to us and to the government of Uganda, this project was significant in the sense that with it being the very first EMS project in the country, actually the government of Uganda benchmarked on the Korean EMS system to build the Ugandan EMS system. So this was a major milestone. And the project led to the inclusion of 5 EMS indicators into the DHIS2. And because the EMS, we didn't have the tools to track the EMS indicators, but with the support of Madame Marie and the team at Ministry, we were able to achieve this. Then Masaka Regional Referral Hospital became the national model for EMS regional response. Different partners would come to us. I don't want to mention the names, but many partners came to us to benchmark on our interventions at Masaka Regional Referral Hospital, especially with the call and dispatch center, the emergency department, and the regional EMS skills lab. Now, we used to, after Dr. Mona had carried out the trainings in the entire region, he made sure that his team followed up at lower level facilities to make sure that an emergency room is created at the lower level facilities. And that is another milestone that we achieved through the project. Bokoma and Simbi performance in the district league tables significantly increased, and Butenga indeed became the center of excellence for maternal and child health emergencies due to this intervention. So actually Butenga is being upgraded to either a district hospital or community hospital. Now, in conclusion, I can say this was a landmark project. It was quite significant because of the values it created. However, there were some identified issues like I've shared with you, and we shall use the lessons that we learned to make sure that we have a better second phase. Then the recommendations that, some of the selected recommendations are to focus more on the national level and more tangible activities. So the second phase, the outlook of the second phase, like my brother Simon presented yesterday, is going to have more of a national outlook as opposed to the first project that we had, which was regional. Then we are also going to look at greater visibility, better project performance, and sustainability, but we shall leverage science and technology as well as innovation for efficiency. But we shall also look at synergizing in order to avoid duplication. So that marks the end of my presentation, and I thank you.
Thank you so much, Mr. Pritchard, for highlighting the impact and lessons from the Coffee Phase 1 EMS project. I'm very sure that these insights have given us a strong foundation for understanding what has worked on the ground. And now we will widen this lens and look at the broader emergence burden in Uganda, both realities that are facing us in the local aspect and at the regional aspect. After that, we will move to government and partner interventions, the progress that they have made, the remaining challenges, and what we need to do next. Those two parts will be discussed by Dr. Joseph Oumo. Allow us to welcome him with a hand of applause. As he comes, after his presentations, we'll have Q&A. I hope Dr. Mary is still online. We'll have her also on online session as she answers the Q&A session.
Good afternoon, colleagues. Good afternoon. Thank you. Right, sorry for the delays. Okay, so I'm discussing emergency conditions burden in Uganda. Specifically, we're looking at the local realities and the regional lessons. And specifically, this analysis was done in 2024, so the 2025 data has not been included. Right, so why does it matter? So emergencies account for a major portion of morbidity and mortality in Uganda. And we're all aware of that. And the high impact is most felt among the young that are economically productive for our Ugandans. And the majority of these deaths, like we discussed yesterday, are actually preventable. Functioning emergency medical services, according to the literature by WHO, can prevent up to 54% of this death. And national EMS strengthening is an urgent ask to all of us. And so therefore, we must take this as a priority. As of 2023, these are the cases that we received through the DHIS2. These numbers might not reflect the reality. Note that the mortality stands at 2.1%, and the leading causes are mainly trauma. We have infectious disease, malaria ranks high in that, but also we have the non-communicable diseases rapidly rising. Then of course, our fight has been majorly focused mainly on the preventable maternal death. And it's a critical burden. Last week, there was a concern in one of the districts that registered 5 maternal deaths. It was a crisis for some of us who are involved in that space. Ambulance coverage in 2024 stood at 11%, but as of 2025, we're now at 21%. And that means for patients that arrive to the health facility using an ambulance. The highest burden regions are mainly Albertine, Southwestern, and Busoga and Teso. The cases are low in Busoga and Teso, but they have the highest mortality rate according to the figures. And the low burden region is actually central, with about 617 cases per 100,000 population. The critical insight, the critical point is that the burden does not match the resources we allocate. And that comes into concern. Yesterday we were discussing about financing, and results-based financing has a bit of challenge because sometimes the resources, the performing facilities might actually not be, there is equity concern when you talk of results-based financing. The performing facilities might overskew, mainly because they have initial input was high compared to the poor resource facilities. Right. In terms of trauma, the road traffic injuries account for more than 50% of the emergencies in some regions. And the biggest concern is that this data is not universally accepted. The challenges, we have data gaps, especially what police reports. Most often when an accident happens, the first thing is you run away from the police, isn't it? Before you look for the health facility. So there are gaps. But we note that the police only report a quarter of the road traffic crashes that happen in the country. The economic impact in terms of trauma is that road traffic injuries consume more than 60% of the surgical budget. You note that in yesterday's discussion, we said that trauma actually, in terms of burden, trauma ranks as number 1. And the highest affected is the economically productive population, the young. Right. In terms of maternal and pediatric emergencies, we know we have done tremendous work on maternal mortality, and the maternal mortality ratio now stands at 189 per 100,000 live births. And I think the figures are even going down. The annual health sector performance report reports institutional mortality now below 100 per 100,000 live births. So that is a tremendous improvement. The leading causes still remain hemorrhage, and then we have the hypertensive disorders in pregnancy and the sepsis. Pediatric emergencies are still concerned and worse with the emergency medical space because of the limited equipment, but also the technical know-how on transfer of these cases. And so therefore, we still struggle to attend to children with pneumonia, with malaria, and even diarrheal diseases. But still, these are the major concerns. And transport delays significantly increase mortality, especially in the neonatal space, especially with the newborns, that we have no specialized equipment, no specialized ambulances to transfer these cases. So there is what we call a dual disease burden. We have persistent infectious disease, then communicable diseases, but we also have the non-communicable diseases rising. We are struggling. And the hypertensive crisis studies report that prevalence is up to 30%. And we know that infectious disease also accounts up to 33% of the emergency cases. So we have to manage both despite our limited resources, and we have to address the concern as soon as possible. Right. What do our countries, what do our neighbors do in terms of emergencies? In Rwanda, they've gone a bit step further. It's initial discussion in Uganda that we do a drone delivery of emergency products, especially blood products. And like discussed yesterday, Rwanda is one of those countries with the best performing health insurance. Though like she discussed, the coverage, universal health coverage still remains around 50 what? What was the figure? About 51, okay? The significant improvement is mainly about trauma. In Rwanda, what is the speed limit? Who knows what is the speed limit in Rwanda? Yes, sir. Anywhere in Rwanda, especially in Kigali. Okay? So you must not drive above 60 kilometers per hour in Rwanda. Okay? So even in urban areas, it is worse, 30 kilometers per hour. And that has significantly lowered the trauma mortality in relation to road traffic crashes. In Kenya, we have national emergency number 999, which is active. I hope you have not now engaged in another discussion. Colleagues, let's have one discussion. Right. In Kenya, the private sector in terms of ambulance services is the strongest. The government one is a bit weaker than ours. And we have the county, it's a county level EMS coordination as opposed to the national and regional coordination in Uganda. In Tanzania, we have a centralized, they have a centralized national ambulance service with community health worker integration, but similar rural challenges like our setting. DRC, the situation might be worse. Minimal formal EMS systems, reliance on NGOs and emergency and community transport, and then of course, resource limitation that is probably not comparable to any of our settings. Right, our common challenges. We have pre-hospital delays. On average, in a rural area, if you have an emergency, it might take up to 4 hours for you to get an ambulance. A bit fairer in urban settings, about less than 1 hour. We have equipment stockouts, oxygen and oxygen delivery devices, essential medicines. An ambulance might come and they might not even have a fluid. Okay, so it's something that, but of course, you go to an emergency unit and the first thing they will tell you is to go and buy some supplies. So these are some of the challenges. Human resources, of course, we know it's a critical shortage in terms of training emergency staff. Staff are rotated from departments to emergency units, and those that we train might be transferred to lower facilities that don't have emergency units. So these are challenges that we have. And of course, coordination, communication gaps. The challenge is we've asked all facilities, all ambulance service providers to communicate to the facility through the regional emergency medical services coordinator. And you should be able to coordinate the care of this patient. That when you arrive to the facility, there is a team that is ready to support you. The geographical barriers in terms of difficult terrains and poor road networks, in some regions, you may not be able to move with an ambulance all throughout the district. And of course, the financing models, we are still dependent on donor support. So we have unique advantages. Yesterday, the discussion about how can incorporate our data elements into the community health. It's called ECIS, Electronic Community Health Information System. So can we use this strong VHT approach and be able to incorporate EMS in terms of response at the scene and support to activate the formal system? So that would mean they call ambulances and be able to support and even locate the service points. In terms of digital health, there's integration. EMS is building a call and dispatch system that is able to, there's a community element. We will have a community app where we just dial or text or even SMS, and you activate the system. And then, of course, there's the element of information sharing that will be available at that app. And then there's an app that is available for our health care workforce. It guides on routing, it guides on information sharing, it guides on activation, rather coordination with receiving facility. And so this is an advanced stage, and preferably, hopefully by end of December or even before, this is available for public use. We have proven local interventions or innovations that we think we can leverage on to get better. Then, of course, we have the multi-sectoral approach. We work not as one sector, Ministry of Health, we work with Ministry of Internal Affairs, Ministry of Defense and Veteran Affairs, Office of the Prime Minister. All these are involved in improving emergency care in the country. You forgive me, I think this is repeated, and the repeating part of the presentation was a copy from the previous, but of course, these are what we mentioned earlier on. Thank you so much. That was in relation to the burden of emergency cases in Uganda. Thank you. You'll allow me discuss what we have done as a country and what we are partnering with colleagues from the diaspora and stakeholders from within the country to achieve in terms of partner interventions. It's meant to be a short one, and then we can proceed to the discussion. IT? Well, this was meant to be mine, and the previous one was meant to be for my boss, the principal medical officer. So this is now my present. Right. So, what have we done? What has government done, and what are partners doing in relation to EMS? And a bit of progress, some challenges, and what we hope to achieve in the future. Joseph Oumo is my name. Yes, so we share the journey, highlight the key interventions by government, and discuss some of the persistent challenges, and then probably outline some priority actions for the next foreseeable future, immediate and long term. And maybe we'll ask you a concern question. So, in terms of why EMS is a must build, EMS is the face of a functioning healthcare system. You go to a health facility and they're able to provide you with that care that you desperately need in that time of dire need. That means the system is functioning. You're at home, you're able to call an ambulance, and they respond within 17 minutes. That's the ultimate goal. Then the system is functioning. Okay? We have talked about causes of mortality. Emergency conditions rank as the top 7 causes of mortality in Uganda, with road traffic injuries accounting to more than 50%, and of course the maternal. EMS is not a luxury. Though it is expensive to implement, it is a lifeline. It is what saves when you need it most. So, this has been discussed. EMS policies of 2021, strategic plan is 2020-2021 to 25. 4 key objectives: scene care, emergency care, sustaining operations, and then governance and regulation. Midterm review was done of the EMS strategic plan. It said that we were slow in terms of achievement of the strategic direction, with only 13% of the planned activities completed. But up to half of them are actually lagging. So, the question is, what police action is most urgent? Is it the Good Samaritan law? Is it the EMS Act? Is it financing mechanism? Which one is most urgent? All, eh? Right. Okay, so the government interventions are quite unique. They have standardized emergency care units. We have national ambulance standards in terms of type B, type C, type A. So we are planning as a directive from cabinet to conduct an ambulance assistance and determine which ambulance is actually fit to be still called type A, B, and C, and those that need to be recommended to be registered. And this should be done as soon as possible. And that means that we have a national ambulance standard for our country. We have 912 short code, which is nearing activation and should be available for country to use. We hope that this will sustain our gains or even protect them better. Development of a dispatch protocols has been done. This was work done with support from one of us, Dr. Joseph Kalansi. And we've strengthened referral pathways. Now you call a facility, they will at least try to say, have you informed Mulago that we are coming? Okay? Have you informed Tabika that we have a patient before they even move? So we've moved strides at least. The highlight is that EMS cannot or could not have been built without establishment of the EMS department, but also had a blessing in disguise. So what was our blessing? So COVID-19 is our blessing for those who work in the EMS space. It was something that really enabled us to grow. Right. Okay, these are just highlights. Forgive me if I didn't mention one of your agencies, but the focus for COFI is mainly about programming, system strengthening, and we work with them to establish a national coordination center. And there's a lot of work they've done in Butenga and Masaka in terms of emergency unit renovations. WHO, of course, with technical guidance and protocols and guidelines. UNICEF has done much work on maternal and newborn care. USAID, World Bank, specifically World Bank in terms of call and dispatch. We're establishing about 4 call and dispatch centers in 4 regions. We have Lira, we have Mbale, we have Arua and Mbarara. So this with support from World Bank. And then the private sector plays a key role. One of the strategies is that we should build a partnership, private sector, public-private partnerships, so that we're able to provide supplies, provide ambulances, but also we can train them to support the system better. So, this has been talked a lot. I think I may not, the experts have talked about this at more length in terms of the coffee massacre pilot. It's been a success, really. So the outputs and the impact, as previously discussed by the previous speaker, is tangible. It's something that you can feel. Okay, thank you so much. So in terms of human resource, Commissioner yesterday mentioned about dedicated scholarship for emergency care professionals in terms of emergency medicine, and then diploma in emergency care. So trainings are ongoing, but also we are doing the in-service training in terms of basic emergency care, and then the ATLS, ALS, BLS, Then the career path, we're developing the career path for the EMT and the paramedics. Of course, the challenge is the higher attrition, specifically the transfers. You train a health caregiver in a health center 3, and they're transferred to a health center 2, where there is no emergency unit. Okay? Or they're in a health center 4, they're transferred to somewhere, say A&E. I mean, rather antenatal. And so it's something that is affecting us. But also specifically bystanders. One, we need to protect them to support us, but also we need to enable them or capacitate them to support the system. Okay, infrastructure and equipment, a lot has been done. We have over 300 ambulances distributed across the country. The target is that every 100,000 population should have a type B ambulance, universal health care, universal access ambulance. And so that usually equates to a constituency according to our population figures. So every constituency should have a type B ambulance, community-based ambulances, not facility-based. So these community-based ambulances, we have reached on average 61% coverage across the country. And we have type C ambulances for specialized institutions and regional referrals. So every facility that serves about 200 million population should have a type C ambulance. Renovations in terms of emergency care units have been done. Special gratitude to Kofi for the work they did in Masaka and Butenga. But also we have, kindly clap for Kofi, please. But also we have some partners that have done works in different parts of the region. We have oxygen refill systems. Ambulances now have oxygen. Type B ambulances must have oxygen, and we're refilling them in up to 75% of the regions. Our gap still is on coordination of ambulance response. We only have 2 call centers that support coordination of ambulances in terms of call and dispatch. Okay. Data monitoring, and then M&E. We've 7 of our 18 EMS indicators that are now in DHIS2. Those of you who happen to have work around DHIS2, you'll see EMS indicators there. We have quarterly EMS reports that are now standard and shared across the region. We have focal point person or focal point for monitoring and evaluation at MOH. Our concern, our cry is that we're only using 25% data from the regions. So it's only 25% of the regions that are reporting. It's affecting us. It's something that we need to work together and see if we can improve. Okay, we still have some challenges and gaps. High in the list is that we have to have a law, a regulation that will oversee provision of ambulance services across the region, or rather across the country. We're dependent on financial support. All ambulances are donations, actually, apart from 38 that were procured by government some time back, 2 years or 3 years back. The rest, we must get from someone. Okay, so these are key priorities. High in the list, EMS Act, Good Samaritan Law. This 912 is almost available for use. And then I've talked about data and M&E plans. And the scale-up committee by standard training, it is needed as of yesterday. It's something that we need. And then, of course, dedicated funding. You've heard that government might have dedicated more additional funding for specifically EMS activities across the country. Yes. My colleague has slept. Right. Okay, so way forward, it's a call that to collaborate together, isn't it? So as government agencies, please, let's pass the act or fight for the act. Let's fund for establishment of coordination centers for ambulances. And then let's have the EMS cadre that is specific to provide emergency care across the country. To you partners, please. Align with our strategic direction and invest in something that is available for use across the country. Not something, someone mentioned about pilotitis in Uganda, right? Okay, thank you so much.
You can stay here. Can I have Mr. Pritchard and my online team? Can you check whether Dr. Mary is online? Okay, good. Dr. Mary, hello. Say hello to us. I hope you're checking.
Hello, can you hear me?
Yeah, we can hear you very well. So we are starting Q&A session, and everyone in the room will ask questions, and they will be directing it to specific people. And I allow the audience now to give us questions.
Yes, Dr. Mary, this is Maria Nkalubo. I remember I was introduced to you by Dr. Kalanzi, but you may not remember the small person now. It's quite some time. Dr. Mary, I mean, your presentation was a reality of what is on ground. The speakers that came in next, definitely at policy level, and normally when you're at policy level, your lenses are in most cases, you know, broader. You don't get into the nitty-gritties of what is exactly on ground. So when you presented and mentioned the young doctors, our pioneers, and Dr. Imron's remarkable efforts in Katakwi, I just held my tears back. Yeah, but I was soothed after when I heard from the next speakers. I've personally met Dr. Imron during one of some deployments, which are not emergency related in Katakwi, of course under government. And when I asked him what motivated him to return to his home district, he told me the same. He said in his own words that I wanted to give back to the community that made me. Up to now, that statement has stayed with me, but it reflects also the deep commitment many of our health workers carry, even while working in an extremely constrained and grappling healthcare system. My question to you, Dr. Ellen, is, from your experience, what has been the journey in high-income countries in terms of overcoming systematic barriers that hinder the development and orientation of skilled emergency medicine physicians nurses and EMTs. And what key lessons or turning points enabled those systems to strengthen their emergency care workforce? It's kind of a combined question. Then the last part is what reflections might be relevant for countries like Uganda that are still in an early stage of building a robust EMS system. Thank you. I don't know, yeah, I hope I've brought it out well, Dr. Mary. Thank you.
So I understand the first question was sort of how to overcome some of the challenges of developing the workforce. I know one of the things, we have very much a sort of decentralization problem in, for instance, the United States as well, as I know we have in Uganda. With the urban-rural divide, we have a great deal of difficulty getting our most highly skilled and trained healthcare workers into the rural areas. One of the ways the system tries to compensate for that is that you generally are paid a good deal more if you work in a sort of a rural area. But really, even at that, it becomes difficult to get someone, you know, from say an urban area to move to and work in a rural area. It's one of the reasons why I think that one of the things that I would like to see us do in Uganda, particularly at the level of our advanced training, when we're trying to recruit people into our Master of Emergency Medicine, our Master of Emergency Nursing, that sort of thing. I would like to see us really get out there and recruit from the areas that are underserved, right? So that we are training people who are from those areas. Yeah, people who are, one of our current students in the master's program is from Fort Portal, rather. He's an MO there at the hospital. So we're spending 3 years giving him training, and when we finish, he will go back there and take that training to that area, back to his position where he's already an MO in that hospital. So that's one of the ways that, speaking of Dr. Kalanzi, that he and I have sort of, you know, talked about trying to get some of this training out into other areas. I'm sorry, what was the other part of your question?
Let me repeat the question. From your experience, what has been the journey in high-income countries in terms of overcoming? That one you've answered, that, I mean, developing and retention of skilled emergency medicine, you know, physicians, nurses and EMTs. The other one is what key lessons or turning points enabled those high-income systems to strengthen their emergency care workforce? And what reflections might be relevant for countries like Uganda that are still in our early stage of developing such a system? Yeah, thank you.
Well, you know, it's funny, I've been thinking about that, and I can't say for certain, but really emergency medicine, at least as a doctor specialty, is really quite new everywhere. It only started, you know, even here in the United States in the 80s, so it's a quite new profession. But I think that one of the potential lessons to be learned is that the development of emergency care really focused, at least here in the United States, around the emergency care units, or what we call emergency departments here in the States, so that there was a home base for emergency care. And I think of that in regard to Uganda because, you know, we always talk about low resource, but there are resources. There's a lot of resources. There are human resources out there. There's an incredibly dedicated pre-hospital team. There are some very enthusiastic workers in the emergency care units in every place that I've visited. And there are even some of the material resources and what. They may be undersupplied, but they're there. And I think that maybe the next step of challenge is to find how do we bring that all together so that we can best use it. And I think one of the things that we did in the United States as we were first starting with emergency care is we sort of centered it all there at the hospital in the emergency department. And then the system grew from there. The pre-hospital system sort of grew from being based there in the emergency department and then reaching out and bringing people in, and then the handover between the teams and what. And the supply chains, and when we were developing our disaster response or our epidemic response, it was centered sort of there in the emergency departments, the emergency care units. So I wonder if that might be one thing to explore there in Uganda, when we've had this really robust EMT sort of paramedic curriculum that we've come up with. We have, as people have mentioned, there's various ambulances and available, different equipment that has been purchased by the MOH or donated from various things. There's a great deal of resources available in the country, and sometimes it feels like it's a bit scattered almost. And I wonder if one way to sort of bring that together and focus the strength of it would be to center our efforts, say in each of the emergency care units, like at the regional referral hospitals, so that we have that sort of center of excellence model that I mentioned, where, whether it's in Masaka or there again in, Hoima or wherever, that the regional referral hospital and the emergency care unit is really sort of the focus of our emergency care efforts, and we are able to sort of grow from there. That's one thought that I have that would, sort of mirror a little bit of how we did it in the States, and could potentially, I think, grow there in Uganda.
Thank you so much, Mary. Let's have other questions.
Thank you so much. My name is Kga Christopher from Uganda NCD Alliance. I have a number of questions from the two presenters, that's Richard and Joseph. Richard, you did well in presenting to us the project and maybe the achievements. But the quick things that came into my mind, given the resources that you poured into the Greater Masaka, and they have actually made Masaka Regional Referral Hospital kind of a model regional referral hospital for emergency medicine services. And then you also mentioned that other regional referral hospitals have come to benchmark. Now my question is Masaka now at a level of moving and maintaining what you put there beyond the project? That's number one. Number two, how sure are we that those who are coming to benchmark, picking the knowledge, that they're also going to use it effectively without the same resources that Masaka has? And that one also takes me to another issue, that what is the sustainability plan for what we have achieved from Kofi and maybe other supporters? This one may also go directly to the presenter who, to I think Joseph from Ministry of Health. Then the other one goes to, the other issue was on the numbers. You told us you've saved 150,000 lives. How were you able to arrive at that figure? Then number two on the same, yours would have also made sense in your presentation if you had actually, you gave us the burden and the numbers. It would have made more sense if we're able to tease out the common causes of emergencies in terms of conditions within the region where you've been working. Then that one would help us to be able to analyze and know. And then you also, so again, maybe this one now goes to, is this Joseph? Joseph, I had so many comments, but I'll just go take you direct to where you ended and told us that the challenge, you said, the data you are relying on is only 25% of the regions that are reporting. Now my question is, how sure are we, and I'm talking this from an authoritative point of view, that actually you are also not giving us 25% or below of the data that those regions are also reporting, that the reporting you're giving to us from the 25% of the regions, they're also not giving you 25% of the expected data. I know the challenge you have with regional referral hospital in reporting, especially the HMIs and the HAIs too. It's something that also need to look at. So I am worried that you could be getting 25% of the data that would be expected from now what you are telling the 25, you are telling us as the 25% of the regions that we get. Thank you.
To avoid the questions to go off the minds, let's just respond to them.
Thank you, Christopher. There are quite a number of questions, but I'm going to try my best to answer them. Well, what I said was that different partners come and benchmark from Masaka Regional Referral Hospital. I didn't say regional referral hospitals benchmark from there. It's development partners. Then how can they sustain the investments? Our model is quite unique. We were trying to do some research on the different partners, and we noticed that it's only coffee who give the budget to the partner, and the budget, the partner manages that budget. For example, we do annual plannings. Like when the project master plan is being developed for 5 years, all the stakeholders are engaged in the consultations. Then we do annual work plans and reviews. So it's ministry that initiates based on the environment at that time and the need. So when ministry does prepare the plans, we review collectively. Then we also have certain interests. For example, we are looking at efficiency, we are looking at effectiveness, we are looking at coherency, we are looking at sustainability, we are looking at impact. If we see an activity, if ministry brings many activities, but there is no correlation into the theory of change, we tend to advise them to ignore those activities. And we tend to focus more on, and this has been a practice that has gone on and we have improved along the way. So I won't say much, but that is how we do it. It's ministry that initiates, because we are trying to build the system as opposed to, so we give government the opportunity to take lead. Then we're on their side as we move together. So in that way, we think we can build sustainability if we work within the government systems and what they want. Then regarding benchmarking and using effectively, what I can say is that, for example, Enabel and other partners have gone to Masaka to benchmark on the call center. When they benchmark, they don't have to really replicate exactly what they see. If they can do it better, even the better. But Ministry of Health, for harmonization, has tended to come up with a structure that is going to govern all, for example, regional call centers. There are drawings that have been designed on how a regional call center should look like in a regional referral hospital. So that way, we are all trying to work within a certain structure and model, such that we don't have to look different from each other. But I can also say, when we talk about coffee, we are talking about government championing and being at the forefront. It's not coffee that is trying to implement or do all this. Government initiates and it takes lead. Then when it comes to sustainability, I've talked about that. How we came to the 150,000 lives that were saved. That figure is quite, we thought it was quite representative of the picture of the lives that were saved. I cannot say it's 100% accurate, but as you know, data may have some errors. But we tended to look at the general register, at the emergency department and the OPD. Then we teased out the red cases, especially at triage. Then we see how many lives, the red cases vis-a-vis the lives that were lost. So that's how we came up to about the common causes of emergencies. It is well taken, sir. And I thank you.
Right, thank you so much, Pritchard. Yes, specific to data reporting or reporting of data, it's a big issue in EMS space. Like noted, we're utilizing 25% of the data. It is what is available. You'll learn later on that you use the data that is available for informed decision making. You don't wait for the rest. But it is what we're utilizing, and it is what is guiding the decisions that surround EMS interventions. It is a challenge, we acknowledge it. It is what we're trying to address, and we're going to leverage on so many things that we're working together. One is the call and dispatch system. This system is able to log in cases and report the utilization of ambulance, the arrival at facility, the response time, and availability of equipment and supplies. All this, availability of fuel per se, or mileage that has been taken, or the ambulance, the route the ambulance took. So all this information probably will be available once we roll out the call and dispatch system. But also we mentioned about the Kga system. We're hoping that we'll use the community members and be able to provide information on pre-hospital services. So the community members, through the VHTs, the community health extension workers, all these have access to this system, and we hope to utilize this going forward. In terms of sustainability, government is committed to build emergency care system in the country. As mentioned, NDP 4 strategically mentions about emergency care system and referral pathways. So government is dedicating funding to the system. So that, in a way, we know government funding is sustainable, right? But also we are looking at alternative sustainable funding modalities. Results-based funding and financing, specifically for a region that performs better, maybe they'll get more fuel or more supplies. We talked about the public-private partnerships. It is quite key. We know that the private players, private individuals, actually some of them are actually as rich as government. And so if we leverage on that existing low-hanging fruit, we could be able to sustain funding for EMS. And of course, we talked about insurance. Though it has its shortfalls, maybe community-based health initiatives, insurance schemes could support that in a community. If someone falls sick, we have a sum fund that is available to support, transfer you from one's facility or move you from your home to the facility. That could be relevant to sustain EMS operations. Thank you.
Thank you. Good afternoon. First of all, my name is Simon Tumsime. I'm a medical doctor. I'm here on behalf of the president of the formerly Emergency Care Society of Uganda, currently Emergency Care Association of Uganda, and I'm happy to be here. I wanted to say, having been an intern when the project at Masaka started, I was an intern at Masaka, and I saw firsthand some of the work that Kofi has done, and I want to commend you for that. I think you've done an, great work, and I won't go back to that. But I wanted to say, mine is sort of, I have two questions. One is, you did mention this in your presentation, Mr. Pritchard, regarding the indicators that we use to assess EMS, you know? And I know most of people here have been talking about it, and I would like for you to comment on that and any progress that we have made, Mr. Pritchard and Dr. Oumo. The reason for saying that is that we know that maternal health, the reason that maternal health has advanced very well is that there are very clear indicators. Once you do something, you know that there is measurable impact. And that has been easy to communicate across the country, to get people to be involved, but also to get partners. The challenge that I know firsthand is that we have, and it's not just Uganda, but it's global, but the challenge is isolating the indicators that we can relate to the activities that we have done. I've noticed that a lot of the data you presented is qualitative. Now, qualitative is good, but we need quantitative as well. So would you kindly speak about the indicators and if there are any ideas that you've thought about to incorporate in the second phase of the project? Because I'm also thinking about this in the context of this could as well have been research that could have been published, because the lessons that you've learned through the initial implementation, the project in Masaka was not just one of the first in Uganda, it is also one of the first in East Africa and in Africa to focus on EMS in very many countries. So that could have, those could have been lessons that could have been learned. So could you talk about that and whether you're thinking about incorporating those aspects into research, you know, going forward? The second question is sustainable training. I know that many organizations in this country focus on teaching the trainings that you've talked about, BEC, ALS, post education, most people within the field. Now, I know that that's important, but that means that every year we know that the medical doctors that graduate, nurses that graduate, EMTs that graduate, and they still come out clueless about emergency care training. Now, that is very expensive if our goal is to focus on only training people who are finished, because we'll never get there if we still have a hole within the academic institutions. What is the plan in incorporating these trainings within existing medical programs? If you do a survey across all institutions, academic institutions, you'll find that medical students, doctors, nurses, all healthcare workers still leave education programs very clueless about emergency care training, skills, and knowledge. So have we thought about that, and can we partner with academic institutions to try and target that hole so that as we try to bridge this gap within existing healthcare providers, we also try and plug that hole for people coming out of the programs? Those are my two questions. Thank you.
Thank you, Dr. Simon, for those questions. So you talked about the indicators that we use to assess EMS. So when you go into DHIS2, we have about 5 indicators to assess EMS. And we have emergency attendance, the emergency unit attendance. We have scene care. We have arrival by ambulance. We have care within 1 hour of arrival at the emergency unit. Then we have death at the emergency unit. So we had some other indicators, for example, in triage and some other areas. We had a discussion in the first EMS stakeholders meeting, which was convened by Ms. Maria, and especially the first one. We had that concern of indicators. And I remember that Dr. Imi from Enable said if we all bring these indicators into the DHIS2, the system will be overwhelmed. So she, according to the guidance that came through, was to have a conversation together and we see what are the key indicators that we need in order to measure the performance in emergency medical services at a national level. So that is what was guided, and Dr. JB knows that. I think if Madame Maria was still in ministry, I know she was really following up on this one, but unfortunately we lost her. But I hope Dr. Marion can pick up on it and we move forward. So what I can say is that the discussion has been ongoing. Good enough, Dr. Omo is here, and he's quite handy. So I believe we can do something with Dr. Omo and Dr. JB. So regarding research, our new direction is so much into research now, because why should we not document the values that we are creating? If we have any data, by the way, in my PPT, I didn't only have qualitative data, I also presented the quantitative data. Then Dr. Atwaire can attest to this. He's going to, we have funded these projects, and he's going to do some research publications in top tier journals. So that is now the direction we are taking. We are trying to make sure that we disseminate, we validate and disseminate all our findings with all, for us to create the values that we, for us to share the values that we are creating. Regarding sustainable training, one of the sustainable ways that we are trying to ensure that the trainings are valuable is through e-contents. I know this is not answering you, I'm going to answer your question. It's through e-contents, because with e-contents we can leverage technology and ensure that we also build on efficiency in terms of cutting costs. If we have a platform where we put material where health workers can access at any one moment in time, we can bypass the refresher trainings, and health workers can, use technology, and then we can cover more with our budgets. So regarding the trainings being incorporated into the mainstream medical programs, Dr. JB has been trying to, SEED Global is so much into education for health workers, especially in EMS, and so is Malteser. We haven't been really so much into education of health workers at in respect to EMS for high-level programs like masters. We tried to bring it in our second phase, but we eventually brought it out, and we said we shall be perhaps bringing in consultants from Korea, or sending health workers for master's programs in Korea. But still we are having a conversation with Dr. JB. He says we need to have Ministry of Education on board as well to see how that can be managed. I think I've answered your questions. Thank you.
Right, thank you so much. Yes, the indicators have been incorporated in DHIS2, and there's a lot of work that we've done on indicators. Like Pritchard has mentioned, there are 5, there are 7 actually, and all of them support monitoring and evaluation of EMS across the country. And work is still going on, some discussions, and specifically on hospital care is something that we're not assessing fully. And then we hope that we have output indicators. Most of our indicators concern has been, some of them are process indicators, and it becomes an issue. Output impact, not yet clear for our space. Together with who we can discuss together. The incorporation of training into the curriculum is something that is planned. It's a strategic direction. We hope that we'll be able to achieve this, including first aid in primary and secondary schools, and something that is targeted and we should be able to achieve in the near future. Thank you.
Thank you so much. Dr. Mary has a response to one of the questions.
Yes, thank you. I just wanted to touch on the idea of the training and getting out the idea and the notion of emergency medicine. I just wanted to say very quickly that both at the, Imbarara and Makere, both of which have a Master's of Emergency Medicine program, the emergency medicine interest groups have been formed for the medical students, and they have been shockingly successful. Like hundreds of students have joined these interest groups and regularly attend any number of workshops, whether it's an EKG workshop or a hands-on resuscitative thing. Some of them are journal clubs. Really, I think that it's such an incredible resource, our medical students who are out there, because at that point in their training, they're still so hungry and so eager to learn all of that clinical knowledge. And one of the questions that we've been dealing with, which is how to get, emergency care out everywhere, that intern system is already in place. If we can get to students while they're concentrated in our various medical schools, they're about to be sent out all over the country to be doing, hands-on care as interns. And so I think that's an incredible resource that we could develop interest groups and workshops around emergency care training for our medical students, particularly in their, last couple of years, both to get the word out and to get the literal hands-on training before they're disseminated out to the various hospitals as interns. Just a thought.
Thank you so much. I think I love this discussion. People are really eager to. Let me allow comment and then a question that was coming from this table.
Yes, we do have masters in emergency medicine, as Dr. Mary has said. And the students are there, but I don't know whether after they finish, whether we have positions for them, because otherwise they will be disappointed. So I think as a ministry, we need to work faster to ensure that in the staff norms in our facilities, especially general hospitals, health center for those positions are there, so that when they come, they are associate consultants in emergency medicine. And I think that is within our reach. Otherwise, the education has gone a step faster. They have emergency medicine in the medical schools now, and we are going to have specialists. I think we have critical nurses. I don't know where they are trained from, but they are critical care nurses, and some are going to be disappointed unless we have positions for them. That's just not a question, but a comment.
I'm stealing the microphone. Oh, thank you very much. So my name is Zimbabwe. I represent Uganda Health Institute, and my question goes to Mr. Kavuma. So after winding up your project in Masaka, have you gone back to do some sort of impact assessment to see whether the good work that you did there is still ongoing, or whether you created lasting impressions on the local teams? Are the local teams able to carry on with the good work that you started, or they have reverted back to their old setting? Thank you.
Let's have questions, and then you answer them at once.
Thank you very much. I have a few questions for Mr. Pritchard and maybe Dr. Omo. And one of the questions you mentioned about, and it is true, you supported the development of the call center at Masaka. And now that they have been using a very long number, which has been very hard for the community, and now that Dr. Omo has talked about the introduction of 912, how is Coffee ready to integrate the 912 within the Masaka call and dispatch? And also, how has been the human resource models that you have implemented in Masaka call and dispatch that Minister of Health can learn from, to make sure in abundance of lack of resources, we can have the other call centers staffed? And also, what are the lessons you have learned that Ministry can learn from training the CFAs, the community members, linking them with the ambulance system? How have they helped, and how have they been able to work together with the ambulance teams? Then Dr. Omo, we've talked about the successes of pre-referral notification. What is government think about supporting facilities with the communication systems to make sure there are known non-personalized contact numbers where the ambulance teams and the doctors who are referring can always call and interact with their colleagues before they refer for the better care? Thank you.
Hello. This is for Dr. Mary Ellen. A bit of background. Dr. Mary Ellen is actually, I would say, a hero for Uganda. And I say this not lightly, because during the Ebola outbreak in 2022, 2023, I was the Ebola task force lead for Mulago Hospital. And I just remember how she would tirelessly come into the emergency room, come into the holding area. She was so involved, and she would be even to the point of using her own resources to support us, me and Justice, as we were doing some of this work. But my question is, Mary Ellen, I really want you to share, when I was young physician just starting in Chirudu, there was an amazing impact that they had. This is about advanced training. Dr. Mary Ellen and Dr. Kalanzi came into my emergency room and kept talking about the WHO triage tool. So in my mind, you know, when you're the emergency head doctor, you have so many issues going on. Isn't Dr. Mona? So you're thinking yourself, hey, this is a headache. This is a great idea, but when are we going to do it? So one afternoon, they came in, her and Dr. Kalanzi, I showed them the areas I had. They designated a green area, a yellow zone, and a red zone for my oxygen and patients. They printed out the labels, they attached them, and the Chirudu emergency was transformed forever. They've done similar work in the resuscitation area in Mulago, taking it from an area which was disregarded, or nobody wanted to work in the resuscitation area. Now it's one of the most vibrant areas in Mulago. So Mary Ellen, I want you to share with Kofi and Preacher, their representative, and Dr. Oumo. You said that in Uganda we have a lot of resources, and it is true. This was already a built space in Chirudu, and all we did was reverse its functionality. I think we didn't even have a budget, with limited budget, okay? And then Malteser supported us in Chirudu to provide the monitors, but we did the groundwork of converting our emergency room into a triaged area. So, Marianne, I would ask you to share that, just a little bit of how that transformation was done in 2 or 3 steps, so that the funders can also know and the government can know that these public hospital spaces and even private hospital spaces can be converted with very little funding into functional areas with the right medical team.
Thank you.
Thank you very much for the wonderful presentations. Just a comment for Dr. Joseph. You talked about the ambulances, type B and type C. So I was specifically interested. What I know is we have probably like 130 districts. So almost in every district, there are almost 2 politicians who have ambulances. What is that number? Do we have like 1,000 ambulances in total? And then maybe this is the proportion. It would be nice to know if there is that number. Then secondly, for the ambulances that we have, I do not know if you have begun measuring the distribution. I've been asking one of the project managers who does work around the region how ambulances have supported them for emergency care. So do you have any estimates on the distribution of the ambulances? You said they're about 303, type B, which is roughly 313. So how distributed are they, and how effective have they been? For the team in Masaka, I do not know if you have used some of them. I don't know how many of them are working for you. How effective has it been, maybe using your reporting system, and then also versus places where we don't have a dispatch center, looking at the referral pathways? I think those are my main 2 comments. Thank you.
This discussion is what we wanted. We wanted this kind of input. Richard, what have you given people?
Thank you so much, our presenters. Maybe mine is a simple one to Dr. Joseph Oumo. We have seen some MPs giving out substandardized ambulances. Do you have any say on that? Last time in my constituency, we got an IPSAM as an ambulance. Then to Pritchard, we do acknowledge that you receive very many proposals and there are very few slots available. I've said this before, but I don't see any change. Do you mind giving out feedback if my project has not gone through like that communication, kind of communication? It may be an email form, in an email form, or having a, like maybe another form that stipulates why you did not consider my feedback, because it demotivates. We have sleepless nights writing, by the end of it all, you don't receive any feedback. Thank you.
Thank you, presenters. My small question goes to Dr. Joseph. You mentioned that in terms of trauma burden in Uganda, Busoga and Teso regions bear the lowest cases, but the highest mortality rates. What could be some of these reasons causing such disparities? Thank you.
So I think to do good, let's start with an online person. Can you put the online doctor, Mary, to answer her question from Dr. Rukoma, and then we remain with our local people here.
Certainly, and I certainly remember that as well, Dr. Lakoma there at Chirudu. And it's actually another example of what I was trying to get at also with Dr. Imran in Katakwe, which is that an amazing difference can be made in the quality of care we're able to offer our emergency patients with our existing resources, right? It's a matter of organizing them a certain way. The first thing we did in Chirudu was to look around, and there was oxygen on one wall, and decide, okay, that's the resuscitation bay. The sickest two patients go there, right? And then, as you say, we had sections for the most well patients, the sickest patients, the ones in between, and then we set up a triage area. And it was, without exaggeration, done in an afternoon. A few of the first-year emergency medicine residents and I were there, and we did it in an afternoon. It's just a matter of rearranging what's already there to give the best care, and that is exactly, in large part, what Dr. Imran started with in Katakwe. He looked around at what was available, and then out of the advanced training that he has, he was able to arrange things in a way to give the next level of care, right? To prioritize triage, so you know who needs the care right away, and then to organize each of the wards so that you were able to focus on the sickest patients in order. And I think that's exactly what can be done, again, with the existing resources, if we can put the right person, sort of seed, if you will, the correct person in each of these units. If we can get our trained young doctors into these emergency care units to begin to get that. And then once you've sorted things, once you're organized, then you can look around and realize, you know, what we really, really need is an ultrasound probe, or what we really need is an EKG machine. You know, only once you've maximized the use of your current resources can you really decide what your most pressing need is. And then you go to the partners maybe, or you go to the MOH, whatever it is, and you know, begin to look for your next need. But I really feel very strongly that we're at the moment in so many areas not taking best advantage of what we already have, because we haven't taken this amazing training that we've fostered and put it in the environment where it can really grow and maximize the benefit to our patients.
Thank you so much, Mary. Thank you for that wonderful explanation.
Thank you, Dr. Atwairi. So there is a question from Dr. Mbabazi from Uganda Heart Institute, and she's inquiring whether we've carried out an impact assessment after the implementation of our first phase. What I can say is that after our first phase, we had a team of consultants that was constituted from the Republic of Korea and locally to do an assessment. And that assessment, the findings from the assessment are informing the second phase of the project. But I can also say that we, immediately after the end of the EMS project, we designated one of the officers to remain there just to monitor on the values that had been created in the entire region. So he's just there to troubleshoot at any time, much as there may be no budget for example, repairing of ambulances, but at least he will reach out to Dr. Marion and they work together. They liaise. If they've run out of fuel, he does the same. So he's trying to, and every month he gives us a report on the progress as we move towards the second phase next year. Mr. Denise, you talked about the 912. Our second phase speaks to the integration of 912 and also promoting the uptake and use of that short code. It's incorporated in there. Then the human resource models. So what I can say, we don't have human resource models for coffee that are used in the call and dispatch system. But what I can say is that ministry is taking lead and we are side by side. So it's the ministry's human resource model that we are following. In case there may be some gaps that are identified, we can make recommendations and we can troubleshoot collectively to do better. Then regarding the community first aid responders, that is the VHTs, training them in community first aid response. We have, after our EMS project, towards the end of our EMS project, we were fortunate to have the community health workers project, which is also being implemented in the same region. So in the community health workers project, we were building capacity of community health workers, providing them with both medical and non-medical tools to do their work, but also building the capacity. We noticed that government has really focused mainly on ICCM, but we brought in the components based on the guidance of the Permanent Secretary, Minister of Health. We brought in the component of communicable and non-communicable diseases, and it also had the component of surveillance for these infectious diseases, but also community first aid response for the VHTs. So the Community Health Workers Project has a component of building capacity of VHTs in community first aid response. So in that way, we are synergizing with our projects. Then, was it Dr. Jetho? Okay. There was a question that came through regarding the proposals. Our proposals, well, we have a few slots available, and some people don't get feedback. What I can say is that our mode of funding is government to government. Even if someone has a proposal, they must find a government ministry or agency that they align into in order to be funded. But COFI does not fund NGOs, COFI does not fund in maybe the private sector. But there is a project which was developed by different projects that came through from WHO, UNICEF, and we did a feasibility study this year with the UNICEF project. It's on primary health care and digitalization. And this project has a portfolio of $20 million, but still UNICEF was guided to align into ministry, such that Ministry of Health can take lead. So that's how it was. But I can say that our funding mechanism takes a very long time. So sometimes you may have to wait for 2 years before you get a response. Because when you submit a proposal, we collectively review, then we submit to our headquarter for pre-selection. Once our headquarter has pre-selected, they will send a team to carry out a feasibility study. But when they send a team to carry out a feasibility study, then chances are high that your project is going to be funded.
Recording in progress.
We don't have any project that has had a feasibility study that has not been funded before. That's why we think even the UNICEF project is going to be funded, because a feasibility study was carried out this year. Now, after the feasibility study, recommendations are made, and actually the Ministry of Finance has to submit the proposal to our embassy. Then the embassy will submit to Foreign Affairs of Korea. There is an internal review by the DAC committee. Then they have to get a certificate of financial implication. Then there is a formative study that is carried out. So it's a long process, but between that application and approval, it takes about 2 years. But whenever we get feedback, we usually get back to the applicants. I don't know why you haven't been able to receive a response, but we usually get back to the applicants. It's only the KGA fellows who, upon return, we always have a designated budget for their projects, which is to the tune of about $100,000 every year. And these ones, when our fellows apply, the response can be in a month's time. Within a month, we have completed. Even implementation can go for a maximum of 3 months. So the KGA program is unique. For example, there was a time we gave the whole $100,000 to Masaka. The Masaka project, they did a very good concept, and they implemented it, I think maybe in about 2 weeks or three. Then there was the Tutata, there was the 717. Now we have various projects by Dr. Atuhaire, we have Regina, then we have this one by Beatrice. So when you apply, I encourage you to come up with good concepts. When you apply, you'll be getting a response when it comes to the KGA.
Right, thank you. Commissioner, the EM positions are actually there in the new structure. And we have positions for emergency care assistants, emergency medical technicians from as low as Health Center 3. There's emergency care nurse for level 3. Yes, pre-referral notification, it's the infrastructure. We're leveraging on infrastructure that was shared, that has been around, especially in regional referrals and general hospitals, especially from our partners, WHO, there is one from JPIGO, and some infrastructure that has been distributed by SID Global, some of the partners. So this infrastructure is what we're going to use. In the meantime, it is in plan to have these communication systems available to facilities as well. The ambulances, yes, the issue with politician ambulances, one, it is now a mandate, it's now a requirement for you to register an ambulance that you meet the norms and standards as set by Ministry of Health. So for you to procure an ambulance, you must submit it for inspection. And after inspection, they recommend it to be registered as a type B, type A, or type C. The shortfall to that is that we do not have a regulation that requires everyone to actually have the ambulance registered. So some people can come, like you said, someone said Ipsum as an ambulance. Some people can come and go to a garage and label it. And there is not much as per now. The law does not have, we do not have a law that can say this is not right for now. But the directive from the president's, from cabinet, is that we're going to leverage on the Road and Traffic and Road Safety Act. And they have directed, I mentioned earlier on that we have been mandated to do census of all ambulances in the country. and recommend that some are deregistered using the Road and Safety, Traffic and Road Safety Act. That we rely on that because there is provision for emergency vehicles in that act. So we rely on that so that we're able to recommend that these ambulances should be deregistered, these are kept, or these are discarded for that matter. So this is supposed to be done as soon as possible, and we'll be able to inform you on that. In terms of distribution, ambulances are strategically placed to serve the population, okay? So the government distributes ambulances across the country. We are saying they are strategically placed as chosen by the stakeholders. So if we're saying we're putting ambulance in, say, Busia municipality, the stakeholders there will choose the best location where these ambulances can be strategically placed and it serves its population. And then this can be a health center, it can be a hospital, it can be a police station. And this is kept in our record. So we have distribution lists and we have locations of these ambulances, and we're going a step further to have GPS trackers put in these ambulances, and we're able to monitor where it is. And this system is in advanced stage together with the call and dispatch system. The other week, we're in the call center and we're able to track, there was an ambulance that was attached to the presidential convoy, and we're able to know that it moved from Kampala through Fort Portal and ended up in Kisoro. So it's possible to know where the ambulances are now and distribution for that matter. Effective service will also be based on this. The call and dispatch system will tell us that we have allocated this ambulance 2 million of fuel, and it is transported, say, it has moved 0 distance, for example, because of the tracker. And then we're able to say, why hasn't it moved the patient for that matter? And so the effective service will then be also catered for that specific purpose. So in terms of trauma, I think they are not good explanations. What I can say is that, yes, the burden is low, but facilities, for example, Soroti does not even, until last week or the other week, does not have an emergency unit, a regional referral, for example. It's something that was so terrible. Until last week, I think they shared pictures that they improvised some space. Busoga, for one reason or the other, the challenges with health seeking and association, I mean, choosing to use alternative cure or alternative routes of medical attention. But we might have to explore why this high mortality despite the low burden. Right, standardization, please. It is a requirement that for you to get an ambulance registered with us, you must meet the norms and standard. And we're leveraging on the Traffic and Road Safety Act. We should be able to regulate ambulance service henceforth. Thank you.
Thank you guys for answering these questions. And I think you can take your seats. And a hand clap. So I want to declare this session closed, and I want to thank Dr. Mary Online for her time. Yeah, Mary, thank you so much for reserving your time. I know it might even be at night that side, but thank you so much. We love you, Uganda. Uganda still loves you, and we can't wait to see you again here in Uganda. I want to declare this session closed, and I want to return the microphone to the organizers. I had seen someone with a face that showed that probably we should have lunch. So it's time for lunch. But first of all, I want to thank you for this session. It was the most engaging session. We got most questions. I've seen the IT person here. We've got a lot of engagement. So we're going to pray for our lunch. And after lunch, come back for the after lunch session. So can we humble ourselves for a short prayer? God, we want to thank you for this day. We want to thank you for the gift of life. We want to thank the organizers of this wonderful conference. And we hope that what we've learned is going to be translated into practice. We pray for that lunch so that it can refreshen us for the after lunch session. We pray through Jesus Christ our Lord. Amen.
Good morning once again. You're all welcome to this event that you've been looking forward to.
Yes, maternity, yes, exactly.
We've been preparing for you, and we hope that you will enjoy today, and we shall have meaningful discussions as far as the topic is concerned.
So this year, actually, we have, I myself created 3 frames. 3 frames. One is research, another one is mathematics, another one is just for copiers per facility.
Was founded in 2006 as the Commission of International Affairs. And this is
Usually, when you do such a project,
so coffee maintains 11 overseas offices, including the one in Uganda. We have a couple of offices in Uganda, also
we hand over.
and other things that is dealing with 11 countries. Currently, we have been able to move, and the biggest continent in the country right now is the National Development Plan 4, which is one of the Vision 2040 strategic areas. And in here we do exist. The first document which came out was the National
You use the same. Just scan it. You can use it still for today.
Whatever project that we do support is based on the dialogue between industry, practitioners, and coffee.
Trust me, tekagenda kuwa kubanga mabega kalina kozi ono w'emaaso yasoba kasolo baba bakolenda kulinatira kabwabuna.
Yeah, 4 is
We
much
talk
better.
about outcome measures, implementing projects such as infectious diseases,
The objective is safety and
project, the illness, cancer, and IV project,
Because I
and
know most
also
people
our
overfill them,
the
and I'm
other
yet
one
to see one.
is improve maternal, adolescent, and child health.
I'm not so sure.
Our analysis,
Okay,
we have seen that
help me to understand. So how do they, like let's say, where is it stationed? The facility?
Yes, the health center.
Then how does it go? Do they call the facility?
Yes.
Is the PhD who
I think
coordinates
they work
the
with,
process?
I think they work with the VHTs and what, because these are local, this is not top tier thing, this is at the local level. Or you can call, because more than likely, you're going to a place where you've been receiving your antenatal.
Yes,
Or
that's true.
or you could,
it could be a case like you're in labor and there's no one who can get you. Then it comes to a big issue.
The other person is staying. Otherwise, someone can come and bundle things.
More than likely, they've given them numbers to be able to call those facilities.
Oh, so it is for ladies who are ready.
It's for pregnant, yes. So you don't like walk because you know in these regions, people don't have cars.
They don't. They don't have cars.
In my village,
They don't have motorbikes.
if you do not have money for hiring a car, there's not a there's no bus.
Yes.
They either have a car.
Even the motorbike to come, you have to
So
call him earlier.
No, unless the motorbikes that are major means of transport. But these things of my taxi could you no. There's taxis that exist inside this street. So it's either an order, you walk, or you own a car, or you have the money to hire a special. Now,
That's
such a
expensive.
place. And that's not just for anybody which is not even deep in the village.
Yes, that's true.
Now, was again, you can't find it until I takes me from here to town. They said it doesn't exist.
Even in the business perspective, it is not effective to do a taxi within the village areas. However, it is effective to do like from Kampala to the village areas.
So the border guys make better
You're all
money.
welcome to this event. I think we're looking
Money
forward
just
to
get borders and take to the villages.
We've been preparing for you, and we hope that you will enjoy today, and we shall have meaningful discussions and as far as the topic is concerned.
So this year, actually, I myself have created three friends.
It's a restaurant.
Another one is the contest. Another one is restaurant. Coffee restaurant.
Coffee was founded in 2006 as a collaboration with National Nuclear, and it's a government agency affiliated to the Ministry of Health and the Republic of Korea. So Coffee maintains 11 overseas offices, including the one in Uganda. We have a country office in Uganda, and also in other 10 countries, making it 11 countries.
Currently, they have been able to move, and the biggest document in the country right now is the National Development Plan 4, which is one of the Vision 2040 strategic areas. And in here we do exist. The first document which came out was the National Development Plan 4, Cabinet Strategic Directive.
Whatever project that we do support is basically between industry or between the partners and has been here to implement quite a number of activities with a total of about 20 million implementing projects such as infectious diseases, capacity building, COVID-19 project, the EMS, cancer, and ID project, and also the WASH project.
The other one is improve maternal, adolescent, and child health. In our analysis, we have seen that there is a big contribution which we make in maternal health. About 60% of our interventions actually are on play 2. In 2019, you go to an accident at the emergency unit and you find yourself being attended to. So this is the reason why we came up with focusing ourselves to improving these areas.
Value for money, efficiency, sustainability. These three things need to be at top priority now going forward. These are the key implications for the funding cuts that we're seeing, not only in Uganda but also in the region.
So I really wish that this, Coffee Health Forum will be developed into a kind of at least East African global networking, where as a knowledge generator, especially a leading forums focusing on health, of course.
Good morning once again. You're all welcome to this event that we've been looking forward to. We've been preparing for you, and we hope that you will enjoy today, and we shall have meaningful discussions in as far as the topic is concerned.
So this year, actually, I myself created 3 pillars, 3 framework. One is research, another one is e-contents, another one is health forum, Coffee Health Forum.
Coffee was founded in 2006 as the Korea Foundation of International Health Care, and it's a government agency affiliated to the Ministry of Health in the Republic of Korea. So Coffee maintains 11 overseas offices, including the one of Uganda. We have a country office in Uganda and also in other 10 countries, making it 11 countries.
Currently, we have been able to move, and the biggest document in the country right now is the National Development Plan 4, which is one of the Vision 2040 strategic areas. And in here, we do exist. The first document which came out was the National Development Plan 4 Cabinet Strategic Directive.
Whatever project that we do support is based on the dialogue between ministry or between the partners and the Coffee. And has been here to implement quite a number of activities with a total of about 20 million, implementing projects such as infectious diseases, capacity building, what we call CHO project, the EMS, cancer, and ID project, and also the WASH project.
The other one, 8, is on improved maternal, adolescent, and child health. In our analysis, we have seen that there is a big contribution which we make in maternal health. About 60% of our interventions actually are on delay 2. In 2019, you go to an accident and emergency unit and you find yourself feeling inadequately being attended to. So this is the reason why we came up with focusing ourselves to improving these areas.
Value for money, efficiency, sustainability. These 3 things need to be a top priority now going forward. These are the key implications for the funding cuts that we're seeing, not only in Uganda but also in the region.
So I really wish that this, Coffee Health Forum will be developed into a kind of at least East African global networking, where as a knowledge generator, especially leading forums focusing on health, of course.
Good morning once again. You're all welcome to this event that we've been looking forward to. We've been preparing for you, and we hope that you will enjoy today, and we shall have meaningful discussions in as far as the topic is concerned.
So this year, actually, I myself created 3 pillars, three framework. One is research, another one is e-contents, another one is health forum, Coffee Health Forum.
Coffee was founded in 2006 as the Korea Foundation for International Healthcare, and it's a government agency affiliated to the Ministry of Health in the Republic of Korea. So Coffee maintains 11 overseas offices, including the one of Uganda. We have a country office in Uganda and also in other 10 countries, making it 11 countries.
Currently, we have been able to move, and the biggest document in the country right now is the National Development Plan 4, which is one of the Vision 2040 strategic areas. And in here we do exist. The first document which came out was the National Development Plan 4 Cabinet Strategic Directive.
Whatever project that we do support is based on the dialogue between ministry or between the partners and the Coffee, and has been here to implement quite a number of activities with a total of about 20 million, implementing projects such as the infectious diseases, capacity building, what we call CHU project, the EMS, cancer, and IED project, and also the WASH project.
The other one, 8, is on improved maternal, adolescent, and child health. In our analysis, we have seen that there is a big contribution which we make in maternal health. About 60% of our interventions actually are on delay 2. In 2019, you will go to an accident and emergency unit and you find yourself feeling inadequately being attended to. So this is the reason why we came up with focusing ourselves to improving these areas.
Value for money, efficiency, sustainability. These three things need to be a top priority now going forward. These are the key implications for the funding cuts that we're seeing, not only in Uganda but also in the region.
So I really wish that this, Coffee Health Forum will be developed into a kind of at least East African global networking, where as a knowledge generator, especially leading forums focusing on health, of course.
In Uganda, access to quality emergency care can mean the difference between life and death. To strengthen emergency medical services, the Kga Foundation for International Healthcare, KOFI, in collaboration with the Ministry of Health, launched a transformative pilot project in the districts of Masaka and Bukomansimbi.
KOFI, Korean Foundation for International Healthcare, is a public agency under the Ministry of Health and Welfare of the Republic of Korea. KOFI supports government-level health assistance to the partner countries, including Uganda.
So the project focused mainly on 5 intervention areas, and these are leadership and governance, infrastructure development, emergency equipment, capacity building of health workers, and strengthening the referral system from community to regional levels.
One of the key pillars of this initiative was strengthening leadership and governance. Project committees were established.
We have been able to see the development of emergency care protocols.
Regional stakeholders came together to create a coordinated approach to emergency services. Leadership training was also extended internationally, with Ugandan officials receiving specialized training in South Korea. Improving infrastructure was central to the project.
Maternity department got a new maternity ward.
New regional skill and simulation labs. A call In Uganda, access to quality emergency care can mean the difference between life and death. To strengthen emergency medical services, the Kga Foundation for International Healthcare, KOFI, in collaboration with the Ministry of Health, launched a transformative pilot project in the districts of Masaka and Bukomansimbi.
KOFI, Korean Foundation for International Healthcare, is a public agency under the Ministry of Health and Welfare of the Republic of Korea. KOFI supports government-level health assistance to the partner countries, including Uganda.
So the project focused mainly on 5 intervention areas, and these are leadership and governance, infrastructure development, emergency equipment, capacity building of health workers, and strengthening the referral system from community to regional levels.
One of the key pillars of this initiative was strengthening leadership and governance. Project committees were established.
We have been able to see the development of emergency care protocols.
Regional stakeholders came together to create a coordinated approach to emergency services. Leadership training was also extended internationally, with Ugandan officials receiving specialized training in South Korea. Improving infrastructure was central to the project.
Maternity department got a new maternity ward.
New regional skill and simulation labs, a call and dispatch center, and upgraded emergency units, including operating theaters, surgical wards, and neonatal units, were built to support effective care in Masaka and Butenga. Advanced emergency equipment, including 4 new ambulances, X-ray machines, and point-of-care ultrasound scanners, were introduced to ensure that health workers have the tools they need to provide life-saving interventions.
New operating light we are currently using during operations. Modern X-ray machine, which is in place, and on a daily basis we are able to do over 100 X-rays.
To build human capacity, Health workforce training was done at the national level in the Ministry of Health, the regional level at Masaka Regional Referral Hospital, and the community level, empowering them to respond swiftly and effectively to emergencies.
The project has enabled us to train 1,700 health workers in courses ranging from advanced life support to basic life support, basic emergency care. We've also trained the regional ambulance drivers on how to deliver emergency care services.
508 VHTs were trained in CIFA, Community First Aid Responder course.
So this is a system that's responsible for providing care for people that have had sudden illnesses or injuries and need emergency care. All right, so this comprises of care that is provided on the scene. So when someone gets an injury or sudden illness, that can be in the community, on the roads, in the workplace, to care that happens when you're being transported from that point to the hospital. This is care that's provided by trained professionals who work on ambulances, ultimately to care that is provided in the hospital, the acute care point or the emergency unit, as some hospitals have it termed.
To improve emergency referrals, a new call and dispatch center was established. It coordinates the emergency units with ambulance teams and community responders in real time, ensuring that patients receive timely, continuous care from the scene through transportation and the emergency department. At the hospital, trained staff triage, resuscitate and stabilize patients before they receive definitive care. This comprehensive system has led to a dramatic increase in emergency room attendance, with over 25,000 patients treated annually. Today, 98% of patients are triaged on time, and 100% are attended to within an hour. The Coffee Project has strengthened emergency care, reduced deaths, and saved countless lives.
Nifunako enamba ya ambulance nenjikubira era tebalwawo ne bajja ne bamutwala netutukira ku emergency ne bamukolako ne bamuzanjaba n'atereera. Mwebale nnyo, mwebalire ddala ab'ekitongole kya Coffee.
Mine would be expression of gratitude.
They are so much grateful. They have never seen people who have good hearts like the Koreans.
I just want to appreciate Coffee, especially the emergency medicine project, to identify the critical need and addressing it without conditions, but identifying with us our need and addressing it has been the cornerstone of the success.
This successful project, therefore, awaits being scaled up across the country. In Uganda, access to quality emergency care can mean the difference between life and death. To strengthen emergency medical services, the Kga Foundation for International Healthcare, COFI, in collaboration with the Ministry of Health, launched a transformative pilot project in the districts of Masaka and Bukomansimbi.
COFI, Korean Foundation for International Healthcare, is a public agency under the Ministry of Health and Welfare of the Republic of Korea. COFI supports government-level health assistance to the partner countries, including Uganda.
So the project focused mainly on 5 intervention areas, and these are leadership and governance, infrastructure development, emergency equipment, capacity building of health workers, and strengthening the referral system from community to regional levels.
One of the key pillars of this initiative was strengthening leadership and governance. Project committees were established
We have been able to see the development of emergency care protocols.
Regional stakeholders came together to create a coordinated approach to emergency services. Leadership training was also extended internationally, with Ugandan officials receiving specialized training in South Korea. Improving infrastructure was central to the project.
Maternity department got a new maternity ward.
New regional skill and simulation labs, a call and dispatch center, and upgraded emergency units, including operating theaters, surgical wards, and neonatal units, were built to support effective care in Masaka and Butenga. Advanced emergency equipment, including 4 new ambulances, X-ray machines, and point-of-care ultrasound scanners, were introduced to ensure that health workers have the tools they need to provide life-saving interventions.
New operating light we are currently using during operations. Modern X-ray machine, which is in place, and on a daily basis we are able to do over 100 X-rays.
To build human capacity, health workforce training was done at the national level in the Ministry of Health, the regional level at Masaka Regional Referral Hospital, and the community level, empowering them to respond swiftly and effectively to emergencies.
The project has enabled us to train 1,700 health workers in courses ranging from advanced life support to basic life support, basic emergency care. We've also trained the regional ambulance drivers on how to deliver emergency care services.
508 VHTs were trained in CFA, Community First Aid Responder course.
So this is a system that's responsible for providing care for people that have had sudden illnesses or injuries and need emergency care. All right, so this comprises of care that is provided on the scene. So when someone gets an injury or sudden illness, that can be in the community, on the roads, in the workplace, to care that happens when you're being transported from that point to the hospital. This is care that's provided by trained professionals who work on ambulances, ultimately to care that is provided in the hospital, okay, the acute care point or the emergency unit, as some hospitals have it termed.
To improve emergency referrals, a new call and dispatch center was established. It coordinates the emergency units with ambulance teams and community responders in real time, ensuring that patients receive timely, continuous care from the scene through transportation and the emergency department. At the hospital, trained staff triage, resuscitate and stabilize patients before they receive definitive care. This comprehensive system has led to a dramatic increase in emergency room attendance, with over 25,000 patients treated annually. Today, 98% of patients are triaged on time, and 100% are attended to within an hour. The Coffee Project has strengthened emergency care, reduced deaths, and saved countless lives.
Nifunako enamba ya ambulance nenjikubira era tebalwawo ne bajja ne bamutwala netutukira ku emergency ne bamukolako ne bamuzanjaba n'atereera. Mwebale nnyo, mwebalire ddala ab'ekitongole kya Coffee.
Mine would be expression of gratitude.
They are so much grateful. We have never seen people who have good hearts like the Koreans.
I just want to appreciate Coffee, especially the emergency medicine project, to identify the critical need and addressing it without conditions, but identifying with us our need and addressing it has been the cornerstone of the success.
This successful project, therefore, awaits being scaled up across the country. In Uganda, access to quality emergency care can mean the difference between life and death. To strengthen emergency medical services, the Kga Foundation for International Healthcare, KOFI, in collaboration with the Ministry of Health, launched a transformative pilot project in the districts of Masaka and Bukomansimbi.
KOFI, Korean Foundation for International Healthcare, is a public agency under the Ministry of Health and Welfare of the Republic of Korea. KOFI supports government-level health assistance to the partner countries, including Uganda.
So the project focused mainly on 5 intervention areas.
Good morning once again. You're all welcome to this event that we've been looking forward to. We've been preparing for you, and we hope that you will enjoy today, and we shall have meaningful discussions in as far as the topic is concerned.
So this year, actually, I myself created 3 pillars, 3 framework. One is research, another one is e-contents, another one is health forum, KOFI Health Forum.
KOFI was founded in 2006 as the Korea Foundation for International Healthcare, and it's a government agency affiliated to the Ministry of Health in the Republic of Korea. So KOFI maintains 11 overseas offices, including the one of Uganda. We have a country office in Uganda and also in other 10 countries, making it 11 countries.
Currently, we have been able to move, and the biggest document in the country right now is the National Development Plan 4, which is one of the Vision 2040 strategic areas. And in here, we do exist. The first document which came out was the National Development Plan 4 Cabinet Strategic Directive.
Whatever project that we do support is based on the dialogue between ministry or between the partners and the KOFI, and has been here to implement quite a number of activities with a total of about 20 million, implementing projects such as the infectious diseases, capacity building, what we call CHU project, the EMS, cancer, and IED project, and also the WASH project.
The other one, 8, is on improved maternal, adolescent, and child health. In our analysis, we have seen that there is a big contribution which we make in maternal health. About 60% of our interventions actually are on delay 2. In 2019, you will go to an accident and emergency unit and you find yourself feeling inadequately being attended to. So this is the reason why we came up with focusing ourselves to improving these areas.
Value for money, efficiency, sustainability. These 3 things need to be a top priority now going forward. These are the key implications for the funding cuts that we're seeing, not only in Uganda, but also in the region.
So I really wish that this, KOFI Health Forum will be developed into a kind of at least East African global networking, where as a knowledge generator, especially leading forums focusing on health, of course.
In Uganda, access to quality emergency care can mean the difference between life and death. To strengthen emergency medical services, the Korea Foundation for International Healthcare, KOFI, in collaboration with the Ministry of Health, launched a transformative pilot project in the districts of Masaka and Bukomansimbi.
KOFI, Korean Foundation for International Healthcare, is a public agency under the Ministry of Health and Welfare of the Republic of Korea. KOFI supports government-level health assistance to the partner countries, including Uganda.
So the project focused mainly on 5 intervention areas, and these are leadership and governance, infrastructure development, emergency equipment, capacity building of health workers, and strengthening the referral system from community to regional levels.
One of the key pillars of this initiative was strengthening leadership and governance. Project committees were established.
We have been able to see the development of emergency care protocols.
Regional stakeholders came together to create a coordinated approach to emergency services. Leadership training was also extended internationally.
He is trying to save the life of these patients.
This program is to get knowledge and skill on infectious disease. As my expectation, I have gained a lot of skill and knowledge.
After this course, I hope I will bring back a lot of skill, experience to share with my colleagues in my nation country.
이종 펠로십 프로그램은 한국인 최초로 WHO 국제기구 수장으로서 선출되신 고 이종욱 박사님의 국제보건 인력 양성의 뜻을 기리고자 만들어진 프로그램입니다. (2007년부터 2021년까지) 이종욱 펠로십 프로그램을 통해서 총 30개국 1,147명의 국제보건의료 인력이 양성되었습니다.
Vulnerable to various diseases changed the great framework of global public health. I want to learn his thoughtful intention from this program.
이종욱 펠로십 프로그램은 전 세계 연수생들에게 임상, 보건정책, 의공, 보건인력교육, 최고의 감염병 대응 등의 6개의 전문 분야뿐 아니라 간호학, 기초의학, 교원양성, 보건정책학, 의공학, 의학교육학 등의 학위과정을 제공하고 있습니다.
ពីបញ្ហាអ្នកជំងឺរបួសឆ្អឹងខ្នងនិងជំងឺបញ្ហាដាច់សរសៃឈាមខួរក្បាលនេះចែករំលែកដល់អ្នកព្យាបាលដែលចលនានៅប្រទេសកម្ពុជានិងគោលបំណងដ៏សំខាន់គឺផ្ដល់នូវការព្យាបាលដែលប្រកបដោយគុណភាពចំពោះប្រជាជនរបស់ខ្ញុំដែលមានបញ្ហារបួសខួរឆ្អឹងខ្នង
That felt as a great opportunity for me to participate in the Lee Jong-wook program because I can learn more about Korean medical technology, especially in NRC, and also the rehabilitation, which enhances patient independency.
이종욱 펠로십 수료생들이 향상된 역량으로 자국에 돌아가 연수 과정에서 축적한 경험과 기술을 현지에서 효과적으로 적용하고 공유, 전파할 수 있도록 한국의 전문가들과 협력하여 학술 교류, 공동 연구 등을 실천하고 있습니다. 이에 연수생들은 12개 해외 협력국에서 코피 글로벌 연수생 동문회 KGA를 결성하여 서로의 경험을 공유하고 지식을 전파하며 자국의 보건 분야 발전에 기여하고 있습니다.
I wish you all the best of stay in Korea. It has helped me to manage infectious diseases and other diseases in the country. And I hope your stay will help you to steady and make your country proud. 감사합니다.
Through a memorandum of understanding, the Korea Foundation for International Healthcare, KOFI, working closely with the Office of the Prime Minister, joined hands with the Busoga Health Forum, Jinja City, Iganga District Government, Jinja Regional Referral, and Iganga General Hospital. Together, they launched the Busoga Region Wash Project, designed to reduce the burden of waterborne diseases and improve sanitation and hygiene across Busoga region. Before breaking the ground, the project started with knowledge. A team of researchers were recruited, trained and deployed, collected crucial baseline data from communities of Jinja and Iganga.
My name is Sang Won-jung. I'm working as a senior advisor and health program specialist in Coffee Uganda office based in Kampala. For coffee, this is the first of its kind in this type of the intervention. First, we don't have any partnership program with the Busoga region, including Jinja and Iganga, where I think there is the most important, one of the important strategic locations. Second, we don't have, coffee doesn't have any wash project. So this is also the first kind. Also, coffee doesn't have any direct intervention project. From that perspective, this is also first kind. Well, in the previous time, or now even, we have been partnering with the Ministry of Health, and we are supporting through the Ministry of Health. We don't have any this kind of project, directly managing and implementing the project.
So how would you describe the overall impact of this project that has had the community of Iganga and Jinja?
We believe this is a kind of a small project as compared to the normal coffee project. This is not, to be very frank, it's not that much big. But because since we started a new project, we want to do it very innovative way with the innovative approaches. So I think that I believe that it will create some kind of synergistic effect, whereby we want to give some very meaningful impact on the community by showing them. I think that there is, especially I want to focus more activities on the awareness on the hand wash, and also the importance of the waterborne diseases, also importance of the environment in general through this project.
So what does coffee see as the most successful or transformative outcome that this project has brought so far, or that it's bringing?
As I already mentioned, this is on ours. It is a very new project based on new concept. So at the moment, up to today, already we have implemented a key stakeholders meeting in Jinja 2 months ago. Also, we signed an agreement with the Prime Minister's office. Also, this is also our new initiative, and then we already signed the agreement. And in Iganga and in Jinja, we are trying to make signing that MOUs. Actually, to be very frank, signing MOUs and contract 9 in total. So I think that by this signing, we can say that now all the shared responsibility has been defined, and we know all the schedules, what we are targeting it. So I think this is a very important progress.
Yes, you have talked about the local partnerships and signing of MOUs. How has these partnerships between coffee and local authorities, the communities, contributing and also being a unique way of implementing this WASH project?
I think this is that joint project actually between Coffee Uganda and the local government. We entrust this important, networking with the community and even coordination to the Busoga Health Forum and the local government, Iganga local government, as well as the Jinja city. So we don't see only that, and then we also want to, through the monitoring and the evaluation process, we want to also expand our opportunity to interfacing with the community directly. One of the most uniqueness in my approach is that I can say there are so many, but if I name one thing, I want to focus on the importance of the e-contents development. People used to focusing on traditional training, but I want to make some online and offline kind of combined methodology. From this perspective, I have invested a lot of our resources in developing e-contents, also to bring up very unique e-contents where you can use this one e-contents after its development as educational tools, and then which includes some even washy song, even washy dancing. And then And then we also know the importance of the delivery skills. So we'll also select champion presenters. And then through these champion presenters, the best champion presenters, plus the best education materials, we'll disseminate through using this strong tools. I think this is one of the important. And then also, I would request OPM, Office of the Prime Minister Office, can be intervened and supporting us in disseminating at national level using the developed e-contents. I think that's so that the impacts will not only limited to Busoga region, but I want to see that it is disseminated across the country.
What message do you give the community of Busoga about the commitment of Kofi to continue supporting the WASH project?
I want to stress the importance of ownership and the participation, and also self-reliant. The government cannot, improve everything. They have limited resources, and then I think that if only they can have some strong determinations to improve their sanitations, I think that this is the most important point, starting point. And then if you are ready to, make a proposals to Kofi and even the local government, then we have some, have some evaluation criteria, but I think it can be workable like that way.
Okay. Yeah. So lastly, just tell us what because coffee is now coming into the light of Busoga, and most people might not be knowing what coffee is. I want you to tell people what is coffee, what coffee is. Yes.
Thank you. Coffee is a government-run official development assistance specialized in health, and coffee is under the Ministry of the Health and Welfare of the Korean government. And Kofi is doing a lot of projects in health care and the humanitarian assistance area. Kofi Uganda office has opened started its activities since 2017, and now recent development is that Kofi achieved international status, whereby we are also one of the internet organizations. And then I think this is a very important, progress for the benefit of all the, beneficiaries, not only Ministry of Health, but we are now expanding our partnership with the other partners, including local government.
This is more than a project. It is a promise to the people of Busoga, a promise backed with science, by solidarity, and by hope. Together with Kofi, Busoga Health Forum, and the local governments, we are redefining what is meant to build a healthy community.
Every year on February 4th, the world comes together to mark World Cancer Day. In 2025, Uganda joins the global community under the theme United in Goals, Unique in Our Needs. A call for collective action while recognizing the unique cancer challenges we face.
The burden of NCDs is very high, starting with the cancers, and specifically talking about cancer of the cervix. We are experiencing an extreme burden whereby Uganda ranks the sixth or seventh among the high burden countries in the world. You find that for every 100,000 women, there are 56 women who present with the cancer of the cervix every year. And unfortunately, out of these, 41 of them die because of late presentation, late screening, and other factors. You also realize that the burden of other NCDs, such as hypertension and diabetes, are also extremely high. It is surprising to note that out of every 100 people, 24 of them have hypertension. And for diabetes, out of every 100, 3 of them have diabetes. These may sound like they are small numbers, but when you apply them on our adult populations, they are really very, very high.
Five years ago, we had around 500 new cancer patients. But when we came to last year, that is 2024, we had around 1,400 new cancer patients. Overall, number one cancer in the region is the cancer of the cervix, followed by the cancer of the prostate, then followed by the cancer of the breast, and followed by the cancer of esophagus, cancer of the stomach, and other cancer follows. We've been blessed that we got a partner who has been helping us to scale up the screening of cervical cancer. These partners who came from Korea, over the year, and also they have increased the number of patients that we screen for cervical cancer. At the same time, treating the premalignant lesions. So we get quite a number of patients whose lesions are actually being treated at the gynae unit at the Mbalala Regional Cancer Center. Now these ladies also get another service of also being screened for breast cancer. We hope down the road this will reduce the number of patients who are presenting with advanced breast and cervical cancer, together with other measures that are being put in place to combat the increase of these cancers.
Generally, about 20 to 25 women are coming in the clinic for screening, and of those who come in daily for screening, we get about 1 to 2 confirmed cancer cases. So averagely, in a week, we get 7 to 10 patients who have confirmed cancer. And we confirm cancer by picking a tissue which is sent to the pathology lab and which confirms the presence of cancer cells. And for those who come with precancer changes, it's about 5 to 10%, and those are able to be treated and followed up within the clinic.
I started to realize that breast was growing smaller, and then it had a dimpling below. So that's when I felt like it was something serious, and I asked a friend of mine who was a doctor. So she asked me to go to another government facility, and I was asked to do a mammogram. I did a mammogram. It was highly suspicious of breast cancer. So I was asked to do a fine needle aspiration biopsy. Even that was highly suspicious, but not conclusive. After like a few months, I started to have backaches. So I did a CT scan and it showed the cancer had moved to the spine. Yes, so I treated that. Then I started to have difficulties breathing. And then I did another CT scan, and the doctors again found out it had moved to the lung, the left lung. So the lung had tumors and I had a fluid in the lungs.
Koganafuna urine nga tejja bulungi. Kati nenzijjanjabwako kati ate ne bagamba nti wali e Masaka tewali Cancer Gundi Institute ne bansindika eno embalala. Kati obujjanjabi mbadde mbusanze nga si bubi era mbadde ninawo enjawulo. Kubanga luli gye nali sifuuyisa bulungi kati nfuuyisa naye nga baŋŋambye ntala nyinkire bunyinkirize kwe gabo baagala kulabira ddala nga.
Nasooka kulwala amagulu n'enzimba nga sikirabangako ebigere. Bwe byava ennaku 3 ne bituuka mu ntombwe n'ebisambi, nenzimba n'obuluuto n'ekifuba. Kati bwe nalwala ne neebaka owaka, nendaba obulwadde obwo nga sibutegeera bulungi. Nina omwana omuvubuka eyajja nannona nandeeta emulago bankwata ebifaananyi. Kati baddokita baakebera awo nali nazimba nnyo nga ndi mu ssaawa yakufa. Ne bakola examining ku bulamu bwange ne balaba oba nalwala mutima oba kibumba oba nsigo, wamu yagamba nga prostate. Dokita oyo okuku yankebera, musajja mukulu, naŋŋumya naŋŋamba nze ndi dokita nzijanjaba abantu, guma musajja gwe togenda kufa. Naŋŋamba obulwadde bubadde bwakakukwata ogenda kuwona. Ne mugamba nze mpona ati ye. Era olunaku lwe najja ne mulaba, olwaleero lwe nzizemu ne mulaba, ssebo pulezidenti w'eggwanga weebale nnyo n'obuyambi bwe watuwa, emulago gyo nabufunye. Naye nkwebaza pulezidenti obulwadde nze nawonya obulwadde, prostate yazimbulukuka siri kyalina kinnuma. Pulezidenti weebale nnyo, weebalire ddala. Abantu baweereza amawulire amakyamu nti abasawo tebajjanjaba emulago. Ssebo abasawo bo bwe watuwa bajjanjaba kiro misana.
Our partnership with Uganda began with a shared commitment to improving healthcare accessibility and quality, recognizing the growing burden of cancer and the need for improved screening and early detection. We saw an opportunity to make a meaningful impact. Working closely with the Ministry of Health and the Uganda Cancer Institute, we launched a 3-year with $3 million pilot project focused on cancer prevention, screening, and treatment. So our goal is to reduce the cancer mortality rate by improving early detection and strengthening Uganda's capacity to manage cancer crisis. So our efforts focus on early detection and accessibility. We have established mobile screening units to reach the communities, ensuring that women can access free cervical cancer screening services. And also, we have trained the local healthcare providers to enhance the early detection capabilities within existing healthcare facilities, such as Health Center 3 and 4. By integrating technology and innovative solutions, we are making cancer screening more efficient and accessible, ensuring that people receive the care they need as early as possible.
National Cancer Management and Capacity Building Project for Uganda. Because cervical cancer is the most challenging issue at the moment in terms of mortality, so the project aims to reduce cancer incidence by providing screening interventions at different levels of health care. We selected 20 facilities. In these health facilities, we selected a team of 2 nurses in each health facility. These are nurses or midwives. We selected 1 laboratory technician. We selected the health information assistant, which we call a data person, who manages data at the facility. We also selected doctors in facilities that have doctors. We all know that health center 4s have doctors, but health center 3s are managed by clinic officers and nurses. So the intention here is actually to train a doctor at health center 4 to understand interventions handling referred cases from health center 3.
For the time being, the project has been running. It started in 2023. It's a 3-year project. I believe that it has been able, or we have started to see some of its benefits, and we are trying to realize the objectives. For example, one of the objectives is to create awareness among the Uganda population in the different communities about cancer, about its prevention, services offered, and then the treatment. So I believe this message is being brought across slowly by slowly.
We are glad we have been getting support from Uganda Cancer Institute and the Korea International Health Foundation. They have been giving us support, and we have been screening, especially cancer of the cervix. A good number of health workers were trained on screening for cancer of the cervix, and we have been screening. In fact, we have a cancer screening clinic in our facility, and we also have an HPV DNA machine in our lab, which tests for the HPV DNA.
Most of these cancers, once captured early, they are treatable and they cure. The challenge we usually get is you coming to us late.
Depending on your age and then your gender, we need to screen for the common type of cancers regularly as recommended by the health workers. For example, when you're a woman, we encourage you and recommend you screen for cancer of the cervix and cancer of the breast, because those are the 2 common types of cancer affecting our women in Uganda. And for the men, one of the most common types of cancer which you can screen for is cancer of the prostate. So when you're a man 40 years and above, you start screening yourself once a year for cancer of the prostate, which is the most common type of cancer.
Those who are going through the same journey that I'm going through, I want them to know that there is hope. Because when it comes to breast cancer, it's one of the most treatable cancers as long as it's detected early. And then for ladies who are scared to screen, for those ladies who think it's better not to know, it's really, really, really will not help. Because at the end of the day, if the problem is there, you're just waiting for it to explode. And yet if you go early, they might catch it before it turns cancerous, or when it has just started, and your chances of surviving are very high when it's caught early. Or if it's caught before it turns cancerous, then you can get the treatment you need, and it will be very simple treatment, other than waiting for it to become bad, and then you have to take a whole year plus to treat a disease.
Nze ndi musawo wa kinnansi anjagala nnyo abantu babeere abalamu. Kati nakimanya nti obwo obulwadde sisobola bujjanjaba nenzija mu ddwaliro. Nsaba abantu mwenna n'abasawo mwenna ab'ekinnansi abajjanjaba abantu, bwe mulaba abantu ng'obulwadde temubasobola mubuleke, kuba nze nandifudde seegezibwaza ku ddagala. Nakimanya nti obulwadde sijja busobola, si bwange, saabusomerera. Kati mulaba mponye munnammwe, munfuule ekyokulabirako mu ggwanga. Singa nange nagamba kanywa eryange nandifudde.
So we need to do a lot as far as ensuring that we are screened early for the different cancers and for the other non-communicable diseases, if we are to be on the top of these conditions. Otherwise, waiting to present with an NCD the treatment route is very complicated, very costly, and very catastrophic. The outcomes are usually very disastrous, economically and for our lives.
My last wish that this funding which the Korean have extended to us is scaled up to other districts, and it continues. We believe that several years down the road, we shall see a big impact when probably women no longer be dying of advanced cervical cancer. That is where somebody says, we hope to end cancer in your lifetime. And for cervical cancer, it is possible because countries like Australia, which intensified immunization of young girls against HPV, and of course, screening regularly, they have totally reduced this burden of cervical cancer in their population.
Cancer is preventable and treatable, especially when detected early. We encourage all Ugandans, especially women, to take advantage of these free cancer screening services provided through this project. At Kofi, we believe that everyone deserves access to quality health care. So together, we can fight cancer and ensure a healthier future for Uganda.
This documentary is brought to you by the Uganda Cancer Institute and the Ministry of Health in partnership with Kofi. Together, we are united in goals, unique in our needs.
In Uganda, access to quality emergency care can mean the difference between life and death. To strengthen emergency medical services, the Kga Foundation for International Healthcare, Kofi, in collaboration with the Ministry of Health, launched a transformative pilot project in the districts of Masaka and Bukomansimbi.
Kofi, Korean Foundation for International Healthcare, is a public agency under the Ministry of Health and Welfare of the Republic of Korea. Kofi supports government-level health assistance to the partner countries, including Uganda.
So the project focused mainly on 5 intervention areas, and these are leadership and governance, infrastructure development, emergency equipment, capacity building of health workers, and strengthening the referral system from community to regional levels.
One of the key pillars of this initiative was strengthening leadership and governance. Project committees were established.
We have been able to see the development of emergency care protocols.
Regional stakeholders came together to create a coordinated approach to emergency services. Leadership training was also extended internationally, with Ugandan officials receiving specialized training in South Korea. Improving infrastructure was central to the project.
Maternity department got a new maternity ward.
New regional skill and simulation labs, a call and dispatch center, and upgraded emergency units, including operating theaters, surgical wards, and neonatal units, were built to support effective care in Masaka and Butenga. Advanced emergency equipment, including 4 new ambulances, X-ray machines, and point-of-care ultrasound scanners, were introduced to ensure that health workers have the tools they need to provide life-saving interventions.
New operating light we are currently using during operations. Modern X-ray machine, which is in place, and on a daily basis we are able to do over 100 X-rays.
To build human capacity, health workforce training was done at the national level in the Ministry of Health, the regional level at Masaka Regional Referral Hospital, and the community level, empowering them to respond swiftly and effectively to emergencies.
The project has enabled us to train 1,700 health workers in courses ranging from advanced life support to basic life support basic emergency care. We've also trained the regional ambulance drivers on how to deliver emergency care services.
508 VHTs were trained in CIFA, Community First Aid Responder course.
So this is a system that's responsible for providing care for people that have had sudden illnesses or injuries and need emergency care. All right, so this comprises of care that is provided on the scene. So when someone gets an injury or sudden illness, that can be in the community, on the roads, in the workplace, to care that happens when you're being transported from that point to the hospital. This is care that's provided by trained professionals who work on ambulances, ultimately to care that is provided in the hospital. Okay, the acute care point or the emergency unit, as some hospitals have it termed.
To improve emergency referrals, a new call and dispatch center was established. It coordinates the emergency units with ambulance teams and community responders in real time, ensuring that patients receive timely, continuous care from the scene through transportation and the emergency department. At the hospital, trained staff triage, resuscitate and stabilize patients before they receive definitive care. This comprehensive system has led to a dramatic increase in emergency room attendance, with over 25,000 patients treated annually. Today, 98% of patients are triaged on time, and 100% are attended to within an hour. The Coffee Project has strengthened emergency care, reduced deaths, and saved countless lives.
Nifunako enamba ya ambulance nenjikubira era tebalwawo ne bajja ne bamutwala netutukira ku emergency ne bamukolako ne bamuzanjaba n'atereera. Mwebale nnyo, mwebalire ddala ab'ekitongole kya Coffee.
Mine would be expression of gratitude.
They are so much grateful. They have never seen people who have good hearts like the Koreans.
I just want to appreciate Coffee, especially the emergency medicine project, to identify the critical need and addressing it without conditions, but identifying with us our need and addressing it has been the cornerstone of the success.
This successful project, therefore, awaits being scaled up across the country.
Good morning once again. You're all welcome to this event that we've been looking forward to. We've been preparing for you, and we hope that you will enjoy today, and we shall have meaningful discussions in as far as the topic is concerned.
So this year, actually, I myself created 3 pillars, 3 frameworks. One is research, another one is e-contents, another one is health forum, Coffee Health Forum.
Coffee was founded in 2006 as the Korea Foundation for International Health Care, and it's a government agency affiliated to the Ministry of Health in the Republic of Korea. So Coffee maintains 11 overseas offices, including the one of Uganda. We have a country office in Uganda and also in other 10 countries, making it 11 countries.
Currently, we have been able to move, and the biggest document in the country right now is the National Development Plan 4, which is one of the Vision 2040 strategic areas. And in here we do exist. The first document which came out was the National Development Plan 4 Cabinet Strategic Directive.
Whatever project that we do support is based on the dialogue between ministry or between the partners and the Coffee, and has been here to implement quite a number of activities with a total of about 20 million implementing projects such as the infectious diseases, capacity building, what we call CHU project, the EMS, cancer, and IED project, and also the WASH project.
The other one, 8, is on improve maternal, adolescent, and child health. In our analysis, we have seen that there is a big contribution which we make in maternal health. About 60% of our interventions actually are on delay 2. In 2019, you go to an accident and emergency unit and you find yourself feeling inadequately being attended to. So this is the reason why we came up with focusing ourselves to improving these areas.
Value for money, efficiency, sustainability. These 3 things need to be at top priority now going forward. These are the key implications for the funding cuts that we're seeing, not only in Uganda but also in the region.
So I really wish that this, Coffee Health Forum will be developed into a kind of a list East African global networking, where as a knowledge generator, especially leading forums focusing on health, of course.
Hello. Can I have the other mic, please? Okay. Hello. Hello. Get us new speakers. Good afternoon, ladies and gentlemen. We are ready for the last event of the event. Though our speakers are acting up, so right now we are going to a discussion of a couple of projects that are being supported by the Korean Foundation for International Health. And all right. One for one. So I would like to invite Miss Sarah Achiro to give us a presentation on the Dr. Lee Jongwoo program. Sarah, you're welcome. Hope it works.
Thank you very much to our moderator. A very good afternoon to you all. Are you able to hear me? With the mic or without the mic? So while we wait for the presentation to be displayed, I would like to say that it gives me so much pleasure to stand before you to make this presentation at the first Coffee Health Forum 2025. This has been organized by the Kga that you'll hear more about as I present. And yeah, I'm really pleased that this is happening. We can move. So this fellowship program is called the Dr. Lee Jongwook Fellowship Program. It is an invitational training program, and it was founded in memory of Dr. Lee Jongwook, who was the 6th director of WHO. He did great work in health, and so in his honor, this program was established. Yeah, we can move. The vision of this program is to nurture experts who will play a leading role in healthcare improvement in least developed countries. And these objectives have been, the short term has been from, I think, 2019 to 2020, and then 2022 to 2024. Sorry, 2020 to 2024, we had these midterm objectives, and then 2025, moving forward, we have that long-term objective to establish an integrated health workforce training program. Next. So in terms of numbers, in terms of countries, this is what we have. We have the fellowship program is currently in 30 countries globally, 15 in Africa, 11 in Asia, and then 4 in South America and Middle East. Yeah, so those are the countries highlighted there, Uganda being number 1 in Africa. Let's move. Yeah, so this is the status of trainees by country, and as you can see, Uganda has one of the top numbers, 119. This statistic is as of 2023, but as of 2024, we've had an additional list of people who have undertaken the program. And then this is by year globally. Yeah, so we have about 8 courses under this fellowship program, and these are the numbers globally for the people that have been trained, totaling up to about 1,500 as of 2023. So just back a little, yeah. So these are the courses that we have. We have a training course for clinical experts. We have a training course for biomedical engineers, health policy administrators, finance, and economics. We have infectious disease specialist course, a course for graduate courses. These are master's programs that are 2 years in nursing, medical education, health policy, biomedical engineering, and then basic medical science. But in Uganda, so far, we're undertaking only 4 under the master's program. That is nursing, biomedical engineering, and then basic medical science. So this is how the program flows. At the very beginning, there's a demand survey that is conducted across the different countries to understand, given that it's a global program, we need to understand the different needs of the different countries. And then a detailed training program and plan is established, followed by selection of candidates from the different candidates who undergo a rigorous selection and interview process. After the selection process, they are then invited to Korea to undertake this course. And once they return, they now become the Coffee Global alumni. They join a network of alumni who have who have undertaken these courses and they've returned to Uganda. So currently in Uganda, we have about 150 Ugandan health workers who have undertaken this program. So these are the key stakeholders as we undertake this program. We have the Coffee Uganda office, the headquarter. We have Ministry of Health. We have the Embassy of Republic of Korea. We have the health facilities and institutions, and then the candidates themselves. So Coffee headquarter is responsible for conducting the demand survey that I highlighted earlier, after which they let the Ugandan office know, they notify the Ugandan office, who then writes to the Ministry of Health to provide a list of candidates that qualify for these different courses. And then once the candidates have been recommended, we then ask them to apply to the system. And once they apply to the system, they undergo interviews, after which they then now plan to travel through the through the embassy, where they get the visual issuance, and then when they return, they join the Alumni Association, where they take on leadership, they develop action plans, and then they also undertake different activities, such as the one that we're conducting today. So these are the numbers in Uganda. We currently have 150 plus, as I highlighted. For this year, we took 17 for the different programs. So this is the list of people that we took to Korea to undertake these various courses. Maybe I'll highlight one for the Health Leadership Policy Management course, that is number 4. We took Dr. Charles Kabugo, who is currently the Executive Director of Chirudu, and I think he went in November for 1 week, and he's already back. And these are the others from the different facilities, including their names and their affiliation. Yeah, so the association actually has a very high level people who are part of the association, and among them, we've had the Commissioner for EMS, who was with us yesterday, the Commissioner for the Lab, the Commissioner for Health Promotion, Community Health, and Surveillance departments. Then we also have directors, including the Director General, Dr. Olaro. He's also part of our alumni. And then we also have, of course, the management and technical teams. And those are the ones that we have so far, different roles and affiliated different organizations. Yeah, so these are the ones. We have alumni from all of these facilities and institutions. Next. Yeah, so as I mentioned, once these people return from Korea, they join a network of alumni, first of all to, of course, interact with those who have been to Korea, but also to share knowledge and experiences, but most importantly to make a contribution to the health system through different projects and different activities. Yeah, so this association also has a leadership structure, and in this leadership structure, maybe I'll highlight just 3 key positions. We have a president, we have a vice president, and then we have an advisor. So in this room, we have the president for the association, that is Dr. Omwena. We also have the advisor, Dr. Lukoma Michael. Our vice president couldn't be with us, but she is Auma Winifred. She is from Masaka as well. Next. So there are different activities that are undertaken by the alumni once they return, because Coffee, unlike other maybe fellowship programs, has a unique element that it does, in that we provide funding for alumni projects, and there are different kinds of projects that can be funded under the Kga, and these are just an example of some of the projects that we fund, including many others. Yeah, Seminar, you can see, is part of them, and this one was funded under the Kga project. So I'll just share some highlights from 2025 about this fellowship program. Yeah, so this was in 2024, where we had a joint gathering. This joint gathering I see Dr. Mana's big smile there. So this gathering was held between Coffee and Quaker, and it was at 4 Points, and it brought together so many of us. I think we're more than 150 in the room, and we had a keynote speech from the former vice president, that is Dr. Kazibwe. And we also had the ambassador and many other dignitaries who participated in this meeting. Next. Yeah, so we also do pre-departure briefings. So before these teams go to Korea, we want to make sure that they are informed and they are briefed about what to expect, both in terms of living situation and the course itself. So we do many pre-departure briefings, and these are some of the ones that we've had this year. And then the special thing about this program also is that we have on-site consulting. So these professors who train the students in Korea usually visit Uganda. This can be a physical visit, or sometimes they can just do an online visit, and they answer some questions and provide some more guidance to the people that have undertaken these courses. This was one of them that we had this year, specifically for the clinical experts, where we visited Butenga and many other facilities, and then also had the alumni present their action plans that they developed in Korea and giving us progress about how far they've gone with implementing their action plans. This is more from that. Tutata is a big deal, as you all know by now. And so together with the Tutata lead, that is Dr. Mwena, Ministry of Health, and Wonju Severance Christian Hospital, they were able to conduct a 1-week training for Tutata. And we had, I think, Dr. Mwena, were they 41 people who were trained? 30, yeah. So we had 30 people that were trained on this day, in this week under this program. This is still on the on-site consulting. We had an EMS quality workshop that was done at Mulago with some donation of medical supplies as well. And then we are also developing a project management guideline to support and give additional guidance to the alumni as they implement their projects. And this is in the works currently. This is still in the on-site consulting. We had action plan workshops, and this was done in Masaka, where we had different people present their action plans and how much progress that they'd made in implementing their action plans. And additionally, we're still continuing to collaborate with Quaker. Quaker also has an association in Uganda. It's called KOKU, the Quaker Club of Uganda, that brings together everyone who has undertaken courses under the Quaker programs. So we've been trying to interact and collaborate with them, and we've had several meetings, including the joint gathering that I spoke about earlier. So they also invited us to participate in their annual assembly, which we participated in. I was with Regina, Patricia, Beatrice, and Linda. And then we had and then we had the 5th annual General Assembly. These are some of the pictures that we took just to invite people to join us. Next, yeah. Okay, so I spoke about the projects that are funded under the alumni, under the KGA, and I just want to highlight some of them that we've done since 2021. So in 2021, we had a CIFA training, that is Community First Aid Responders training, targeting police officers, UPDF, and bankers. This was done in Masaka. And then in 2022, we had a basic life support training done at Entebbe Regional Referral Hospital. This was targeting border riders. You know how much of a problem they are locally here. And then we also had a mobile application system that was designed. That's one of our projects as well in 2023. This was to connect the elderly and people with disabilities to health facilities. It was more of a pilot project, and maybe we'll get to hear a bit more about it. In 2023, we had Tutata. You all know about Tutata. You've heard about, you listened to the presentation this morning and also saw some of the videos. And then in 2024, we had four projects. We had the Zoonotic One Health project. This was implemented in southwestern Uganda. I won't go much into it because we may have a chance to listen to a bit more from the project implementers themselves. Then we had a WASH project as well. This was implemented in Busoga region on Masese Island. And then we had a 717 e-learning course that was developed by one of our very own, Patricia Ayu, who should be in the room. And then we had the WHO surgical safety checklist that was digitized. This was done by Diana, I know Mugisha, who is with us in the room this afternoon as well. So these are some of the projects that we've undertaken under the Kga, and they've had some meaningful results and impact. Next. Next, are we together? Okay, so starting 2024, we did a bit of a restructuring of the Kga project, and I just want to highlight some of the things that we've done to try to restructure how the alumni projects are run. Very quickly, we've done, maybe I'll highlight simply 5 key things that we've done to restructure. So number one, we established a strategic governance framework because we wanted to have critical key values that we wanted to attain through these projects. And so we came up with these ones as our strategy, as our framework. We wanted to have transparency in our selection process, we wanted to have accountability when it comes to implementation, and fairness as well. So it's an open competition, everyone can participate as long as you've participated under our fellowship program. We wanted to also have visibility and increase how much, first of all, coffee is known, but also the Kga themselves, because they are a very powerful resource. And then I wanted to also have some dynamism and have not the usual projects that are normally implemented, have some unique elements to our projects, and I'll share a bit more about the results of this. And then we also wanted to promote quality management in our projects, where we implement not just to finish, but so we can have quality in the process, but also quality results at the end. And then sustainability was also a major issue that we faced, because it seemed as if these were personal initiatives that we wanted to institutionalize for sustainability. And then scalability as well. We wanted projects that can be able to be scaled just beyond maybe the facility or beyond the community or area where it was implemented. So this is what we came up with as our governance framework. And then we also decided to professionalize the project selection process, where we share now official proposal invitations. This comes through email, and I think everyone receives them. We've provided guidelines and orientation to the alumni so they can understand the new procedures, but also so they're able to comply with them, including external evaluators, because sometimes there might be some sort of bias. I may like EMS too much and pass Dr. Mona's projects, and yet there is other health issues as well that need to be attended to, including letters of expression of interest. We found that it was very difficult to have the alumni present proposals at the beginning and then keep revising. So we thought they would have a simple document for them to just fill in, a letter of expression of interest, where we just highlight key things, and then they're able to present later the detailed project in a meeting in the office. And then we also encourage supervisor endorsements from institutions, because we didn't want to have this individualized, as I shared earlier. And then we also decided that Ministry of Health needs to be notified about this project so that they can be aware of what we are doing. So through this, we designed many tools, many templates. We also provided a clear evaluation criteria for these projects. We conducted more than 20 orientation and guidance meetings. We also coordinated with many external evaluators, including people from Makerere University, Kampala International University, among others, to provide fair and neutral evaluations of these projects, as well as providing clarification sessions for the alumni who needed some clarification. These are some of the pictures from one of the very first orientation meetings that we held at the office at the beginning of these structural changes. And then we also decided that we needed to strengthen reporting, accountability, and documentation, including the inception, midterm, and completion reports. But we thought that that wasn't enough. I needed to have the people who have implemented these projects come to the office and share with us their presentations. So we've invited them to share these presentations, including the results and outcomes that we've found that they've got from implementing these projects. We've also decided to add visibility in terms of both publications and articles, as well as documentaries. And this is very important for institutional memory. And this is what we've done to make sure that all these happen. Next. Yeah, institutional ownership and visibility. I've highlighted a bit about that. Maybe one thing that I can highlight from the institutional, maybe just go back a bit. Yeah, one thing that I can highlight is the formal MOUs here. So every project implementer now signs a memorandum of understanding with Kofi to ensure that they commit to deliver the results that they promised when they develop these projects. Yeah, so we also know that the people that we work with, the people that are part of our alumni association, are health workers, but they're also very busy with other work. And so we thought it was critical to include an element of capacity building to improve and grow their project management skills. And so we had what we've dubbed the Project Management Clinic. This was done, the first of its kind, done this year. And the target was for people that had written proposals to Kofi. We targeted 6, 2 per project. And yeah, this was conducted in our office where we invited external experts, but also utilized the skill and wide knowledge base and resource of our Kofi staff who took them through many topics, including lessons learned, project design matrix, milestone activities, and the rest. And while we did this clinic, we undertook a pre-test and then a post-test score. And you can see, at least in that session, there was evidence of increased knowledge and learning about project management from these project implementers. So these are some of the pictures. You can see Beatrice over there. We can see Regina participated. Dr. Tuhaire, who moderated the earlier session, was also there, as well as a number of others that you can see, including our Kofi country director who participated and the Kofi staff. So what did we get out of this project management clinic? One, we realized that the quality and uniqueness of our projects have increased significantly. As you can see, this is one of our alumni projects, and it's quite unique. We had never had a seminar before, and these are some of the results from that clinic. And then institutional ownership, we found that most of our projects have been embraced by the institutions where our alumni come from, and maybe they'll share a bit more. Patricia will share about UNIPH, and then Diana will share a bit about Mulago and how they've embraced these projects and owned them. Reporting has become more structured and evidence-based. And then we've had also strengthened visibility, whereby each project we've required every project to develop a documentary. And so we have these documentaries available. And maybe they'll share with you in their presentations as they tell you more about their projects. And then we also have higher alumni engagement. Now there's more interest in these projects and in the activities that are undertaken under Kga. And then, of course, the reputation of the Kga is improving because the evidence can be seen from this seminar where high-level people have been invited and they honored the invitation and even made very meaningful presentations. And we now want to have even national, but not just national, global perspective when it comes to developing our proposals and implementing our activities. So I'll share some major achievements. The Tutata project is a major achievement under the Kga. We won the best project of 2023, and this award was given to us in June of 2024. There is our president now receiving his award from the Republic of Korea with a team that went with him. We also had additional projects in 2024 that were awarded. Actually, in 2024, we're meant to receive only 2 projects, funding for 2 projects. That is the WASH project. These are some pictures from the WASH project and the ZOHEC project. So these are the projects that were approved and funded, but because of the effort that we put in making these structural changes, we got an additional project, and this was a 2-in-1 kind of project where we had the 717 e-learning project. These are just some pictures. This one was a final dissemination of the course once it was complete, once the development was complete. And then this one, the surgical safety checklist. So these 2 were given to us because of the efforts that we put in making these structural changes. And because of these 2, we won the best project. Actually, we won the outstanding project of 2024 as well. So we've been doing great and winning consistently. Next. These are the awards that we got for outstanding project for 2024. And then 2025, we've also got additional projects that are currently ongoing. We have 3 projects for 2025 with a budget of 65,000. Yeah, so for these projects, we've actually already started them. We had kickoff workshops for these for these 2 projects. One being the e-content project. We even had, if you saw the papers today, this was in the news. And then we also had the kickoff workshop for the research project. This was done on 5th of December. That was last week Friday. So we're doing well, and yeah, I'm really proud of what we're doing. Thank you so much.
Another big hand clap for Sarah. I think I've not had a chance to, because sometimes we get so serious on the podium. But Sarah has a combination of humor and technicality in the work she does. So she really made our afternoon very easy, and I'm sure we all grasped what she presented by the way she presented it. So thank you so much, Sarah. Of course, yeah. One thing that I picked that I'll never forget, and which I will sell to other projects where I am, is the project management clinic. I had never heard about it, so that's a good innovation that I'll sell elsewhere. Sarah, this is a Q&A. And we're going to keep it as short as possible. But we are very much appreciative of the work that you are doing and the rest of the team from Coffee. I'm personally a beneficiary of the Dr. Lee Jong-wook program, and I'm proud of that. I'll start with a question and then invite questions from the participants. My question is just one and very simple. How does this program facilitates knowledge sharing among other alumni across different countries? We can see the much work we are doing here, our Dr. Mona leading us. How is he able to sell what he has sold to other countries, and where Coffee has presence, and how are other countries sharing what they are doing under the same program with us here? I mean, for capacity strengthening. Yeah, so let me invite other questions, just 2, because of time I was warned by. Only 2 questions to Sarah, or 3 maximum. Sarah, is there a question? There are no questions from the participants? Yeah, she was very clear in what she was we used to say that a lot in class. The teacher was very clear. So Sarah, let's just answer that question on knowledge sharing for capacity strengthening. What are the plans for Coffee in terms of facilitating that? Yeah.
Thank you very much, Maria, for that question. To start with, maybe I'll start with locally. Locally, as you know, once you go to Korea, you are required to develop an action plan. So an action plan is based on some of the issues that you find either within your institution or beyond. And these action plans are basically the actions that you're going to take once you return to make a difference within your institution. So we start with that. And so locally we have many action plan workshops that we hold once the alumni return from Korea. So we hold them locally. But beyond Uganda, we had not yet had any exchange except for the connections that the alumni make while they are there, and they can share amongst themselves. But as an institution, as Kofi, we did not have that yet, but it's something that we have been considering actually. And a forum such as this would be a good one where we can invite even additional participants from other countries and other associations to be able to share knowledge, and we learn from each other.
From me and Sarah.
All right. Thank you. Thank you. So you're handling the last session. We have two presenters. After they are presented, they get their questions, and we close. Yeah, we are late. All right. The names.
I've been told to take it on from here. So we're going to have two presentations. These are going to be presentations of the activities that we've undertaken under the KGA. And first we'll have AU Patricia, who developed the 717 e-learning course, to share with us a bit of her project, some of the lessons learned, and some best practices. After that, we shall have Diana, I know Mugisha, share with us about the surgical safety checklist and what impact it has had within Mulago Hospital. And once they're done with their presentations, we shall have a brief sharing, some few questions, and then we'll close the session. So it's going to be short and sweet. So I hope you look forward to it.
Thank you very much and good afternoon. So I'm AU Patricia. I'm going to present a case of an e-learning course for One Health 717 framework in Uganda. As Sarah has mentioned, this is one of the projects funded by Kofi under the Kofi Kga Alumni Network. Yes, thank you. Yeah, as we all know, public health emergencies exist globally, and public health emergencies include disease outbreaks and natural disasters. If you've been watching international news, you've been seeing the different disasters happening in the different countries globally. And also, if you've had a chance to look at the World Health Organization reports, you can see the different diseases that we are battling in the different countries along the world. So one thing is that timely and effective detection, notification, and response are crucial. So the 717 framework, and I'm going to give a brief about this because I'm sure most of us don't know about the 717 framework. It's just a mechanism for us to ensure that detection, notification, and response are timely. So Uganda adopted the 717 framework in 2022, and currently we've rolled out the framework in 12 regions of the country. Next slide, please. Yeah, so how was the 717 framework birthed? So the 717 framework was developed by Resolve to Save Lives. It's one of the global bodies. And it was later adopted by the World Health Organization. And in this 717 framework birth, they analyzed data, outbreak data from several countries retrospectively. And then researchers found that most of the outbreaks could feasibly be detected within 7 days, reported within 1 day, and responded to within 7 days. So that's if all the core public health functions are working normally. So these timeframes were then adopted as a simple evidence-based framework to measure and improve outbreak preparedness and response in a speedily manner globally. So what is 717? So the first 7 in the 717 framework stands for the time to detect, which is calculated by subtracting the date of public health emergency threat, when the date when the public health emergency emerges to the date of detection. And then the 1 stands for the time to notify, which is separated from getting the date of detection from the date of notification. And then the last 7 on that framework is the time to complete early response action initiation. And it's calculated by subtracting the date of notification from the date of early response action completion. So the 7 response actions are those listed down, like initiating investigative or deploy investigation response team, among others. Those are not important for this meeting. Next slide. So how does the 717 approach support achievement of other targets? So 717 is one of those frameworks that supports the different several existing approaches that we use in public health emergency response. So the 717 approach complements the 3rd edition Integrated Disease Surveillance and Response Guidelines, which focuses on prevention, detection, and response. And then the 717 approach also has been used to develop the 2nd National Action Plan for Health Security, which is a 5-year plan, which also focuses on detection, notification, and response, among others. So the 717 framework enhances the early action reviews and the interaction reviews by providing clear performance targets and a simple way to check performance. And then it also contributes to achievement of the Sustainable Development Goal 3, Target 3.3, which mentions about ending epidemics of communicable diseases and strengthen country capacity for early warning, risk reduction, and management. And then the 717 framework has also been incorporated into the Ministry of Health 5-year strategic plan, which was completed recently. So what was the rationale of us coming up with this project? The use of an e-learning course will minimize costs incurred in physical trainings. As we all know, when we have to train our health workers, we usually pull them off their workstations, pay for hotel fees, among other costs. And then also, when we have this e-learning course, we shall be able to minimize absenteeism at workstations, still due to physical training. So when we have our physical trainings, work is not happening at our workstations because of that. And then users of the 717 metrics can be able to refer to online classes, or if they have any questions or during study time, among others. So what was the goal of this project? It was to develop an e-learning course for 717 metrics so as to increase the coverage and to fasten the rollout of 717 metrics in the country. So we have rolled out 717 framework in 12 health regions of the country, and if you're all well versed with this, we have 16 health regions. So 4 health regions have not yet been reached. But even in the regions where we've gone, the district rollout has really been minimal. And yet we know that this is where we have the outbreaks occurring. But also when we're rolling out, we focused majorly on the human health sector. And yet we know that of late we have so many zoonoses which are cutting across from the animal to the human health sector. So the 717 e-learning course is currently being hosted on the Ministry of Health e-learning platform. So this is just a project scope. So we went through approval processes, went through stakeholder engagement, we did content development and review. We eventually uploaded the content on the Ministry of Health e-learning platform, and then we disseminated, and the only pending thing is monitoring and evaluation, which we shall be doing on a 6-month basis. So the geographical scope of the course, we developed the course at the national level. We engaged the national level stakeholders who are engaged in the 717 assessments. Then we intend to roll this out to the subnational level in all regions of the country and all the districts of the country. Then the long-term goal is to have everyone converted to do a 717 analysis for every outbreak that we experience in the country. So the eligible participants of the course, at the higher level, we have the policymakers and program managers. Then at the operational level, we have the public health professionals, epidemiologists, lab staff, clinicians, among others, cutting across to the animal health experts and the Ministry of Water and Environment. And then we also have the development and implementing partners from the different One Health ministries, departments, and agencies. So we have certification for the course. So participants who get 80% and above, or we shall issue them a certificate of completion of the course. If you get less than 80%, you won't be able to get a certificate once you've done the course and completed. So the certificate will be issued directly to the email of the participant. And then the name that you used for logging in is the name that will appear on your certificate. So the approval processes by Ministry of Health and Ministry of Agriculture, Animal Industry and Fisheries. So we went ahead to introduce the project to the chair, Steering Committee, 717 Alliance, and we are blessed as a country to have the global chair being a Ugandan who sits at the Ministry of Health, so this was an easy process. But also we engaged the other ministries and briefed them about the objectives of the project and proposed plan and timelines. Then we, of course, got approval to go ahead, and then we kick-started off the project steps. Then activity 2 was the stakeholder engagement, which was a successful meeting, a meeting just like this one. So we identified a list of the key stakeholders at the different ministries, departments, and agencies, including the academia, and we sat them in a meeting like this. The stakeholder engagement was a very powerful meeting because it helped us to realign the next steps of the project. Actually, there are things that we had to drop and things that we had to come up with, so we were flexible enough to adopt the comments and the feedback we got from the stakeholder engagement meeting. And then we also went ahead and engaged the professional bodies. So we sent a letter to the professional bodies, 2 of them. And it's unfortunate that up to now we haven't yet secured a meeting. So we hope that once we secure a meeting, we shall present the project to them. And then we are able to have health workers get some CPD points that they'll use when they renew their practicing licenses annually. And then the next step we had was content development and review. So as I mentioned, we identified a multidisciplinary team of stakeholders who are actually engaged in the 717 implementation at the national level. And then we reviewed content from several sources, including what we call the 717 toolkit, which was developed by the 717 Alliance, which is the body that generated this tool. And then we also used the World Health Organization documents. We used some locally produced 717 reports. We actually went and did an actual outbreak investigation and response, and the content that we obtained from there was what we used for the case study development. So in total, we have 4 modules, and I will show us a sample of this with a conclusion and overview section. Yeah, this is just to show that we went ahead to do data collection, active data collection, which we used in forms of videos, pictures, voicings, among others, from Sembabule district, which had an active outbreak of anthrax. So the content we used there was to develop the case study. And then the content went through 6 reviews across the different stakeholders that we used. We also engaged the adult learning department at the Ministry of Health, which has an annex in Mbale. So these guys helped us to modify our content into an adult-friendly content for us to use in this course. So these are just images for the different processes we went through when we went to collect data, which we used in the case study. So the activity 5 was the launch and dissemination, and this was done not long ago. But this dissemination meeting was impressed by the different key stakeholders involved in 717 assessment, and we captured the One Health disciplines, including Ministry of Health, Ministry of Agriculture, Animal Industry and Fisheries. We also had teams from academia, then partners, including the WHO, CDC, Baylor, IDI, among others. This is just an outlook of how the course looks like on the Ministry of Health e-learning platform. So if you can clearly see, there are 4 modules on the left side of that slide. There are 4 modules. And then at the end, there's a certification and conclusion section. So once the learner logs in or signs up for the course, they have to first register, and that's the registration form. So the form captures key details as you have seen in the subsequent slides. Next slide. Yes, so these are some of the questions that we have incorporated for signing up for the course. So issues of the name, the email address, the highest level of education, the current role or position, among others. So we captured these details so that as the learner is signing up, we are able to capture their details. For example, the name is what will appear on the certificate. The email address is what we shall use to send the certificate. And then the next information just helps us when we are doing our M&E to know which people have we reached, because we have a target audience that we want to reach, but also want to know whether we've reached them at every milestone, so that if we haven't reached a particular category of people, we prioritize to see how we can reach them. And then the course duration, so the course takes about 10 to 15 hours to complete. However, if someone is really sharp or really fast, they might take a little shorter time than that. So what we are still yet testing is for if someone logs into the course and doesn't complete it within the required time period, which is a minimum of 2 months, we hope to keep sending emails to the person so that they're reminded to go ahead and complete the course. But we are yet to test this. We haven't yet tested it. So we also have course rules. So part of the course is for us to get feedback from the learners so that in case the learner tells us to make some adjustments, we're able to make the adjustments. So some of the course rules are that participants are required to complete each module before progressing to the next. And this one is auto-done by the system. You can't progress to the second module if you haven't finished the first one. Then we also have quizzes and activities within the modules, and this must be completed to ensure that the learner has actually met the outcomes that are required from the course. And then we also have issues on adherence to the platform policies, including respectful communication and intellectual property rights. So we expect the learner to give us feedback, and this feedback should be in a language which is actually appropriate for us. So we have a feedback tool, which is what I've just been talking about. So we expect the learner to rate the quality of the content from a scale of 1 to 10. Then we also want the learner to rate the content variability on a scale of 1 to 10. And then also the ease of using the platform, and then what the learner thinks they enjoyed most about the course and what they think we should do to improve the course. So this should be in a language that is appropriate. Yeah, this is a sample of the certificates. So I put this without the signatures just for intellectual property rights, but this is a sample of how the certificate looks like once you've completed the course. So this is auto-generated and comes to your email address. So that is a link to the Ministry of Health e-learning platform. So we had some lessons that we learned from implementing this project. One of them is that cross-sector collaboration is essential for One Health training. So it was very important for us to engage the One Health sectors so that we capture content that is favorable for all the different One Health ministries, departments, and agencies. Then we also see that digital learning increases accessibility, but requires strong local infrastructure. So for Ministry of Health, we had what was already existing as a Ministry of Health e-learning platform. But when we dug into having our course uploaded to the platform, we realized that actually this platform was an e-learning repository, not an e-learning platform. So what we wanted to put there was not suitable for us to put up there. So we had to upgrade the infrastructure. So currently the Ministry of Health e-learning platform is being upgraded to an e-learning platform, not an e-learning repository, but also they're upgrading their system to an Android version so the learner can be able to access the course on a phone. But initially you had to use a laptop or a desktop version for you to be able to access the course. And then also we see that localization of the content improves learner engagement and relevance. So initially we had developed content, but it wasn't as user-friendly until we engaged the adult learning department of the Ministry of Health. So they were able to help us localize the content to a normal Ugandan learner. And then also we see that capacity building must go beyond content delivery. So initially we thought that once we have the content put up there, that's enough. But then we realized that we tried to engage a few people, random people to use, to upload, to sign up for the course, and realize that actually people have IT issues. So capacity building is not just beyond developing the course content, but also we need to now train the learners on how to use the Ministry of Health e-learning platform. And then also we see, which is very key, that partnerships and funding support drive sustainability. So we are trying currently for Ministry of Health to completely buy in. We've engaged them from the start. So now the next steps for us we are trying to do is to see how we integrate this Ministry of Health, this 7-7 e-learning course into the other Ministry of Health activities so that we don't have to incur extra costs for us to be able to roll out the course successfully. So one of the success stories, as I've mentioned before, the Ministry of Health e-learning repository is being upgraded to an e-learning platform. And then we also have an Android version being developed and incorporated into that upgrade. And then also, it was unfortunate that the Ministry of Health didn't have a certificate up to the time that we were doing this course. So we had to come up with a template for certificate, which will be used for all the courses on the e-learning platform going forward. The next steps is just countrywide dissemination and monitoring and evaluation, which is pending. Yeah, acknowledge the following institutions and most especially Kofi for funding this project. Thank you.
Thank you very much, Patricia. You may take a seat this way first. If you have any questions for Patricia, please keep them. We'll have them all together after Diana's presentation. So now I invite Diana, I know Mugisha, to share with us her presentation.
Imagine waking up and you as a patient, you find that instead of operating this knee, somebody operated on this one. Ladies and gentlemen, my name is Kga Diana. I am a nursing officer from Mulago National Referral Hospital. I am also specialized in laparoscopic nursing. Thank you, Kofi, for that opportunity. I'm also a specialized midwife from Makerere University. In 2008, WHO brought on board the surgical safety checklist. But it has taken us many years for us to have it on board. And you notice that every year, 4.2 million people die within 30 days of surgery. And you realize that the greatest contributor of this death is because of heart disease and stroke. But millions more, they suffer from different complications that come out of these surgeries. And that's why we have this WHO surgical safety checklist on board. These are some of the statistics that I found out in the online. Somebody did a study and found out that these hospitals you see here, their compliance rate to this checklist was as you can see on board. But my main interest is our National Referral Hospital, where all of us may be candidates to being attended one day. So we were at 10%, and we also confirmed this from a research that Kariro did in 2012, and he also found it at 10%, which is very, very low and alarming. When I came back from South Korea, I did a survey in our theaters, and the survey showed also 10%, which was very terrible. I can tell you over 10 scenarios of this. But to start with, I don't want to go to Muhimbili Hospital because that is a known story to medics in this room. You know the brain surgery and the amputation story? If you don't know, you don't know. I wanted to send you to the internet. But these were two patients, they were just sharing a name. I know Kga Diana, I know Kga Diana. One I know Kga Diana had a brain tumor. Another I know Kga Diana had, the leg was for amputation. These two patients get in theater and they were both operated on, but the one for tumor ended up with amputation. Yes. And the one for amputation ended up with brain surgery. So if you want to know how that story ended, just now go online, because I was given only 20 minutes. But I had Muhimbili Hospital doctors and nurses while in Korea, so I asked them, what really happened to these patients? Then they told me that the one who survived, the one who had an amputation, of course, survived. The one who had a tumor died. So is now on their payroll of the hospital to compensate that patient. It takes us back to the checklist. We shall see why every patient deserves safety. Every patient needs to be taken care of by me, by the surgeon, and by the anesthesia team. The knee surgery that I started with, one of my lecturers in Makerere came and she was perturbed. We were just in class. She's like, "You guys, I'm just bothered. One of my uncles was in one of the private hospital in Kampala, and instead of operating on, it was a knee surgery. Is there any orthopedic surgeon in the room? It was a knee surgery. They ended up operating on the other one. Do you know what the surgeon told the patient after the patient wakes up? Even this other knee had a problem, but did it have? I was in theater, and one of our surgeon, I found her sad in the morning, and she's a jolly one. So I'm like, "Dr. Swan, so why are you sad?" She's like, "I just lost my patient on the list." I'm like, "What? So you mean we are not going to operate?" She's like, "I lost the patient." Why? One of the health centers in Kampala operated on a mother. It could be me or you, imagine. After they left gauze in. So this mother ended up in GI wards of Mulago because probably she developed peritonitis. So she was meant to have surgery that morning. I think that was like after 3 weeks from the other health center where they left the gauze in. And then she passed on that night before the surgery. I witnessed a neuro case where the neurosurgeons, instead of opening this side of the skull, they opened on the other one. So that is the WHO surgical safety checklist. So I have already talked about this. When I did the survey from Wonju Hospital before I left, and when I came back, I did from Mulago, and these were the results. For us, we were just between 10 and 20%. For them, they were above 80% because they are doing it well and doing it better. So what is our project? What was my project objective? Next. The project objective is to reduce surgical complications and mortality, like some of them that I have mentioned, to improve patient outcome. Once you use this checklist, then you know that the outcome of this patient is going to be okay. Then also improved communication and teamwork, because the checklist involves the nurses in the room, the surgeons, and the anesthesia team. So there is a lot of collaboration between the 3 teams. So it improves the communication. Next. So this is the checklist that I've been talking about in its original version. As Mulago Hospital, when I brought this project on board, we adapted it. And next, you will see. Next, this is the adapted checklist that we did, which has the sign in, the time out, and the sign out. I always tell the people I work with that even if you sign for me just the first part, there's a lot of complications that we shall reduce by just signing in this patient. For example, the patient must confirm their identity, the site of the procedure, and the consent. Think about Muhimbili Hospital, where both people had the same names. So, just by that first question, what is your name? I know Mkshadan. What are they going to do? Because every patient that enters theater that is conscious should be able to explain, at least in layman's language, that they are going to be done. Bagenda kunsalako okugulu maybe. Or they will explain. Me, I always ask them, and they know how to explain even GI issues. So you will know by just one question that these patients who have same names, when they talk about the knee, and for you, you were thinking it is a tumor, then from there you will clarify and you will not do that mistake. And the other one of where they operated on different knee, we need to mark the sites of operation, surgeons in the room. Because had they marked the site of operation, they would never have operated on a wrong leg. So this is what we developed. But the surgical count feeds into the other checklist. So when I reached South Korea, it is not clear, but this is the version of the count which they were using. Next. So we also adapted it into this version. So this is the version that we are currently using in Mulago Hospital, which helps us look at the goals that we have started with, the sharps, the scrub nurse and the circulating nurse are supposed to do the counting 3 times at least, or every time they add any item on the operating table. Also, the instruments. So this is what we adapted from the one of Wonju Hospital. Next. So we conducted different trainings, and these are some of the presenters when we had the trainings, that is later from UCI. Next. So Kofi was able to procure for us an all-in-one desktop, a very good desktop, by the way, 4 of them. But remember, we have 16 theaters. So we are using the hard copies in the rooms. Then we take them out and feed them in these desktops that we received. That is how we are using them. So we had the official launch of the project, and by the way, the project was welcomed by the ED. She really loved the project and she supported it. That's why it had success, not just her, but the whole administration and the teams on the ground. We had to hand her over one of the t-shirts that we used in the training. And there are different in-charges in the operating theaters, so we were able also to share the other 4 desktop to them. So after completion of the project, we had to correct our data and also find out now the compliance rate of the surgical count sheet and also of the WHO surgical safety checklist. So this is our compliance rate of the, you've moved, surgical count. Yeah, the one of the surgical count was found to be at 70% of the data that was entered. Next. And the one of the surgical safety checklist, it moved from 10%, remember, to 69% by the time we completed the project. By the way, the time that were given to us was little time because we started in December, and these people wanted completion by March. So you can imagine the marathon that we went through all this. Next. So at least this is clearly telling us that from the Kariro's 10% to when I did the survey in 2014, 10%, at least by 2025, we were able to move that extra mile to 69%. And the wise man bridges the gap by laying out the path. That means, oh, let me read this again. Morgan says, the wise man bridges the gap by laying out the path by means of which he can get from where he is to where he wants to go. Next. So what is our sustainability plan. I implemented this project when I was still at school in Makerere because I was even on study leave. But when I returned in July, I said I need to dedicate more time to this project. So every time I arrive in Mulago, mostly by 7 a.m. And because it is a training institution, we have many, many students that come. You see, staffs are already trained. But every morning, in those people who have been in our theaters, they are 16 in number. Every morning, you receive over 30, 50 students. So I decided that every morning they come, because I brief them if it is their first day, that for us here, every morning from 8 to 9, I will be conducting trainings. Not just on the checklists alone, but also on other things they do not know. So that is part of the sustainability plan, because these people work in different hospitals, these people will finish and go in these other hospitals, and I know that they will take that knowledge alongside them. Mulago is planning to digitalize the whole hospital by 2026. I think they got a project from Koika, from Koika, and so, like I said, they gave us 4 desktops. So by the time they digitalize it, everything, we shall have these desktops all over in the room, because that is one of the challenges that we have with the project. Next. So these are some of the trainings I do conduct, like I was teaching them about surgical scrubbing. Next. Yeah, trainings. These are Makerere and other institutions that come in. So the challenges faced, like I told you, that we use hard copies to do this, then later transfer the data to the desktop. Sometimes we get stock out of the papers. Sometimes the hospital machines toner is out, you know. Then another issue is shortage. Sometimes the nurses will tell you that when they are alone, for example, in a room, also filling this form, then transferring it to fill the other side becomes a complication. So we urge the government to at least improve our shortage within the hospital. I've talked about the computers and the 16 rooms. Later, I found out that we could also incorporate the PACHU, that is the post-anesthesia checklist, into the same system. But because we had not planned for it, it was very hard to have it funded and be put in the same desktops. But we are still waiting for the hospital to help us through. So what the photo shows us when we were on the dissemination day, when Kofi was handing over officially the project to the hospital. So in pictorial, you can see Dr. Sekabira, who is the DED of Mulago Hospital, and the rest of the team, and a representative from Kofi. So let's go back. The lesson learned is that implementing the WHO surgical safety checklist, and it helped to improve compliance rate from 10% to 69%. And this underscores the critical importance of standardized safety protocols, enhanced communication, ongoing trainings and leadership, support in fostering a culture of patient safety, and significantly reducing surgical errors and complications. Next. So this was at dissemination day. Next. That is our ED, and the group photo there, which they had already showed you. Even that one we saw. So special thanks go to Coffee Uganda. Thank you so much. Mulago is grateful for funding this project. We want to thank Mulago Hospital also for receiving the project, the staff in theater, the IT team that helped in the implementation of this project, and the teams of trainees. Next. So that is the award that they were telling you. They were able, this activity won an award. I thought it better to show it to you, the award. Next. For God and my country. Thank you.
Thank you very much, Diana, for that wonderful presentation. You may take a seat and maybe take a few questions from the audience. And Patricia Egu, you could join, as well as Dr. Omwena. Dr. Omwena. So my first question goes to Patricia. Patricia, I think, suffered the most in developing her proposal to the point of getting the approval and funding. And I would like to know how you felt about the structural changes that were introduced and what your experience was like up until you won the project. So the question is, what was your experience and how did you feel about the structural changes that Coffee introduced in the alumni projects?
Yes, thank you, Sarah, for that question. So when we were applying for the grant, we of course got guidance from previous cohorts, and the approach that they told us wasn't what we expected to go through. So my project, seeing that I had to work with different stakeholders from the different ministries, partners, etc., I had to seek approval from the different offices. And as we all know, you just don't walk to the PS's office, you don't just walk to the DG's office. These people are busy, they are never available. So this made the project to go beyond the required time. But one support system that I could say is that when we got this project and funding, we introduced the project to our boss at the workplace, Dr. Rio. So Dr. Rio was part of the project from the inception up to the end. So he guided, he gave emotional support, he guided us on whom to work with. He actually gave us some contacts and even gave us heads up of, let me help you call that person, and you just walk there. So working with my immediate supervisor at my workstation helped us to maneuver in a smoother way than expected. So yeah, it was a challenging moment, but with support from the boss, it got a little easier. Yes, thank you.
Okay, thank you very much, Patricia. I'll take one question for Diana and one for Dr. Mwena. I want to challenge us to finish in the next 15 minutes, so let's have the questions. Do we have any?
Thank you so much. I would like to ask Patricia, in the checklist, by the way, thank you so much for bringing the One Health approach into this. This is a good way. I wanted to know, in where one is registering, you have one thing that you're picking as a country of residence. And at some point you're saying we're recommending to scale up countrywide. So I'm trying to imagine, did you mean country of residence or you meant county of residence? But maybe you had some idea there. And then I know Mugisha. I'm also Muchiga, but from East. So I easily pronounce your name. That's why I cannot miss you in the theater. So your project is a very good one. And I know you've done a lot of data you're presenting is Mulago. But believe you me, I was just telling colleagues on the table here that last week I was in Kitgum. Let me keep this short. And interacted with one of the doctors who said the mother had inguinal hernia. Okay? But when they opened, they found actually she had fibrosis. So you can imagine doing such things without proper. So for me to you is an appreciation. Thank you very much. And please scale this not only in Mulago, but even in other, especially the teaching hospitals. It would even be better because these are the people who are churning into the system that we do have. Thank you.
Thank you very much, Isaac. So I'll give it to Patricia to give us a response, while Diana, you'll also tell us about how you plan to scale this beyond Mulago.
Yes, thank you for that question. So our intended audience was strictly Uganda, but when we had our stakeholder engagement meeting, well, we got feedback from the stakeholders that we are targeting Ugandans. However, this course is going online. There are no restrictions nowadays to whether you're in another country or not. You can always access data from any other country. So that's why we broadened it out and left it open for someone to type their country where they reside. However, Uganda is the only country that has actually developed a 717 e-learning course. So the 717 Global Alliance, who is actually a Ugandan, Dr. Isa Makumbi, told us that he's going to try to market this course beyond Uganda so that other countries can actually adopt the course. So we cannot limit the usability only to only Uganda. That's why we made it open. Thank you.
Thank you very much. Scaling it beyond Mulago is very important. But like we all know, it involves a lot of costs, which at the moment we may not have. However, like I said, that my commitment is to the young people who are getting in my theaters to get to learn. These people come from different hospitals. Some of them are upgrading. Others are maybe the staffs within Mulago. But I believe that every person I train, even when they have not completed, wherever they will go, because I always tell them that wherever you will go, should you ever land in theaters, kindly bring this up, because it is simple to learn, it is simple to teach to the rest of your colleagues. And just like I always tell the staff I work with, that me, should I ever be in any of the theaters, kindly use this checklist, because I know it is very important. So my scaling it up, if it involves money, I might not have. But for the knowledge, wherever I'll be in these theaters, I will always train these youngsters to have that knowledge, go across the country as they work in different places in Uganda and abroad. Thank you.
Thank you very much, Diana. Okay, there's one question, then I'll come back to you, Benjamin.
Thank you so much, Diana. I would like to take this opportunity to introduce myself. I'm Regina Mugisa, and I work at Mulago, Specialized Women and Neonatal Hospital. And I'm looking at the surgical checklist. This is a very good innovation, but it can be scaled down to the other facilities without you actually even doing so much. Because if we leverage together with the Ministry of Health, it can be maybe integrated into the EAFIA system. This is a health information system, which we all know right now. that we are using as we are seeing our patients. So this checklist, I'm sure, can be uploaded as a new menu, and then it can be taken on there. Then the other issue is still to do with the sustainability. How can we ensure that other people, other nurses and clinicians, doctors and so on, actually take it up and they are trainers of trainers? Just look at it in a way that if you're not there or you're busy in other activities, can there be someone else who can take this on? So can there be a training of trainers whereby it's an obvious thing? Or can you even scale it out to the health institutions, the academia, so that they can also emphasize by the time the interns, senior house officers and so on come to the facilities, not only Mulago specialized, but we have also other institutions around the hill, for example, who should be also doing this. Thank you very much.
Thank you very much, Regina. I'll take one more question and then Diana, you can respond.
This is for Ms. Diana Mugisha. I had a question about that 69% of Mulago. What is preventing Mulago from reaching the Wonju scale of 80? What are those factors? If there are 3, which of those 3 can we start working on so that we really get to the top of that list? And then for Madam Achiro, I had a question, maybe some insight into, when we have Korean culture, we have Ugandan culture and African culture. So where do you find culture affecting the processes of working on these grants or working on these projects? Where do misunderstandings occur? Because you said you have those briefings, but it's important for us to understand where those cultural schisms are so that we can avoid them and it makes it smoother for other people.
Thank you very much, Dr. Lukoma, for your question. Dan, I think we can start with you.
Thank you very much, Regina. I think this was very positive to take in. I did not train alone. First of all, I had the doctors on board training, anesthesia team training, and it's because when I was given 20 minutes, I did not project all the trainers. So already there are trainers on the 3 teams, the nurses, the anesthesiologists, and then the surgeons, 2 of them. But I've taken it very positively that we can, for example, use Mulago always every week has different trainings from actually the nursing department, that we could use such opportunities to train more nurses. Myself, I went to Cancer Institute in their theaters and I did training of their staff on this checklist. So I've taken that positively, and then the EAFIA, I will take it on from there. Thank you. And then Dr. Michael, thank you so much. Why we not on 8 and above %, just like Wonju? We are taking baby steps, Dr. Michael. We are going slow, but we know that one day we shall reach there. When you look at their setup, by the way, it is quite different. You find in their operating room, they have at least 3 nurses. But what I can tell you, you find in our rooms, sometimes 1 nurse is running 2 rooms. Those who have been there, they know. One of the issues that I told you about is the shortage. So tell me how this 1 nurse who is running 2 rooms is going to go ahead and has many cases and then run this checklist. Sometimes that shortage beats us so much. I told you that another issue was that we had only 4 desktops vis-a-vis the 16 theaters. So it is double work to fill in the hard copies and also enter this data in the system. So one of the things that I noticed is that some of the data would be filled in the hard copy and then be missed to be filled in the desktop, making now the percentage stay at in 60s there. But like I told you, next year, when they scale up digitalization, we are likely to have better percentage, since each room will be having its own computer that every time you do something, you enter it at real time. So thank you so much.
Thank you very much, Diana. I also wanted to commend Regina for the recommendations and feedback provided, because once we come together, then we can learn and actually do better together. I'll take one last question from Benjamin, and then we can wrap it up.
Thank you so much. Thank you, the presenters. Thank you, Patricia. I'm looking at e-learning. My apologies, I kept on moving out. My boss was disturbing me. Have we done pilot of this e-learning platform? Then next is, how do you see its uptake? I happen to be among people who designed the e-learning for GeneXpert PT forum. And we started it around 2022, immediately after COVID, 2021, 2022. And we wanted it to, we had learned a lot from COVID because participants from outside Uganda could not come here for training. So we came up with that initiative. It's a good one, but for known reasons, people don't want to register for it. We have suffered. I don't know how you are going to handle that. Then have you incorporated mentor-mentee interaction? Like at the time you need like to practically demonstrate something. So shall we have that kind of video arrangement in that? Last one is on sustainability plan. Who is hosting it and who will be hosting, paying hosting fee for the next 5-10 years? Thank you.
Who wants to go first? Diana, Patricia, who wants to go first?
Thank you very much for those questions. Yeah, there are 4 questions and very important questions. The first one is about piloting. So my experience for these very few weeks is that people are actually interested in the 717 assessment because it's becoming a requirement for every outbreak that happens for us to do a 717 assessment, because it helps us to do that M&E so that we know how we've performed, what were the bottlenecks. I didn't go into the details of how the 717 assessment is done, but we go ahead and collect bottlenecks, we go ahead and collect enablers. So for the bottlenecks, we're able to redesign strategies to see that we curb these outbreaks early. So it's becoming a requirement. So I should say that as of, I think 2 days ago, when we checked into the system, people are actually logging in but not completing the course. So we had 3 completions and several logins but not completing the course on the back end. So the uptake, I think, will be good. I intend to do wide publicity starting next year, so that when we have any activities, we integrate this into those activities. And then 2, we have several WhatsApp platforms for our end users. So once we see that we have kickstarted properly, we intend to do wide dissemination and sharing this in the several platforms that we have for our intended users. And then about the mentor-mentee interaction, this was one of the things we thought we would have. But looking at the way our systems run, we need someone to be there to get feedback. We actually proposed this, that if someone has questions, a learner has questions, they're able to post them in the group and someone responds within a specified time period. But after several discussions, we agreed that we first pause that for now. Maybe once we've completed the upgrade and we see the dynamics, then we can maybe incorporate that at a later stage, but that one was dropped as of now. And then for the sustainability plan, as I mentioned, it's Ministry of Health hosting this. The Ministry of Health has an e-learning platform. So about who pays and everything else, I know it is government. And for now, I think we are not worried about who will pay the hosting fees and all that. Yeah, thank you, and over.
Thank you very much, Patricia. We heard in the morning from Dr. Mona about Tutata, but I was curious to know how, now that you've listened to Diana's project and the work that she has done, how it relates to emergency and the work that you do.
Yeah. The checklists are important, just like, because first of all, the surgical safety checklist, the health industry borrowed from the aviation industry. Like you have heard before, in aviation, there's practically a checklist for everything. If you are an aviation nerd like I am, you will check online and you see that, for example, if both engines goes off, so there's a checklist for that. If a bird hits the windscreen, there's a checklist for that. And I think this is very important, especially in emergency setting, because in emergency, there's very little time to think. And that's the same principle which we did with Tutata. We cut away those things which needs a lot of thought processing, because it takes a lot of time and you don't have it. So having a checklist, it is a yes or no answer. If it is yes, do this. If it is no, do this. It is very clear. So I think it plays a very big role. Now, this is very true, especially in the operating room. And when you're operating on a patient who, let's say like you're doing a damage control surgery, you are limited by time. Maybe you want to be there for only like 60 to 90 minutes. So checklist becomes very important. Thank you.
Thank you, Dr. Mwena. As we conclude, I would like to know from you as our president for the KGA, seeing the current structural changes that are happening, and now that you've gotten into leadership as our newest, what direction do you plan to take in terms of projects and the work that we're going to do with activities of the KGA?
Thank you. I joined the KGA in 2023 when I came back from Korea. And I was in Masaka before, and some of these other projects which were done in 2021, 2022, I was there. Now, during that time, call for proposals come, but you find there's only one person who have submitted this. So there was practically no competition. What has changed is that there are more people who are getting interested. And because of this, quality also keep increasing. And that's why you are seeing all these various projects coming up. And also that's why you're seeing we are winning at international level. So this, we need to keep it up going. The changes, for me, I think they were good because I was among the first people who made those kind of suggestions earlier. And I'm happy that Kofi has taken it up. In the next 2 years, what we are thinking about is mainly around two things. One is institutionalization of these projects. Now, when you look back, most of the activities that were done kind of disappeared in thin air. But now you are seeing core ministries taking it up. For example, like Tutata, even 717, as well as the surgical safety. Institutions are now beginning to own it because as individual project leads, you cannot own this like it is my personal thing. Like Tutata is not my personal thing, okay? You can be the face of it, although you cannot own it because it will not benefit you as a person. It is meant to benefit the entire population of the country. These projects are meant to save lives. So that is why in the next 2 years, we want to ensure that all our projects are institutionalized. They have clear sustainability plans. Because the first sustainability plan is if those institutions takes them up. And then we still need to go ahead and support them, especially if it is government taken. It's taken up by government. And government might be much slower because there are so many competing priorities. So like we have had yesterday, we need to involve the general public and also involve key partners like the corporation, the idea of the Tutata run. That is when it comes into place. So we have many people, we share widely, we create awareness in all the different fields, be it biomedical engineering, be it health system administration, be it laboratory, whatever. We share widely, people get interested, they will come in to support us. They will have goodwill towards our program, they'll be more receptive, and they can support us. So for example, if we manage to mobilize 50,000 people in a country, and each person give us 10,000 shillings, that one will be enough to train over 1,000 health workers into Tata. And this is something which we can do as KGA, and it is also good that we have partners like Coco, they can still join us, and we ensure our projects are out there in the public. Thank you.
Thank you very much. This has been the KGA panel led by Dr. Mwena, Miss Diana, Aina Mugisha, and AU Patricia. So we're going to have a group photo, and then we wrap up the session. It's been a pleasure moderating this session. I'll now hand back to the MC, who I don't know if is still in this room, or Beatrice, to wrap it up. Thank you very much.
All right, what a day. Thank you so much, guys, for keeping around up to this time. We are sorry that we've shot by 10 minutes, but we are going to go home now. So I would hand over the microphone to my colleague.
Good evening once again. Members, we are about 20-something in this room, but 11 people have responded to our evaluation. Kindly give us feedback so that we can improve and make it better next year. We want to find a better forum next year, okay? Kindly give us that feedback. Whether positive or negative, we shall take it in good faith. Thank you. It's room for improvement.
All right, so at this juncture, I would like to make an announcement. One is an apology that you will not be able to get the facilitation today, but everything will be, we shall package everything for tomorrow because of some logistical issues around timing and all that. But tomorrow, we shall have things ready for you. So take heart and let's come back tomorrow with the same attitude, with the same spirit like we've had from yesterday, today, and let's take it to tomorrow. I'm so grateful for today that we've been able to achieve our milestones for this day, and I pray that we shall be able to do the same tomorrow. My kind request to you is that let's keep time. Today we started a bit late. We started at 9 because we didn't have quorum, and we pray that tomorrow we are able to come in time. Let's plan. Tomorrow is a bit short because it's a Friday and there are other competing activities. So let's be here on time, and we shall also try to keep time and make sure that the program ends as early as possible so we can go for the end of year party, something like that. All right. So thank you so much for today. I am so blessed that you came. I pray that as you go, may you go home safely. All right. Thank you.
And lastly, members, this to empower you, or all of us, one of the parameters we performed badly was time management. Tomorrow being the last day, and being a Friday, we would have wished that we leave this space by 2. We stop at lunchtime, we have our lunch, and then we stop at 1 p.m., we go for lunch, and that's it. But majority of us are reporting late in the morning, and that's why we are kind of having these sessions go till late. So please, let's make